cheek, cheek.
Sweet memories keep haunting me, and deep in my soul, I know you are mine, and my heart belongs to you.
Dr. Vijay Mohan Prasad, Chairman of VGM Foundation, for this initiative.
Sweet memories keep haunting me, and deep in my soul, I know you are mine, and my heart belongs to you. And deep in my soul, I know you're mine, and my heart belongs to
Dr. V.G. Mohan Prasad, Chairman of VGM Foundation, for this initiative.
Sweet memories keep haunting me, and deep in my soul, I know you're mine, and my heart belongs to sweet memories keep haunting me, and
Sir, you are on live, sir. Sir, please hold on, sir. Just a minute, sir. Sir, your mic on, sir.
Yeah. Good morning, friends. I deem it a great honor and privilege to stand before you at the inauguration of the Gastro Update 2023, the live endoscopy workshop that's not only going to be viewed in India, but also the MENA countries, Southeast Asia, and some of the viewers from Europe and US. So I'm really happy that this endoscopy workshop will impart knowledge and wisdom and fine tuning for all those who are dedicating themselves to the field of therapeutic endoscopy. We have fantastic cases lined up here today, and the demonstrators are great demonstrators who have done demonstrations across the globe in multiple countries. We have an array of patients and different types of cases lined up for you to give a variety of presentation of all therapeutic endoscopic procedures. And I'm very, very happy to introduce my mentor, my philosopher, my guide, and a person who's like God to me, Sri Padmashri, Professor Dr. K.R. Padanisamy, who's one of the senior most gastroenterologists of this country, to deliver his introductory remarks. Sir.
Good morning, everybody. I am very happy to be here. I would like to thank Dr. Mohan Prasad for having given me the opportunity to talk to you all today. And I would like to briefly share my experience of the evolution of this endoscopy in our country. Like I started my career in early 80s as a gastroenterologist, and in 1981. Those days, of course, we have had only fiber optic endoscopes. We were doing only a diagnostic endoscopes. And 1985, when we held this annual conference of gastroenterology in Chennai, first time the video endoscope was displayed. And then 1986, when I started traveling, those days we did not have any sort of a structured training. We have to travel overseas to centers to just observe and then learn ourselves. 1986 started traveling. At that time when I visited NIP Sohendra, at that time even Dr. Sohendra was doing with the fiber optic endoscope. And later, the next I visited Dr. Peter Cotton, then he was in London Middlesex Hospital. And then he started at that time itself video endoscope with all live transmission to the auditoria. A lot of trainees were there. Then later when I talked to Nip Sogendra, why sort of he is not moved to video. At that time he said he was not comfortable with the video system. So now of course everybody moved forward. And from the diagnostics, of course, all over the world, they have moved forward to the therapeutics. In India also, like the ERCP and various other therapeutic endoscopy procedures. And US, I would like to share my views on US. US in our country was propelled forward by two world stalwarts like Shyam Varadarajulu and Robert Haas. I think they have traveled extensively in our country, not only in corporate hospitals, in the government setup also. And they are responsible for what US today for diagnostic and therapeutics. And without wasting much of course, now we have a lot of other advances like the dead space endoscopy, POEM, and so many things. And I think you're going to have a lot of, no, you're going to view a lot of interesting procedures, therapeutic procedures. With this, I would like to share my personal view on regarding Dr. Mohan Prasad. Mohan Prasad is a great friend of mine, and known to me from his student days. And he used to work with our teacher, that is Dr. Madan Gopalan. He was a pet student of Professor N. Madan Gopalan. And Dr. Mohan Prasad has conducted such several conferences, endoscopy workshops of national, international repute. And also, I would like to share with you, he is a multitasking personality, and he is a great orator, not only in English, Tamil, and no, he is a great singer. And Dr. Mohan Prasad is humble, hospitable, and humorous. With this, I would like to wish the endoscopy workshop a great success. Thank you.
Thank you very much, sir, for those lovely words.
Yes. So, what are we going to do today? First will be a lecture by Professor Dr. Malay Sharma. He'll introduce endo ultrasound to you. And after that, we move on to the live sessions. There are beautiful lectures coming up. Mark Knorr from United States will also give you an intro on the electrogastrography in dysmotility disorders. We are also going to demonstrate a case here. So as the day progresses, so we will move on to the yeah. So, and Malay Sharma ji is going to speak now. Before that, we have something very auspicious, very nice, that it's a great blessing to this Gastro Update 2023. So, and I would like to tell you that the physical conference will be held in November, probably first week of November. So please be there at Coimbatore to enjoy the salubrious climate and also to have fun learning, and it'll be really amazing, my friends. So all of you should come to Coimbatore in November 2023 for the physical conference, the 2-day conference that happens in the weekend on Saturday, Sunday. So to bless the whole program, we have none other than the revered Guru Maharaj, Sadhguruji from Isha Yoga. Let us listen to him before we start this program proper. Thank you.
Namaskaram. My best wishes and blessings to all of you who are participating in this national conference of gastroenterology, endoscopy and liver diseases. And my special congratulations to Dr. V.G. Mohan Prasad for putting a conference together like this. And I'm especially greatly inspired by a medical conference taking interest in the Safe Soil movement, and this is very relevant and apt because you cannot address human health without addressing the health of the soil out of which we are made. As all of you definitely know that human health and nourishment and nutritional values are absolutely intimately involved. And to fulfill that, it's very important the soil is rich. Without rich soil, there is no rich food. Without rich food, there is no rich life. And health is definitely not in our perspective if our nutritional aspect is not taken care of, and there is no way to do that without enriching the soil richness. And unfortunately, soil has fallen upon bad times in the last few decades, that we are moving towards desertification, and soil extinction is what the UN scientists are talking about. In the next 50 to 60 years, we can move towards soil extinction because the agricultural soil that is present on the soil right now has become so weak without the necessary organic content, and in turn microbial life is being decimated. Microbial life is the foundational life for who we are. As doctors, all of you know the significance of what the microbial life is doing within our own systems Similarly, in the soil, trillions of life forms are working constantly to keep the life on this planet up. And fortunately, we have moved it in a direction through very industrialized approach to agriculture. Instead of nurturing the soil, we have exploited the soil in such a way that in many ways, in next 2 to 3 decades, we could be facing severe food shortages on the planet. So it is time to revive this, and once again my congratulations to all of you for taking interest in Save Soil movement. This is definitely the culmination that the medical professionals take interest not only in the health of human beings, but in the health of the planet. This is very, very promising, and this is the real success of Save Soil movement. Let's make it happen, save soil.
Sir, your mic on, sir.
I welcome Dr. Malay Sharma, who's here to deliver his talk. So we'll go ahead with Dr. Malay's lecture first, and then also we can go ahead. Malay, would you like to speak first? So
Sir, please unmute your mic, sir.
please unmute your mic, Malay.
Or mic unmuted. Yes, sir. Yes, sir.
Yeah. Dr. Malay Sharma is a senior gastroenterologist and a great endo trainer. He is in Meerut in Uttar Pradesh, doing annual courses of training, and also even apart from that imparting lot of endoscopic therapeutic training all through his life. So he is a go-getter and a world-renowned person in endo ultrasound, and so I'm happy he is here. Malay, would you like to wait for a few minutes, 10 minutes, so that I can finish a very quick case of cervical esophageal inoperable malignancy for stenting? That's what we're going to show now. So as Malay waits on, we'll just continue with our case. Can I have the case details on the screen, please? Yeah, Mr. R, who is 55 years old, presented with dysphagia of 2 months duration, and endoscopy showed ulceroproliferative growth at 20 centimeters with a tracheoesophageal fistula, and dilatation and Rayleigh tube insertion was done elsewhere. All this was done outside, and the CT neck shows a growth in the upper thoracic esophagus with circumferential wall thickening with the tracheoesophageal fistula formation. So the plan is to deploy FC SEMS, a fully covered SEM stent that can cover the tracheoesophageal fistula. So The alternative is to use a partially covered stent, and the covered portion of the stent can block the tracheoesophageal fistula. One problem that we have to face is the cricopharynx is at 15 centimeters and the growth starts at 20 centimeters. And what we should remember, if we deploy self-expansible metallic stents way up, very close to the crico, there are two problems. One, the stent flare can go and compress the larynx, and the patients can choke because of asphyxia. The other problem is the stent upward migration further can produce a globus sensation which the patients can never tolerate. They keep on coughing and they want the stent to be out. So these are problems that we always face with these sort of high up stents, the so-called cervical stents. So we need a stent which has got a smaller flare, and we need to deploy just 2 centimeter above the upper margin of this growth. This patient has been referred from elsewhere, and I am yet to do an endoscopy on him, but I'm going to demonstrate now. So let us see. So this patient I've never endoscoped earlier, but we'll try do it online. Then you will understand the difficulties where you and I go through. We also have a C-arm ready here. We are using the Allinger's C-arm, which is the DigiScan, which is the latest with a 1K into 1K camera, and we're going to show the images and the fluoro using the Allinger's DigiScan. So let me first start with the endoscopy on this patient just to check what is happening, and then we will proceed further. So as you are going through the oropharynx, please ensure that you suck out all the fluids which are there. Looks like there is a purulent fluid coming out of this. Might be coming out from the trachea. So let us see. Now I'm just entering gently into the cricopharynx. Yeah, there I can see. There seems to be some growth here also. So it's at least fleshy, so let us see if it just crossed. No, we just crossed it. Okay. The thick mucus produces a plug here. I'm just trying to put in water. We are using carbon dioxide insufflation. So, can we have some water pump switched on properly? So, water is not flowing well. Yeah, now it is better. Now we're getting water. So it is always mandatory that you check for the water, and the air before we move in. Yeah, there is almost a near total block here. So this is we are at, now we are at 20 centimeters from the, bite guard, from the incisors. So I'm just pulling back just to see. That is a false passage. Just hold the scope, please. Here, hold the scope. Yes. So the passage is here. Can you see that? Okay. So that is all the growth over there. So I'm just trying to gently, cross. So what I'll do is I'll never give a linear force. I'll just gently torque the scope and try to see if I can cross. But I think I find it difficult to cross here. So I will not cross this area. So what I'll do is, see the traumatic ooze of blood from the growth, because a very friable malignant growth. So I'm just going to, put a guide wire there. But I just have to, before I put in a guide wire and, get in deeper, see the amount of friability of this growth. So what I'll do now is to check what is this level. So this level is almost like 17 centimeters. So 17 centimeters, and the crico cuts very close here. So I will ask my mentor, Dr. K.R. Panisamy, who is a veteran leader in the field of endoscopy.
Do any contrast study to know the extent of the lesion?
Of course, of course. Of course, we should do that. And also what we can do is, a CT has been done earlier.
Done earlier, okay.
CT has been done earlier. This is from the government hospital.
Okay.
The patient has come from GH. So the CT had been done earlier, as I showed in the patient data. So yeah, correct. Post-cricoid area, that's what I'm assessing. Probably this tumor has invaded the submucosally, and proximally it is involving the cricopharyngeal area. Now at least the field is clear now. So from here we'll reassess. This is the upper margin of the tumor. I'm at 18 centimeters. 18 centimeters, and the fistula is also over there. And then I'm just gently wriggling the scope backwards, and there is some compression here, this area. Can I have some water, please? Just hold here. Yeah. So we have an additional water irrigation port. So I'm just trying to clear this area. Podum. Stop. Stop. So I'm just reassessing, because very, very important to reassess whether a patient is eligible for a procedure or not. So now this area, what do you think, sir? This looks like a submucosal invasion to you? Looks like a, yeah. But still, the scope, I mean, stent can be passed here. It's not a problem. And we need to assess where the crico is. This is almost, we are at the cricopharyngeal region. So here again, you know, the involvement is there probably. See, this tissue looks unhealthy to me here. And we just see the larynx and the laryngopharynx. Yeah, that is the laryngopharynx here. See, very close to this thing, but still the tracheoesophageal fistula has to be close. For what it's worth, I think definitely this patient can have a stent. We can deploy what is called a cervical stent, which has a small flare. I'm going to show you. This comes from the innovative therapeutics. It's a Taiwung stent, right? Can we show the stent? I'll just take out the endoscope briefly and then show you the stent and then go back in. Water varmating channel. Water. Just check. Hold this. Can I have the stent? Oh, okay, sorry. Yeah. So this is the Niti S Taiwung stent. So this is, can you open this? Can you open this? Take it off from here. Take it off. Yeah. Okay. So this is of 10 centimeters length, and see that. Okay. This is a esophageal covered stent. And is it a fully covered stent? It's a fully covered. It's an FC SEM stent. So that is the you have the markers there, which are radio opaque. So there's no problem. Now we can go ahead with this stent. So I'm going to reintroduce the endoscope, and then pass the guide wire under fluoroscopy guide, and then we'll try to introduce this stent. Jelly. Hold the scope. Infuse some water, please. Water. Konjama. Yeah, that'll do. Yes. So now we'll have to see where the tumor is and which is the passage. So, yeah, there we go, down there. At, you know, yeah, put some water please again. Water, water. Yes, yes, yes. That's fine, that's fine. Okay, there we go. I can see the opening there. And now, what wire you're going to give me? Kannan is an able endoscopy nurse, one of our senior most. Sir, we are using dream wire now. Previously, we used to use stiff guide wires, but I'm going to use a cannula and then pass the, we can use the guide wire, but we are using a Visiglide, Visiglide guide wire. So sometimes, it just coils because of the hydrophilic tip. We're not using a stiff guide wire. Sometimes the stiff guide wires go and poke themselves in the tissue and can get stuck. So, yeah, see, can you put some water here? And see, I saw this opening here, somewhere here down there. Yeah, that is where we have to go. So we'll just focus it. I can just by rotating the scope and the body, we can align ourselves to this position. So now I'm a little deep inside. So now I'll ask my assistant to pass a guide wire and then check under fluoro. Yes, can we have fluoro? And you can have a fluoro image also coming up on the screen, please. Yeah. So can you, yeah, can't see. Can you move the monitor a little bit this side? Yes, yeah, okay. Yeah. Or move it this side. Move it this side so that we can see. So, yeah, okay. So, move, more. More. Yeah, more. Yeah, that's fine, that's fine. So, can you pass the guide wire? So, now we'll have to cross the diaphragm. Screen, keep screening. Keep screening. Now, the guide wire has to cross the diaphragm. Stay there. Screening, please. No. Previous image was better, pa. Show the diaphragm. Yeah, be there. Screen again, keep screening, pass the guide wire. Now we'll have to see the guide wire crossing the, reduce the brightness. Yeah, can you pass the guide wire? Yeah. Has it crossed or no? No, it's just coming in. Yeah, now you can see the guide wire coming in. So, yeah, now we have passed a guide wire there. Okay, fine. So, what we'll do also is to pass the, cannula over the guide wire, and I'll just put in some contrast. So, have some contrast ready just to check what is the lower extent of this tumor, because we did not cross this tumor. The other trick that you can do is you can use a 5mm scope where we can cross the tumor with a 5mm scope over the wire, or 6mm scope also can be used over the wire to see the lower extent of this tumor. But here I'm not planning to use the scope. We have the scope, so we'll demonstrate for some other cases. Put some water here, put some water outside. So we have a separate water irrigation port. So can you show this water irrigation port here? Cameraman, please to show the water irrigation port here. See this. This is an additional water irrigation port which just cleans up the whole thing. So you don't need to use your channel to pump in water. Enough please. Okay. So now, so contrast ready? Okay. So now can you just screen? Go up please. Move the camera up to bring to the thorax from the neck. You'll have to come from the neck. Yeah, okay, there we are. So, yeah, we will start infusing some contrast now. So, just to see whether the tumor is below or above. Can you show the tip of the black tip? No, not the endoscope. The catheter cannula tip. Yeah, just stay there. Okay. Yeah. Okay. Now I'll keep pulling back gently. Keep the wire inside. Pull as I'm pulling back. The wire should be passed inside. Yeah. Okay. So, yeah. Okay. Now, I'll just also take a measure of this layer level. Can you pass contrast again. Can you pass contrast? Yeah. Push in contrast, push in contrast, push in contrast, push in contrast, more. Okay, so it's a very short segment growth. See that? Now you can see the whole column of esophagus lighting up there. Even though the volume of contrast injected is not much, so I wouldn't expect the whole esophagus to appear. But nevertheless, the column of contrast that is seen below the tumor, it is not does not show any irregularity of margins. So I'll just push up my tip here of the catheter cannula. See, I'm very close here. You can see endoscopy view. You can see the tip of the cannula is very close here. See, this is where we are. So I'll show you. Yeah, this is where we are. That is a tip. So we are almost here, and then I'll just pass a few centimeters inside. And can you show now fluoro? Show from the neck. Show from the neck. See, I'm just showing that is the tip of the cannula. You can see there, just outside the scope we are. So that is where the tumor is. So keep fluoro on. Screening. Yeah, inject some contrast there. Inject contrast. Inject. Yeah. See, that is a narrowed segment. You can see that? Right. So, and that is the area. So I would have expected some contrast to spill into trachea, but it's not going through. Probably, this is up on top. In some other angle, we are down there. Probably that is the reason we are not able to, because we have bypassed that growth area and gone down. So the tracheoesophageal fistula has been demonstrated on CT scan. So if the contrast had exuded into the trachea, the bronchial tree, patient would have started coughing also violently. Patient is comfortable, which means the fistula is not here, probably up there. So on the other quadrant. Okay. Now this, I know that it's a very short, about 2 centimeter is the length of this tumor. So I'm very happy to deploy a 10 centimeter stent. So what we'll do now, so we'll just move up my endoscope tip, and I'll just put an external marker. So we can do two things. One is to inject contrast here, like lipoidol, which is radio opaque. The other is to put an external marker. So we don't like to inject contrast unless it is a very difficult, very complex case. Just hold the scope, please. Hold the scope there. Yeah. So this is the upper margin of the tumor. So this is the max. And after that, there is no more tumor here. So I'll put my first marker here. Put an external marker here, please. This place. Okay, here. Yeah. That is the upper margin. Yeah. It's high up in the neck. The tip of the endoscope and the external marker should coincide. Can you take your hand, ma? Please leave it there. Take off your hand. Take off your hand. Yeah. Can you screen? Yeah. It's exactly opposite the tip of the endoscope. Okay. We have put an external marker. So I'm again rechecking the dimension of the scope where it is. It is at 18 centimeters from the incisors. So I'm going to come back up. I'm going to come back up, and I want to know where the crico exactly is. So this is the narrowed area, probably that is the beginning of the cricopharynx. So yeah, this is probably the crico. So where, yeah, it is almost at 15 centimeters. So I'm going to deploy the stent very, very close to the tumor. I will not deploy above. So the flare starts 2 centimeter above the stent, no, upper margin, right? Yeah, okay. So now what we'll do, we'll just hold the scope, please. I'm just going to remove the cannula, keep passing the guide wire. So I don't need to put in a marker here because I'm going to watch the stent as it gets deployed. It's a distal release stent, right? It's a distal release stent. So we can always, adjust it as we are deploying under vision. So the upper marker is not required, only the tumor margin I want to see where it is. So that is why I just checked how far it is from crico. So that is why we don't even need a marker to be placed here because we're going to deploy the stent under vision. And this is a nitinol stent from, put some little water in the external irrigation port, just put some little water. Little water, very little, very little, very little. Yeah, that's fine, that's fine. To clear the lens. So, yeah, put some more water to clear the lens more. Yeah, put some water. Okay, okay, fine. So I'm keeping the insufflation minimal. It's carbon dioxide only, so there's no problem. So one advantage is, that it will prevent the bloating, because if you deliver so much air and you're not going to get into the stomach to aspirate the air, patient can have a lot of discomfort and pain and needs more sedation. The patient has been given only propofol sedation. We are not, given general anesthesia here. As I'm withdrawing my, cannula, my assistant is passing the guide wire inside. Yeah, keep passing. I'm pulling out my cannula. No, there should be no movement. So it should be faster. So I'm just slowly watching. See, this zebra lining was something phenomenal which came years ago. When we started, there was no zebra marking. And, like 1987 when I started doing my endoscopy and stenting. Yeah, yeah. Now the wire is completely gone. So completely swallowed. So okay, I'm pulling back the guide wire because too much of guide wire had gone into the stomach. So I'm just pulling back. So yeah, yeah. Okay. So the guide wire got swallowed inside the cannula, so we had to do this. But anyway, I'll just do a check under fluoro whether the guide wire is below the diaphragm. You'll have to move down now. Just check whether the guide wire is in place, has crossed the diaphragm. Move, more, more, back. Yeah. Fine. Fair enough. Now come back to the neck position. Maintain the fluoro from the external marker. Yeah, that is the tip of the endoscope. Fine, perfect. Just little more you can move so that you can keep this portion the center of the screen. Yeah, little bit to this side. Show the tip of the endoscope also. No. Opposite. Yeah, that's fine. Be there. So that we can just start introducing the stent. Okay. So this is the nitinol alloy, is a soft alloy, and so it doesn't work like the stainless steel which we used to use those days, 30 years back or 20 years back. Now no more stainless steel. Yeah. Can you just load it? Now we have Mr. Vignesh, who is a senior technician from ITPL, helping us loading the stent. So the cameraman can show the loading of the stent here. So let's put some jelly on the tip of the, yeah. So it is a OTW stent and not it is not a TTS, it's not through the scope. So it's just removing the scope, maintaining the guide wire. We'll again recheck, side by side we'll go with the endoscope and recheck. Okay, so somebody has to hold the guide wire in place so that doesn't migrate, right? Okay. Yeah. So how many markers do you have here? I'll just put some jelly here, please. Put some jelly. Jelly. So the stent has got 3 radiopaque markers and one endoscopy marker. So I'm just gently pushing the stent through. Yeah. So we should always watch if there is a resistance. Can you screen, please? There is no resistance here. See, the scope is freely passed in. So you can see the distal marker, this is a middle marker, and then you have the proximal marker there. So you can see the three markers there. So this is, the first marker is beyond the construed stent, and the middle marker you can see here, and the proximal marker, the distal marker is beyond, and proximal marker is also beyond the stent. Okay. Now, I'll position this, stent just very close to the external marker. Now show the, move the radiographer, please move the scope. See, I need to see the external marker there. So I'm just going to come back up a little bit more. You have to move up more, move up, show up more, yeah, up more, yeah. Perfect, perfect. See that? Now the small flare of the cervical stent is above the external marker, and now this, we said it is a very short 2 centimeter uh, 2 centimeter stricture, malignant stricture. So we will start maintaining it here, and can you just reduce the zoom so that we can see the whole place. Otherwise you can move below first. We'll just start the distal release and then we'll pull it up. Show the bottom of the stent. Show the bottom of the stent, please. Show the bottom of the stent. Yeah, little more of the bottom of the stent. If you can unzoom, it's nothing like it. Yeah, there. Yeah, okay, great. So, yeah, you want me to go side by side? No, first we'll start deploying here and then we'll pass the scope side. Okay, sure. Okay, we are going with the scope side by side. I'm just sucking out the throat. Yeah, I'll just stay here. Please hold the scope here, please. Okay, okay. Now, we're going to deploy the stent here. Yeah, that is a yellow marker, which is the end of the stent. So so we need to position it wherever we want, so that we just push the stent assembly system inside, more inside. Okay, just stay on there. Yes, perfect. You can see the tip of the tumor tissue there. So what is this level? We are at 18 now. I think that should be perfect. See that? We saw that. Where is the external marker? Can you show the external marker now? Up on top. Marker on top. Okay. You can, yeah. No. Show. Yeah, perfect. Okay. Now, external marker, you can see the yellow indicator is here. That is the end of the stent. As we are deploying, we keep watching the yellow indicator. So, now, you can show from the distal end the release. Yeah, okay, great. Now you can start deploying. We'll ask Vamshi to deploy the stent. Dr. Vamshi Murthy is a budding gastroenterologist doing all third space procedures. We're going to give him an LKG stuff of releasing the stent. So, he's already budded bloomed gastroenterologist. Okay, if you want to, Dr. KRP is objecting to a budding gastroenterologist, already a bloomed gastroenterologist who does a lot of third space procedures. And see, is deploying the stent now fluoro just to see the distal release. The stent has started opening up very well. Yeah, you can keep deploying, keep moving as the stent opens, keep moving. Yeah, we need to focus on the yellow marker. It has just gone up a little bit. Just hold the scope here, please. I'll keep focusing on the yellow marker. We'll keep the stent assembly system little more inside and keep deploying. Yeah, keep deploying very slowly. The deployment, yeah, very slowly. Yeah, keep deploying. Yes. Put some water on the lens, please. Just little bit of water on to clean the lens. Yeah, okay, fine. Yeah. It's been delivered very well above the tumor. So now bringing out the obturator, we need to follow the guide wire assembly. Show the fluoro, please. Yeah, the obturator is coming. Now slowly. Yes. Okay, great. Okay, okay. Yeah, the guide wire and the whole assembly is out now. So that is the stent which has been deployed. So it'll take time to open up a little bit more so that, we don't need to try to go in now. Put some little water here. Yeah, that's fine. So this is how much centimeter now. Exactly at 18 centimeter we have deployed, and then we have 2 more centimeters before cricopharynx comes in. So definitely the patient will have a relief from the tracheoesophageal fistula. That, right. Uh, where there is a tumor which is very close to the cricopharynx, so we cannot use a large flare stent, and it has to be a soft stent with a small flare, and it has to be a covered stent so that it just protects the whole place, and the tumor ingrowth also is prevented. So this is a very soft stent, very beautiful stent. The first cervical stent that I deployed was probably almost like 15 years back or something. So we've been using this stent, a very, very nice stents from Taiwan, very soft. So it doesn't produce any discomfort or pain to the patient, even on expansion. So we have helped this patient overcome the tracheoesophageal fistula. We have put in a covered stent. It's unlikely that stent will migrate, because if it is a benign fistula tract, there's no scaffolding, then there are high chances that the stent might migrate. Then you'll have to fix with a Ovisco clip fixator, or previously we used to use all the metallic clips, flimsy clips, but they used to hold on to the mucosa and fall off. Again, prevent the stent migration. But now with the availability of Ovisco stent fixer, we can just deploy the Ovisco stent fixer that will keep it in place. So even if you are having a tracheoesophageal fistula, which is of benign etiology, and there is no malignant tissue to scaffold and hold the stent, you can use an Ovisco stent fixer. So it will stay in place. So it's a very soft, beautiful stent. So with double covering, so with silicone and also PTFE. So double covering, right? Or single covering? Silicone outside. PTFE is also there, but silicon is better. So we have deployed this. And thank you so much.
Congratulations. Okay, very good demonstration.
Thank you. It was, see, I had so many challenges here. One, we were getting ready for Dr. Malai's lecture, but there was a little, he is there, there was a little time gap. And so I just started off with this procedure. We had never done an endoscopy on this patient because the patient was referred to us only this morning. So anyway, we could demonstrate a beautiful, stent placement here. I thank God and thank my mentor, Professor K.R. Panisamy, for guiding me. Dr. Vamshi Murthy, our previously budding, now bloomed therapeutic endoscopist, for assisting me. So thank you so much. And Malaiji, thanks for holding on. And over to you for delivering your talk on endo ultrasound.
Malay sir, you are on.
I had not even seen the stent. I had not even done endoscopy. Water varla. Water channel. Water var.
Yes sir.
There's no water coming out of the channel. Beginning lende varla. I had to manage with.
Yes sir, make it slide show sir.
Want me to start?
Yes sir.
Can I start now?
Yes sir, go ahead.
So the tips and tricks in performing a successful cystogastrophy, and this topic will be discussed in 7 headings. We have to define what is pancreatic fluid, how does the pancreatic fluid spread, and once it spreads and creates the pseudocyst, what are our options? What are the indications of cystogastrophy? What do you do before? What do you during? And what do you do after the cystogastrophy? So the definition of pancreatic fluid is that if it is less than 4 weeks or it is more than 4 weeks. If it is more than 4 weeks, there will be a fibrous wall. I think there is some noise around here. Somebody is speaking. Can you have some other mic on? Okay. If it is more than 4 weeks or less than 4 weeks. If it is less than 4 weeks, clear fluid or necrotic fluid. And again, more than 4 weeks, a clear fluid or a necrotic fluid. If it is more than 4 weeks, less than 40% is called liquid wall of necrosis, and more than 40% is called solid wall of necrosis. But the pancreatic fluid spreads, and the spread is into the retroperitoneal, subperitoneal, and peritoneal spaces. The story of pancreatitis begins from retroperitoneum. Initially, the fluid lies posterior to parietal peritoneum, from where it can spread into anterior pararenal, perirenal, and posterior pararenal space. But the fluid from pancreatitis spreads along the celiac artery and superior mesenteric artery into the subperitoneum. And embryologically, it tracks along the mesentery, and this tracking into subperitoneum, also known as ligaments. And the spread of fluid again follows the principles of embryology, and though it happens laterally, but more often it goes from posterior to anterior along the linorenal ligament, gastrosplenic ligament of dorsal mesogastrium, then the gastrohepatic ligament, and least often into the falciform ligament if the pancreatitis is very severe. The third part of spread of pancreatic fluid is into the lesser sac, to parietal peritoneum, or the greater sac from the tail of pancreas, which is an intrapancreatic part of the pancreas. So the peritoneal fluid is spreading into the greater sac and lesser sac. And the lesser sac has a superior and inferior part, which are separated by the left gastric artery and the hepatic artery. This is the superior part and inferior part. This is important because sometimes when we do EU, we can find this collection, and this appears very close, superior recess. Then from the superior recess, there is a communication into inferior recess of lesser sac, and lastly, it goes close to the spleen, the splenic recess. And all the three recesses are very well seen on CT as superior recess, as inferior recess, and as splenic recess. So the peritoneal cavity has a greater and later sac. In effect, the pancreatic fluid is spreading into two drainable areas. One is the gastrosplenic, gastrocolic ligament, and second is the lesser sac. Most often, it is the lesser sac collection, which we generally say that this is ligament or this is a pseudocyst, but most often, most of the collection, in my experience, 70 to 80% time, are lesser sac collections. And hence the options of management are surgery, radiology, and gastroenterology. And we have to see in this case, it appears as a classical pseudocyst between the stomach and liver, but as you trace it down, this has got a wall, and this is lying now posterior to stomach, and this is a lesser sac collection. The indications of cystogastrostomy when we see are symptomatic pancreatic fluid collection with coliar, infection, obstruction, or pain for more than 4 weeks. And then we start checking on what to do, our checklist of cystogastrostomy. where we do check the cyst wall, thin or thick, less than 1 centimeter, more than 1 centimeter. Is there a vessel in the wall? What are the contents of the cyst? What is the character of the cyst? Whether it is septic or only symptomatic cyst because of obstruction. And we start preparing our assessment and deciding to do cystogastrostomy, where we have to have a linear US scope, mandatory to have CO2. Fluoroscopy may or may not be required if you are using axios and electrosurgical unit. And depending on what stent you are going to use, the standard definite needle, guide wire, dilator, balloon. So the first thing that we are going to use is a 19 gauge needle. When we're talking about the needle, I want to discuss 5 aspects that you have to select the puncture site, learn how to take the needle out of the scope, select the puncture angle, avoid puncture through the diaphragm, and understand the artifacts of needle. For selecting the puncture site, we have to find the area of maximum convexity. So when we are moving our scope clockwise, anti-clockwise, in, out, we have to find the point of maximum bulge. And then we have to consider whether we are moving in and out, just beyond bulge, at bulge, or just before the bulge. We have to take the needle out of the scope, which is not always an easy job, because if you are not careful, the needle will go through the scope. So taking the needle out of the scope, once you have identified the best position of the scope, you have to ask your assistant to fix the scope so that it neither moves in or out, left or right. It is not even allowed to start. And it is in this position that you move the down knob down. And you hold it down with the ring finger, so that if a resistance is encountered while passing in the needle, you see it. You will lose the US view, but do not worry about losing the view. Now that the needle is out, you check that the needle is out by endoscopic vision, by feel of the needle while it was passing out of the scope, and by EUS on EUS. And you can move the elevator up and down. Later on, after getting contact with the tissue, to see whether the needle is out of the scope or not. So the needle is out, but the needle has to puncture now. So you have fixed the scope, you have fixed the needle, and now you move the up knob fully up, back again, so that you regain the view and proceed with the puncture. But just before puncturing, you have to adjust the angle, because transmission of power is angle dependent. And if you are using maximum up deflection and maximum use of elevator, yes? So I'm on now. I think I'm on now. Maybe
Yes, sir. Go ahead, sir.
am I on? Sorry. Yeah. So I thought there was some. So I thought there was something. Okay. So the transmission of power is angle dependent, and you have to use that elevator, and you have to settle down for 90 degrees rather than for 60 degrees. You have to avoid puncture through the diaphragm. And you have to understand that this is the image where you're seeing the diaphragm. And why did it happen? Because there was collection in the superior recess, and somebody decided to puncture this collection in the superior recess, and this puncture was done just below G junction. How to avoid diaphragm? You identify the celiac artery at around T12 vertebra. And once you have identified the celiac artery, you are imaging from G junction. All you have to do is push a little bit down. You will be able to identify the celiac artery, and then you rotate. If you are below crux of diaphragm, then you rotate whichever way. You will always be safe. And you understand the artifact of the needle, because these are the reverberating artifact of needle. This is the missing part of needle, and last is the tip of the needle. And once you push it in, you will see that the needle is divided into three parts. Sometimes you may be worried what is happening inside, but this is the way the needle looks when it goes inside a cyst. And you see ghost image, multiple ghost image of the tip of the needle because of the contrast. And these ghost image are grating lobe artifacts. The second thing you have to do is pass in a guide wire. And sometimes you have to use multiple guide wire. So you have to make two loops of guide wire within a cyst. And before making two loops, second loop, you have to pass in a 10 French stone or 10 French pusher tube. Pass in a guide wire, it is pass, make a loop, and then once you pass in a guide wire, you are worried about this hypoxic area, but the sound waves are not allowing to go through. Then comes the cystotome. Your initial puncture decides the power transfer, which is maximum at 90-degree angle. Cystotome, cannula, or Coimbra dilator can be used. So you have to rule out the presence of a vessel, push the cystotome out, check the tip on fluoroscopy, keep the cystotome a bit away from the wall, apply current and synchronize the advancement of cystotome. You will feel as if you are entering into the cyst, and you will see the echogenic turbulence as soon as the cystotome enters into the cyst. Dilate with a balloon, and once you have dilated, decide to place the stent, which are this: place a stent, single stent, multiple stent. But your job is not yet done. You have to follow up. And you have to follow up for complications which are seen in 5 to 16% of patients. And bleeding due to pseudoaneurysm or a wall vessel or collateral is one of the most common complications. You have to be careful because there may be blood in the wall of the cyst, and you have to be select. And in this case, there was bleeding when there was puncture of the wall of the cyst. There were several methods available when the bleeding happened, but just tamponade by the tip of the scope decreased the amount of blood to each systole. The second complication is infection because of the increased frequency and common after drainage of fluid and large necrotic component. If you are able to establish an associated drain, then the incidence is less than 5%. Then there is walled off necrosis. You have to clear by rat tooth. And if you see the granulated cavity, this is okay. And even this should be okay when you see necrotic tissue only in the wall. The complication of perforation happens due to guide wire manipulation, balloon dilatation, misplacing stent, repositioning stent. And it happens because there is border, there is puncture at the border and the balloon got deflected. And the balloon went outside the wall. And if it is lamps or nagi, we can use for perforation. In this particular case, because we had placed the stent, plastic stent, we were not worried. So stent misplacement and stent migration can happen. Stent can remain within the lumen into the cyst, partly one inside the cyst or in the wall. This is a case in which the axial stent went all inside, and this is the endoscopic ultrasound appearance of the stent going all inside. Another stent was placed, and this is how the two stents looked. And when the first stent was removed later on through the newly placed axial stent. A simple stent migration, this patient was retrieved by red tooth forceps. Sometimes the stent can get buried into the wall. The Spexus stent, this was retrieved by red tooth forceps. And this is the real follow-up policy. You can do pseudocyst, one, there are different follow-up policy. When to remove the stent. In summary, there are clear guidelines for fluid collections, which is pancreatic fluid is spread, but the misspread is mainly into the cyst, ligament cyst, but more often into the lesser sac. And whatever you are doing when you are doing cystogastroscopy is draining the lesser sac most of the time. Thank you very much. I again wish to thank Dr. Mohan Prasad for giving me this opportunity to speak. Dr. Mohan, I have another lecture. Can I leave now?
Sir, just a minute, sir. I will give a microphone.
Yeah, can I leave now?
Just a minute, sir.
Because I have another lecture after 10 minutes. Sorry.
Ma'am, your mic on, ma'am. Ma'am? Ma'am, your mic on, ma'am. Yes, sir. Go ahead, sir.
Yeah, hi. Yeah, we should be grateful to a great teacher like Malay Sharma, who has done a phenomenal job how to, take care of the pseudocyst, how to drain it effectively. Right. Now, we move on to a beautiful case, a third space procedure, which is called the POEM, peroral endoscopic myotomy. We have an expert looking on here. So, Dr. Ravi Shankar from Singapore is here. So, he's going to guide us. And the performer is Dr. Madhura Prasad Suman, who's an expert in all third space procedures and endo ultrasound guided procedures. So, over to this case presentation. Can you show the case?
Running,
And
sir.
Dr. Dev, yeah, come here and speak. Dr. Dev is our gastroenterologist, so he'll introduce the case.
Thank you, sir, for giving me this opportunity. So our next case is Mrs. Priya, the 18-year-old female is having a complaint of postprandial vomiting over the last 2 months. And when we did upper endoscopy, we found that patient is having dilated esophagus along with the food stasis, and there's a resistance while negotiating that lower esophageal sphincter. So we did manometry, and it came out as a type 2 achalasia there. And so our next plan will be to perform POEM for this patient.
And can you show that manometry has been shown?
I think next
So,
slide.
can we show the next slide?
Ma'am, your mic on, ma'am.
Can you show the next slide? We want to see the manometry images.
Yeah, please show the manometry image. So show the next slide. You showed the PowerPoint presentation. You showed the PowerPoint presentation. Can you show the next slide?
Running, sir.
That is a manometry of this patient, which has got a pan-esophageal pressurization. And even though the system said it's a type 1 achalasia, Myself and Dr. Ravi Shankar both, differ. We think it is type 2. And also this esophagus, which we're going to see now, is not too dilated or roomy. So this one will be probably type 2 achalasia. So now over to Madhura for the plan. What are you going to do? Where are you going to start the incision, and how many centimeters of myotomy you'll perform? Would you do a short myotomy or a long myotomy, or what is the plan? So please tell us. Thank you.
I think if we are going to treat like a type 2, we like to do a 5 centimeter myotomy on the esophageal side and 2 centimeter on the gastric side. So I hope you agree with that. So this is the OG junction. It was fully demonstrated with the the scope without the cap. I don't want to pass it with the cap. I like the OG junction not to be injured, because when I'm going into the tunnel side, I find some injury, it becomes difficult. So I don't try to enter with the cap, but I've already seen the OG junction at around 39 centimeters. So I'm starting the entry incision. I like to give a flap between the tunnel, between the myotomy side and the entry side of around 4 centimeters. So I'm going to start at 29 centimeters or 30 centimeters. And here we're going to inspect the mucosa. So the first and foremost important thing is to see the mucosa pattern. Can we have the NBI? So we're using an X1 scope. So it shows with so much clarity the mucosal pattern. Let me see the NBIS. Yes. So it looks pristine, the mucosa here. I have the needle in already, so that I can't suck out too much. Let us go to another part of the mucosa and demonstrate the NBI. Yeah, doesn't seem to be having much of submucosal fibrosis. It looks a bit pristine. A little bit of furrows are here. Can you appreciate the furrows there? So furrows would mean that it's a bit borderline, but there are no ulcers as such. You can remove the NBI, make it white light. So we are doing a posterior myotomy. So for posterior myotomy, we will be at 5 o'clock position. We put in a little water, check where the water is standing. And the water will be standing at 6 o'clock. And exactly where the water is standing, you can see the spinal bulge also. So we are sure that this is 6 o'clock. Patient is supine, so this is 6 o'clock. So we would like to start at 5 o'clock, but look there are furrows. Okay, and it might create some trouble. So I'm going to start a little bit towards the 6 o'clock, or maybe I'll choose another spot. It's very important. The spot to enter seems to be the most important thing, because once you're in the tunnel, there's no problem. But before you're in the tunnel, choosing the spot is very important. I'm going to take my time. Please forgive me for that. I don't want to go into a furrow.
Meanwhile, Madhura, could you explain how do you prepare your patient prior to
So what we'd like to do, Dr. Ravi is asking, so what we'd like to do is we'd like to put in a Riles tube at nasogastric tube at 25 to 30 centimeters above the air water line, and suck and wash the previous day or even 2 days. If the patient has a lot of ulcers, we like for a week to 1 or 2 weeks to have them on Riles tube and give rest to the esophagus for it to heal, because doing a third space, we need everything to be good. So if it was a bad esophagus, that would have been a good approach. So, and also always try to do an endoscopy before you proceed with intubation, because many of these patients have, even though you have done the scopy the previous day, the next day you put them on the table, they could aspirate because of just saliva collecting in the esophagus. So we like to always do an endoscopy before we intubate the patient. And yes, we are doing it under GA. So let me see if I can choose a spot here. This is how many centimeters? 30, right? Seems all right. This seems okay. This seems okay. Would you agree? The mucosa seems all right. So I'm using a 23 gauge needle. Use the smallest needle. Little bit of vision will be difficult here because everything will collect at 6 o'clock. So to prevent that, you can turn the patient to the left lateral also. It helps. So everything for a while, it seems to help. So I'm going to choose a spot here. Yes, so I'll say needle out. Start injecting. Keep on injecting. Yeah, so we're having a good lift. That gives me reduces my palpitation because I know the mucosa is good and there's going to be less vascularity. Yeah, and stop. and you can needle back. I'm going to use a TTJ knife. We like to use the TTJ, but we are happy with the hybrid knife as well. But um, what do you do in your unit? Okay. In at the same time. Yeah. You can do, saves you time. Definitely, definitely. So I'm going to start at the point of entry itself, where I injected. And we're using the RB system here. Needle out. So the cut also has to be a straight line and less charring and all that. Let's see how it goes here. So we have a good cut, and I like to extend, proximal first. You allow the scope to move and not the accessory. Always check your plane. Make sure your plane is there and you are not going to the bottom of the plane. I like to extend it a little bit here also. Yeah. Okay, there's a vessel there. Take the coir grasper. We like to exchange and go with the coir grasper. I know people use the precise sect and coagulate it as they go. It's an individual preference. We are using endocut Q, yes, and not spray coagulation. Yes, not spray coagulation. I'll show the tunnel entry and then we will be switching to another room, but let's see, you have to give some time for me. Yes, open, yeah, open. Is that the place? Yes. No, we have to grab it more, Open again. Grab it now, yeah. So when you're using the coir grasper, push the coir grasper out, at the same time pull the lesion up. We need to see a bit of marking, otherwise the scope will get damaged. We are using the coagulation.
So
I can't see the charring because
soft coagulation for coag.
No, it didn't happen because there's a lot of fluid there, and for coagulation to happen there should be no fluid. We'll open it again, we'll go back in, capture it. We'll try now. We'll try to inflate a bit so this fluid pops out of that place. I don't want too much injury near the entry point because it becomes difficult to close with the clips after that. Open. Let's see what happened now. Yeah, seems to have done its job but not good enough. Shall we check the setting? Open. Yeah, close it a little bit and yeah, catched. I can still see a good lift, so I'm not worried about injuring the muscle. Here we don't want to injure the muscle, and towards the OG junction you can open. You don't want to injure the mucosa. So here at entry point you don't want to injure the muscle. And at near the OG junction you don't want to injure the mucosa. So that's the most important part of the tunnel. Because here we are entering and there we are doing the myotomy. So we need a, So I'm going to inject some more and then see if I can do the rest with the needle itself. Yeah, inject. That's the beauty of a J knife because it will, it can inject and cut. Don't have to exchange. Okay, so stop. Yeah, can stop. I like to finish some apex dissection. I'm trying to coagulate like this. Let's see what happens. Shall we try? What do you think? You can try. Okay, I have a huge team here who can help me if something happens. Yeah, it seems to have worked. It's a bit fibrosed already. Yeah, so apical dissection. This is where you want to go, right? That is the direction. So you can see the dark. Oh, I have another big vessel there. I'm going to exchange again for the coir grasper. Can I have another coir grasper if possible? Or let's check on the settings once. Can you change to tunneling and myotomy? That has a soft coagulation there. We're using a preset settings, and that, yeah, swift coagulation. Can we shift to soft coagulation? Yeah, hemostasis. So really helps to know all the settings and all the everything, your mission, and I insisted the one which I'm working with should be there instead of something new. So that's important. Know your team. Now where is it? Oh yeah, there you are. I saw a larger vessel inside. Yeah. Is that the vessel? I'm going to grab that and see. Yeah, hold. Absolutely, I think that's the one. Can we have another coir grasper if possible? Yeah? This is new. Okay, can open. Little longer you want me to press? Yeah, it makes sense. I'm going to open. So this is a kind of dissection which our surgeons start to open and see. Close. No, open. No, don't grab it, don't grab it. Close it. Yeah. Open. Yeah, that's the vessel. So I'm going to actually grab it here. Hold. You shifted to soft coagulation hemostasis? No. Seems okay. Seems okay, but we still have to cut it to go ahead. So I'm going to try to cut it. So coag and cut to create some space. Open. Yeah, hold. Hold. I'm going to cut. No, it's not working. You must change to tunneling. Yeah. And tunneling. Yeah, leave it, leave it, leave it, leave it, leave it. Leave it at tunneling. Yeah. Cut. Yeah, open. I think it's fine. We'll go ahead with the TTJ again. Okay, inject. Yeah. Yeah, it's fine, it's fine, it's fine. So what we do is de-ledging, where we try to cut the fibers out, needle out. Oh, there's a bleed there. Needle back. That's the vessel, which was not coagulated, I think. I'm just pressing against it with my cap, going back with the coir grasper. It's a different one? Same one. Can you get me a different coir grasper, please? Okay, where's that source? Give a wash. At the edge. Okay, I think it's this edge which is bleeding. I don't want to catch the edge. But we'll anyway hold it and hold it for a bit. Hold. Are we holding it? It's not stopped, so that's not the point then. Open. Can we turn the patient left lateral? திருப்புங்க. Yeah, but it's going to only, because everything is settling down at the 6 o'clock position. You can see, hold the scope. Hold the scope. Like this. Hold. Yes, I can see this here. Is it in the other side, the muscular side, or in the mucosal side? The bottom. Open. Want to twist it? Yeah. All right. See you. Yeah. Hold. Yes. Try பண்ணலாமா? Okay. Hold the scope. Yes. Not able to see anything. Open. It stopped. Stop பண்ண மாதிரி இருக்கா? Looks like it stopped a bit. I'm holding it, that's why it stopped. But I can't see, and then I can't coagulate without seeing where I am. I'm going to keep sucking. Am I still on? Okay. So, yes, so what we are doing is we've held the point of bleed, but without vision, I'm not going to coagulate. It's still too much water there. It stopped bleeding because I'm holding it. But the moment I let go, it's going to bleed, but I can't see where I am. So without seeing where I am, I'm not going to coagulate. There you are. Okay. It stopped. Open. I think there's too much water. We'll suck out and come back. Open, leave it. Yeah, we'll suck out the water. It stopped. There was a brisk bleed, thinking we thought it's a bigger vessel. Let's see. Yeah. It is oozing still, but not so bad. But it's on the other side, the muscular side, not the mucosal side. Seems to be okay, but we can't find an exact vessel there to stop it. Sit. Is it on this side or it's on this side? It's on that side, no? The muscular side. But I can't see anything, so I'm going to go ahead with TTJ. Yeah, and inject so we can spot the exact site, and then go back with the coir grasper. I'm a very careful person and I like to do things slowly, but you will see, more masters doing poem next. So you can inject, keep on injecting. Yeah, enough. Stop. We add a little bit of diluted epinephrine into the injection fluid. There you go. It's bleeding there. Now I can see the spot. So get the coir grasper. It is on the muscular side. Now we have to be very careful not to chart the muscle though. Kind of stopped again. Stopping oozing. Is the other coir grasper it? The cap position not allowing me to see what is going on. You want to wash? Wash. Enough. Where is it? Again it stopped, huh? Again it stopped, but we better stop it before going ahead. Because it will bleed again. Shall we proceed without it? It's on the other side. The cap will, compress it as we're going. Then if there is any bleed again, we'll check it out. So you can see the tunnel, a little more of deledging and I'll be able to go in. If it were the mucosal side, I would have grabbed it a bit better, but I don't want to touch the muscular side. So we are happy doing a posterior poem, even though the tunnel entry is not that easy, the posterior poem. Oh, don't tell me again it's bleeding. The moment I try to enter, it's bleeding again. So now I can see that spot on top. Yeah, I'm going to focus, keep it there, and try to exchange and coagulate. Keeping the bleed in focus is important, and knowing, fix exactly the spot so you can come back to it. And don't change the scope position and your view also. I'm going to grab it away from the muscle and then try to. Hi, sir. My guru is here, Dr. Mohan Ramchandani. How are you, sir? Yes. Okay, open. Yeah, ready, open.
We have
Close.
a guru here,
Hold on, step.
Dr. Mohan Ramchandani, so who's an expert in all third space procedures. In fact, he was the one who taught us all, and I did my first poem under his guidance and supervision. So the guru is here, so of all third space procedures and whatnot. Sky is the limit for Mohan. Now Mohanji is here, so please come over, and he'll be, guiding Madhura through this poem.
Open.
Madhura,
Yes, you have come at the right time.
where are you now?
I'm here at the entry spot. There's a bleeding spot here.
Yeah, don't
Open.
bother about this bleeding spot.
But the
because-
moment I try to enter, it's again bleeding.
No, let it
open,
bleed.
open,
So,
open, open.
Whenever
Close.
we are in the mucosal incision side, we should not spend too much in coagulation.
Okay, okay,
Because
okay.
that will make the incision more ragged and difficult to close.
Correct,
And
correct.
most of these bleedings will stop once your
Open,
scope
open.
is inside with the tamponade.
Leave
So
it.
best is to allow it to bleed and carry on with the incision.
That's wonderful to hear, because I'm going to do that now.
So
So,
the orientation is posterior. It's more on 6 o'clock. That's why it's on the bulge of spine.
yes,
That's
yes.
why it is slightly difficult to enter.
We
But
have-
anyway, the incision looks very small to me. You can
Okay.
enlarge this incision by a centimeter downwards.
Sure, sure, sir. The thing is, we have not even tried to enter. Before entry, it started bleeding.
Yeah,
You can inject.
Okay, yeah,
Yeah, yes.
that's fantastic.
So, needle out. Can I increase the incision a bit?
Yes.
Yeah.
Suck out the fluid first because it's getting, that's right. Suck out whole fluid, yeah. Okay. You can come proximally to suck out the fluid because it will come out again.
Yes, true. I'll come out again and suck.
So now there's a very nice submucosa in front of you. So you can have a dissection on the lateral side.
Definitely. Is enough incision?
I think we'll first do the
Dissection.
more dissection on the
Lateral side. Needle out.
Don't bother about this bleeding.
Wow. That is something wonderful to hear actually. Because you're there, I can
keep on
continue.
dissecting the submucosa.
Needle out. Yeah. It's ready? We'll enter and then
Not
we'll
yet,
show.
not yet. Still more dissection needs to be done. So I will suggest you to keep the accessory stationary and go with the scope.
Go with the scope
Go with
only.
the scope.
Yeah.
And don't bother about this red thing.
Yes, very nice. So now you can keep on dissecting on that side. Similarly on here, towards you. Yeah, yeah, yeah. Keep on doing. Yes. More, more, more. Yes, very nice.
We will inject a bit more, sir.
Yeah, more.
Yeah. And inject. Inject more. Yeah, you've injected? Yeah, yeah, yeah. So you don't want us to stop that small ooze which is
No,
going
no,
there, sir?
no. Yeah,
Yeah.
now you can enter. Yes, push. Yes, almost. One. That's a very
No,
important step.
we'll
So
show
what
the
you can do
entry.
is
We'll
you
show
can
the
have
entry
one
now.
more.
Cut a little bit on
Yeah,
the
slightly
ledge,
more,
D-ledge,
slightly.
D-ledge. Yeah, needle out. How to improve this vision is only by sucking, no, sir?
Yeah,
But then
sucking
if we
and
suck,
you
the
may
fluid will
turn
come
the
out.
patient slightly laterally also.
Lateral, yeah.
Slight
Proper left
lateral.
lateral, I told
That
you to
will-
put, no, patient?
Yeah.
Please put the patient left lateral. Yeah. I thought the patient was already left lateral. Yeah. Leave the scope, leave the scope, leave the scope. No, no, no. We are going to enter and then go. We'll show entry and then we'll go. Put some water here.
You can enlarge the incision by 2 millimeters.
2 more millimeters. Yes, yes,
No,
yes.
don't push water.
Don't want, don't want. Okay.
That will all accumulate there. Push the patient left, more left.
Madhura ma'am,
Yes.
next that is ready. Vamsi sir want to start. We will move on the
We
next
wanted
that
to show the tunnel entry and then go.
Okay ma'am, thank you.
Okay, 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 okay.
Come back, come back.
Yeah.
It should be
Inject.
more than the 1.5 times the scope. So it's around maybe 1.5 to 2 centimeters.
Yeah.
I know. Cut from below.
Cut from.
So that, yeah, so that you can include the submucosa also.
Yes, yes. So you
And
want me
use
to cut
some
from.
coagulation, you know.
Yeah. So we'll do a spray coag and
Yeah.
inject a
Start.
bit more. Yeah. So it seems to be adequate. You want me to cut some more, sir? We can try to enter.
Try to enter them.
Little more. Reledging has to be done. Want some more millimeter of cut over there?
1 millimeter of cut will help.
Okay. Needle out.
At the apex.
Apex. You want me to
Yeah,
increase the
yes,
cut?
yes.
Yeah, yeah, yeah.
Yeah,
Yeah. Enough. Back.
that should be enough.
Try to enter now. No. I think we'll switch and deledge and come back again, sir.
Okay.
What do you want to do, sir? We'll show them the entry once more. You can switch. It's taking more time and it's bleeding. So
Thank you ma'am. We will move on the next that and come back to you ma'am. Vamsi sir. Vamsi sir, your mic on sir.
Am I audible?
Yes sir, yes sir.
Yeah. Hello there. We have a very young female patient over here who presented to us with hematemesis. And we want to see what is the cause for hematemesis. She came yesterday night to us. And we have a very dynamic gastroenterologist who came from Singapore, Dr. Ravi Shankar. he wants to introduce the new scope to us, and then we'll see what's happening in this patient. And we also have Dr. Srinivas accompanying in this room.
Good morning, everyone. So we have a young lady who presented to us with hematemesis on endoscopy she has gave. So to do this case, I have the state-of-the-art endoscopic machine from Olympus, which is EVIS X1, and I'm using the 1500 scope. So the beauty of this scope is it has few functions. It has the EDOF function, which helps you give a global view because it superimposes images, and it makes the image quality very clear, as you can appreciate on the screen. The blood vessels, the whole appearance of the esophagus is very clear because of its EDOF function. In addition, as you can see, the 1500 X1 series also has a few more functions. One is its NBI. You can see, compared to its previous generation NBI images with the current generation, the image quality is exceptionally high, and when I zoom in, you can see that the detail with which you can see the mucosal and submucosal vessel is phenomenal. You can precisely appreciate the surface pattern. You can appreciate all the vascular loops. So the NBI in this, compared to the previous 190 system, is exceptionally good because of its improved clarity. In addition to that, there are two other functions which X1 comes with. One is your RDI. How RDI helps is because of the amber filter which it has, it helps you see the blood vessel very clearly. The utility of this comes in very handy when you are doing like third space endoscopy, or when you are trying to cut something and something is bleeding, you don't know what is bleeding. So using an RDI function, it helps you to see the blood vessel. So the RDI function helps you to see the blood vessel and target your treatment precisely. So the blood vessels, as you can see, will appear yellow in this mode. And then the third function which we have is called TXI. TXI makes the imaging very bright. For those people who have used Fuji systems before, you may also appreciate, which is something very similar, like the LCI in Fuji. Here it's TXI in Olympus. Either way, it enhances your image brightness, and you can see that it appears even more brighter in your TXI view. So now we are going to go back to white light, and then I'm going to go all the way down. I'm zoom, so I'm coming out of zoom. This is your G junction. As you can see, we are entering the stomach now. There is no esophageal varices, so there is no sign of portal hypertension in this young lady. We are entering the stomach. The stomach mucosa looks all right. We are in TXI mode. This is the regular mode. You can see with TXI things get brighter. Whenever you have an inflammatory lesion or something that is red, TXI is based on hemoglobin, so it picks up and makes it appear even more red. So I'm going to go down all the way. So here we are. We could see all these reddish angioectatic spots here. This is even more very clear. As you can see, these angioectatic spots in a zoom mode, you can see the dilated blood vessels very clearly, and here again, and here again. The vessels are beautiful. You can see how dilated they are.
I think this RDI TXI imaging has really beautified the whole thing. These are classic angiectasias.
Yeah.
You showed the bigger one also in the front. Yeah, there are multiple angiectasias.
Yeah,
In otherwise normal lady young lady who came with there's a beautiful angiectasia again. You can see the vascular pattern of these angiectasias very clear. So on this new technology scope, EVIS X1 processor and the advanced scopes. So this young lady came with hematemesis. So I think deserves a good APC to just coagulate all these blood vessels.
So again, just to highlight you how it appears in RDI, we can see the blood vessel here. The blood vessel starts to appear yellow because of the amber filter that the system has. So now we are going to use APC.
Would you like to look at the fundus also?
Yeah, sure.
Were there any lesions there? Angiectatic lesions? What do you think is the etiology here? Is it genetic, or do you think that is a fundal varix?
It doesn't look like fundal varix.
No.
No,
Okay.
not at all. No.
She had no esophageal varices. She has
She has
no
no
cirrhosis.
esophageal varices. She
Yeah.
has no cirrhosis.
No portal hypertension.
No portal
On
hypertension.
ultrasound also. Yeah. Okay.
The other
So-
thing we have to entertain is whether she has any other autoimmune diseases that could contribute. Typically, when we see this kind of angioectatic lesions, there are a few other non-liver related conditions which can cause this. You can sometimes see in patients who have renal dysfunction, we can see in scleroderma, we can see in autoimmune conditions. So in her case, we may need to entertain those, and we may have to evaluate why she has.
Also, chronic kidney disease,
Yeah.
CKD patients.
CKD
can also
patients
have
tend to.
these
Some-
sort of angiectasias. So, but all the workup was negative. We don't even know why she has these angiectasias.
So moving on, we have decided to ablate these angioectatic vessels using APC. APC comes in different settings and mode. They have Herbe, we are using Herbe 300 YOD. So APC, the catheter comes in two different sizes, 10 French and 7 French. And then we also have different types of settings. We have pulsed APC, forced APC, precise APC, and then again the catheter also comes in different designs. You can zoom in. This is a straight fire catheter. We also have a side fire catheter. We have circumferential catheter. Herbe postulates saying that by having those external attachments, the APC gets spread evenly. But when we look at the signs of APC, the way it works is, it is a non-contact energy delivery. You just have to stay at least 4-5 millimeters away from the mucosa, and whatever it is, the organ goes to the tissue that is close. So whether you use straight fire, side fire, circumferential fire, in my opinion, there is not much big difference, because the way the APC gets delivered is whichever tissue is close to the catheter, the APC goes straight to the tissue, and straight fire is somewhat easy to handle. So you insert your device, and my settings here are standard. We use a flow rate of 1 at 30 watts, and stomach antral mucosa is thick, so you don't have to worry much about APC related adverse events because the muscle layer is thick there. However, when you want to apply APC in cecum or in the esophagus where the mucosa, where the muscle layer is thin, you need to be careful with your settings.
Dr. Ravi, so if there is a watermelon stomach, would you use a lateral firing or would you use an end firing? APC Pro. What would be your choice?
My preference for any type of angioectasia is a straight fire, because again, based on the principle, not to offend RB or something, but based on the principle, the way APC gets delivered is whichever mucosa is closer, the APC goes there. For instance, if you're here, if I apply, it goes here and it functions like a side fire APC. So straight and side, in terms of clinical benefit and utility, I think it's minimal. Yeah.
And to the young viewers, what is this APC? It's argon plasma coagulator. So where first the argon gas is ejected, this forms a plasma over the lesion. Then you just press the electric current, so just produces coagulation. That's what is APC. So, and again, I also use more of straight firing. Even in the management thought, if somebody does a mistake, you want to punish him, it's a straight firing. You don't do a lateral.
Yeah, straight firing is always better.
Always better.
So again, there are different modes in APC. Pulsed mode is intermittent release of energy. Forced is like painting. So we like to paint because, can you switch to pulse mode? So we show them what pulse looks like. So I'm going to show you what a pulse mode looks like. So we are going to go closer. In APC, whenever you want to do, you put your catheter, don't put it close to your endoscopic system. Olympus will be unhappy because you're going to damage their scope. So always put it outside. Herbe has this black color mark for you to decide where to place the catheter. So you pull it back, place it at this distance. This is good. You hardly have to move your catheter in and out. Most of the time your catheter stays static. You're going to move your endoscope in and out. So I'm going to show you how a pulsed APC looks like. So we are here. I'm not going to touch the mucosa, and then I'm going to deliver. It just delivers one pulse. So it delivers one pulse. But rather we want to paint when you do APC. So I prefer a forced APC, in which case the organ delivery is continuous. You can stay here, you can just apply like this, so you don't have to waste time, and you are precise.
That is a beautiful demonstration, Dr. Ravi, how to do a
And then you apply.
post-coagulation and a paint mode.
So we always do it so it's faster. You stay closer, and then you paint.
We have Dr. Amal Prayanta from Sri Lanka with us. So, yeah, he's going to be with you also. So, I want to ask Amal, because he was one of the earliest therapeutic endoscopists of Sri Lanka. So, how many cases of, these sort of angiectasias do you see, and what do you do with them?
We occasionally see actually once or twice in a year. We also use the APC. But sometimes we have seen very extensive things like especially portal hypertension. In that case, what do you do, Ravi? You advocate APC or you advocate something like a shunt procedure or what?
So APC, gave management can be tricky sometimes. Like in this case, you can see the ectatic vessels are minimal, so we can ablate them completely with our APC. But there will be situations where patients come in 2-3 months again with drop in hemoglobin. Even after APC, you have recurrence. So if your gave appears nodular, let's say it appears like one nodule here, one nodule here, here. One option that we can consider in this case is band ligation of these gave. That helps to treat them to a certain extent. In certain instances, if it is very diffuse, the other option is RFA. You can use an RFA to ablate the gave. Yeah. Sure. Yeah, I will just ablate in the meantime. Yeah.
Everything in one session?
I don't know. Here I think the return to follow-up rates are not so high, so we take this opportunity to burn as much as we can. So we minimize costs for them.
So as Dr. Ravi is demonstrating the end firing using the forced coagulation mode, setting 1.
Yeah, 1 and 30.
1 and
30.
One
Flow,
and-
yeah,
yeah.
flow is 30. Flow is 1 and then energy is 30 watts.
So flow is 1 and energy is 30 watts. So now, in the other theater, we have progressed with the poem case. So we'll briefly switch to OT2 and then endoscopy suite number 2, where Madhura is continuing with the poem. So we'll just come back.
Yeah.
So
See you
can
soon.
keep
We will
firing.
continue.
Yeah. You need to get it clean, no?
Yeah.
Sometimes, we need to clean the tip. So if it touches.
I think we are good here.
Yes,
some more.
remarkably covered and wide extent of angiectasias. I think there are some in
Few
the
more
fundus
and then,
also.
yeah.
There are some small ones in the antrum. It always requires rework up after a few weeks of the tissue healing. So how do you help the healing of tissues after this? You use sucralfate topical?
We use just PPI for them, high dose omeprazole, at
What is
least
your
6 to 8
experience
weeks.
with ribamipide, which is
We
a time-honored molecule, been there for at least 30 odd years, 35 years to be precise, in Japan, and not very popular in other countries. But again, it has had a comeback in India. Do you use that ribamipide in
no, in Singapore we don't have that. Indonesia they use it, but I have, because it is not available in Singapore, we have never used it. Where we practice, what is widely available is vonoprazan, which is a PCAB, potassium channel
it's
blocker.
coming to India.
That one is very good because you don't have to adjust it with your meal time. It can be taken any time,
Correct.
so patients like it.
Also more potent.
More potent, yeah, more
In the
potent.
meantime, you can keep continuing. So we are still live. So the moment they said they're switching, then we can go offline. We continue. So can we switch to OT2?
Yes, sir. Madhura ma'am, your mic on, ma'am.
Yes, 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 yes. We're here. Can Dr. Mohan also have a mic?
Yes, sir. Yes, ma'am.
Yes, good,
Both the
good,
mics are
good,
on.
Good. So we have crossed the OG, and we are in the gastric side. So how much more do you want us to go,
So
Dr.
we'll go
Mohan?
1 centimeter more.
1 centimeter more. Can we inject a bit more? Yeah, inject. Yeah, okay. So needle out. We're using the spray coig here. So
Be careful towards
I'm not going that way. I'll close to the muscle side. Yeah, that side should be all right. You want me to go a little bit deeper, sir? Trying to stick close to the muscle. So I'm trying not to move the needle at all and only move the scope.
Yes, very good.
So
That's the mucosa there.
that's the mucosal side. So
Sometimes
I
we
will
can
switch
cause the
closer
burn
to
on the
the,
back of
yeah, I'll keep close to the muscle area here.
Because if you use spray, you have to be very precise. Otherwise,
Yes, absolutely,
spray is a
absolutely.
non-contact current. It can burn
Needle
the
back
back
and
of the
inject.
mucosa.
Absolutely. Absolutely. Shall we stop now and examine, or you want me to? This is 2 centimeter into the stomach?
Yes.
Okay, so you can come out and.
So we'll come down, come out and see how is our tunnel. Yeah, very nice. So that's very good.
This is the OG junction where we crossed it. This place, I think. Where is that?
That's the OG.
This is the OG junction,
Those
bit narrow there.
fibers, the spindle vessels you can see now
Yes,
onto
yes.
the muscle. That's all cardia, gastric cardia.
So
That's very
after
good.
you start your myotomy, then we'll switch to OT4.
Sure.
Where Shivangi is ready for ERC.
Very nice.
It's already in.
So that's the very nice. The tunnel is entering into the stomach, and then it is. You can
Bit into the
retroflex and
stomach.
see.
It looks
Yeah.
like little more deeper, maybe.
So sometimes you may have. You see that? That's it. Very good. You can push the scope and measure.
Measure.
The thickness of scope is around 11 mm. So it's double of the thickness of the scope. That means it's 2 centimeter.
So we'll stop
Yeah.
we'll start the myotomy now.
Once you start myotomy, we'll quickly go into the other theater.
Some water there. Yeah, it's already there. So this is a type 1 achalasia. So it says type 1, but we want to treat it as type 2 because there's no sigmoid esophagus, and when we manually saw the manometry, we found some increased pressurizations. So we'll treat it as type 2. So shall we take 5 centimeter above the OG and 1 or 2 centimeters?
2 centimeter, the gastric is done, so you
Yeah.
can do around 3 centimeter in esophagus, 3 to 4.
3 to 4 in esophagus and 2
2 centimeter in stomach.
2 centimeter in stomach. Yeah, sure, sure. What would be your take on full thickness versus partial thickness in the beginning and then full thickness towards the end?
Yeah, so I actually gradually have moved away from calling full thickness because the longitudinal fibers in one incision you cannot completely get rid of longitudinal fibers. It is the one fiber which gets separated.
Yes, yes, yes.
So it's not the whole 99.9% still is active. While if you cut the circular fiber, if you snap it open, it's totally gone.
So what do you want us to do now actually?
You can do full thickness or you can start from, yeah. So you can see this is the lower margin of the mucosal incision. So you can go 1 centimeter inside and cut from here, right?
Cut from here.
Yes.
So we'll be doing 4 centimeter as planned.
Yeah.
4 centimeter till the OG.
Yeah.
And so 1 centimeter gap is enough, is it?
Yeah, 1
Between the same. So a lot of bile stain. So this is the muscular layer, and we want to see again the entry point. This is the entry point. So from entry point, I want to enter here.
Yes.
From here, we'll start. Okay. Centimeters here. Show me. Yeah. Okay. So I'll start like a full thickness, and you can stop me.
Slightly more proximal.
More proximal.
Come
more,
back,
more, more.
come
You
out.
want me to come back?
Come back. More come back.
Okay.
More
more.
Yeah, from here.
I like to give a small gap between both. Okay.
Yeah, but
okay.
the scope, the accessory is quite in.
Yes, yes,
It
yes,
is-
yes.
if
Oh,
the
okay.
cap is
Correct,
still
correct.
inside.
Absolutely, absolutely.
Yeah.
So I will go down first, dip down.
Yeah, that's enough. Now pick up all those fibers.
And we do a 2 coag and
So you have to bring the, yeah, it's too much in. Yeah, now it's good. Very nice.
so I'll cut
Yeah, so
like a
your
full
accessory is
thickness.
too much out.
Too much
You
out,
are-
yeah.
So
yeah.
you
Yes.
go with the scope.
Yeah.
Go with the
absolutely.
scope. Yeah, now it's perfect. So once you are with the scope with accessories slightly out, your control on accessory is much better. Otherwise you will hit the mucosa like this. Yes. Yes, very nice.
So
No, don't stop, because if you stop, then you convert endocut into true pure cut, and
Correct,
then
correct.
your bleeding chance will increase.
so I'm doing coag and then cut.
Yeah, then if
But you
see
don't want me to tap.
Yeah,
You want me
no
to
tap,
continue.
tap. See that once you do
that
tap,
pulse.
it's pure cut.
True, absolutely.
Otherwise, if there is a small vessels that get coagulated, because endocut is an intelligent
I
cut.
don't want to hit the mucosa, so I'm trying to, but I understand why it has to be continuous. This okay?
Yeah, perfect. Very nice.
It's very thin towards the side.
That means you have crossed the GE junction.
What centimeter are we, sister? Okay.
Very nice.
So I will leave that serosa part of it, and
Yeah.
it's okay if I go with only coag?
Yeah. Okay.
Okay.
That's better in the stomach.
Better in the stomach.
Spray some water to clean.
No. I will spray. That's enough.
Now you have more better.
Better visibility. Yes, you can switch. You can switch. We are almost done. You can switch. We'll show the end of it. Yeah, that's it. Is that some problem?
No, that's nothing.
That's just a fiber. Okay. Yes. Needle out.
Yeah. Very good.
That's fine?
Yeah,
This
that's
way.
fine.
I think we're very close to.
That's
The end,
submucosa.
huh?
That's submucosa. Okay, very good.
Think, are we done with the myotomy?
I think you can add a
little
half,
more?
half centimeter. Come back. Catch the where you left.
Yeah.
Yeah. Here.
Yeah,
This-
here it is.
That's
Here it is.
submucosa. That's submucosa.
Oh, this is submucosa.
Come
Yeah.
back. That's the muscle. See
This is
that?
the plane of the muscle.
More proximal, please. That's the muscle. See that?
That is the
There,
muscle.
yes.
Yeah. Correct. I think I left it actually in
there.
between.
So that will be
Yeah.
slight.
Is it too deep or it's okay?
No, it's okay.
Heel out. Yeah. I'll keep it inside. Yeah, now I got the plane.
Yeah, that's the muscle. See that unless we cut that. Yeah, complete myotomy. Yeah. Keep on doing, yes. Yes. Okay, now I cut.
This is fine.
Wait.
We'll
There is
stop.
a vessel there.
Okay.
If you push water, you can see the vessel there.
Sure. Wash.
Wash. See that will bleed very.
Okay. Can I stop here or do you want me to do some more?
You can go to slightly right. If you go to the right, you will.
Be able to avoid that vessel.
Yeah,
This
avoid the
vessel, right? This
Yeah, that's the vessel.
This one.
That one, yes. That will bleed. So go to
Wiggle
the
out.
right. Come back and take that. Come back. Yeah.
Can
the
take
bottom,
it from
the
here.
bottom.
Okay. Right here. You
Yeah,
want me
right
to
here.
shift? Yeah?
Yes.
Okay, sir.
How do we identify sling fibers? Because many times we are not seeing the sling fibers.
No, but
very clearly.
unless you dissect too much on the muscle and expose, then only.
You want me to cut that bit
That's
also?
enough, I think.
That's enough.
Yeah.
Okay.
Now I think
Shall
we have
I
gone enough
stop
into
and-
the stomach.
So that layer should be intact,
Yeah,
right? So that it
yes,
doesn't produce any more peritoneum.
Yes, and you can
Okay.
see the peritoneal fat now.
Yes. This yellow parts.
Below one.
Below.
Yeah, that one. Come back and now we'll see how good we have cut. That's very nice. Come back, very good. Come back, yes. Now we'll enter inside and see. Wow, that's completely open.
Wow, that's
Very nice.
great. I think we
Very
should give a
nice.
big round of applause.
Thank you so much.
Very nice.
I think when the guru is next to you, I think it becomes very easy to do anything. So even the first case that I did when Mohanji was teaching me, I did a complete myotomy, just very quickly. And he was asking, oh wow, you did a complete myotomy. I said, when the guru is next door, what is the problem? So now, as she's starting the clip closure, we will move to that side and come back, or you want to show the first clip? Or
You want me to put a
first
bigger
clip.
clip because it's a bit short, or shall we proceed with the regular clips?
Regular only.
Regular should be fine.
Unless you have a lot of money, sir.
she's waiting for a long time to go. So
We'll switch and come back. We can do it as a PIP or something. Yeah.
Yeah, ma'am. Thank you, ma'am. Thank you very much.
Yeah. So you can. Thank you so much, sir. Thank you. That was amazing. I learned really a lot today.
Yes.
Go ahead, ma'am.
Yes. Good morning. We have here with us Dr. Shivangi Kotari. She's a young, dynamic, and a very versatile person. And she is the Associate Director of Endoscopy in Rochester. She's the Associate Professor of Gastro in Rochester University. And she's also the ACG Governor for the whole of Northern New York. And her niches include ERCP, EUS, SPI. She's Barrett's endotherapy, pancreatic cancer screening, and so many more. I think we're really happy to have you here, madam. Thank you for coming over. And she's
Thank
best
you for
person-
having me.
Oh, thank you. She's the best person to take us through this patient. She's the patient who's here is Mrs. V, who's a 60-year female. She's presented elsewhere with cholangitis, which was managed conservatively, and then she has been brought over here. So right now we found a contrast CT showing an ill-defined peripherally enhancing lesion in the GB, which is infiltrating into the CBD, and which looks like a malignancy. So the plan is an ERCP and a biliary sense.
All right.
Over to you, ma'am.
All right. No, thank you, Dr. VGM and the entire team. Congratulations on a great unit, great course, and also thank you for inviting me to be a part of this.
We're all excited because I know you're a go-getter and you'll never, ever fail. That is
You've just jinxed it now.
like
No, thank you.
RRR.
Yeah.
So just keep on marching. So
All right, perfect. So,
over to you.
all right, perfect. So, we are using the new Olympus TJF 170 scope, which has the disposable cap to again minimize the risk of infection transmission and bacterial infection at the elevator. So, we have the disposable cap to show you guys.
Can you focus here?
So you can see the cap. This is disposable. And again, this is mainly to minimize any infection transmissions associated with the duodenoscopes. All right.
Thank you, ma'am, for nice introduction, ma'am. Ma'am, before introducing, ma'am, I just wanted to know for the beginners, ma'am, like to identify the morphology of the papilla, like which is going to be difficult for beginners, like particularly for us.
Right. So the main thing I always tell my fellows is spend some time looking at the Spend some time looking at the papilla, try to anticipate which way the bile duct is going. You don't never want to be above. You always want to be below the papilla and try and gauge. So for now, we've been looking at this for a while. But our anticipation is that the trajectory of the bile duct is going upwards along this angle. Again, this is a small papilla, so you could consider just having a tip of the wire to engage it. I always like to bow my sphincterotome to get that upward angle. ERCP is all about vectors and angles, so you try to make sure that you get that upward bow. So we'll do a little bow here. All right, perfect. And then let's get the wire at the tip.
So it could be wire guided cannulation, ma'am. That
Yeah,
could be the safest.
you always want to start with a wire guided cannulation and then advance your catheter. We're getting a little bit of motility here. Again, we are dealing with a gallbladder cancer, so the anatomy is a little skewed. You want to gently engage the papilla. Again, we still have our upward motion. I'm slowly bringing my big wheel towards me. We always want to maintain that upward motion, gently advance the catheter. And once you feel you've navigated that first fold, you try to have your tech feel the wire. Can we advance?
So there'll be some giveaway feeling like that.
You will feel a little give. So there are two layers of give. One is the initial give at the ampulla and then the duodenal wall. Oh, we lost our 1 second. Perfect. So we have a little redundancy here. You can see as we are trying to advance the catheter, there is a little bit of redundancy at the ampulla.
Yes, ma'am. Sure, ma'am.
So it's okay to disengage. Can we give some glucagon, please?
Buscopan we are having. Can we
Buscopan,
give Buscopan
yeah,
also?
Buscopan
Yeah.
is good.
And regarding giving Buscopan also, ma'am, like for the beginner, I'm just asking a doubt. If the patient is having already as a 110 heart rates and all, so is it been safer like 110 or 120? Should he give or like for one ample buscopan? Because sometimes that doubt keeps on our mind, should we give or shouldn't we?
Right. So we usually use glucagon in the US.
Sure, ma'am.
We'll let the Buscopan kick in. But again, that's a conversation. That's a great question. That's a conversation with our anesthesiologist. You're always communicating with them, speaking with them. And I'm always checking, is there any change? Even when we're doing like minor ampulla ERCPs and you're giving so we have a little better angle.
Just little. Okay.
Perfect. So now we have a little deeper cannulation, you can see. So we're going to slowly advance our toe.
Yes, ma'am.
And we'll try the wire here. And we feel a little bit of a give. Fluoro, please.
Screen.
Fluoro.
Yeah.
Perfect. So we're, can we right left reverse? Sorry, that's the US angle for ERCPs. So, all right. Fluoro. So we can see the wires heading most likely. So loops are always good. Keep that.
Yes.
Loop in the world of ERCP is always good.
Sure.
So once you advance it through strictures, that's always
Yes.
helpful.
That VisiGlide, particularly in that type of.
Right. Because the loops usually don't perforate your ducts. So
Sure.
you're always safe pushing a loop across the
Better
structure.
negotiating in a structure particular
Right,
case.
Right. Fluoro, please.
Screen once.
All right. Fluoro live, please. All right. So now can we straighten our wire? Pull the wire, try to get it. Again, we may be stopping at the stricture. So this is where your experienced techs are very, very important and helpful. You can see how we navigated across a tight stricture. So
Yes,
now
ma'am.
we'll do some injection.
Contrast.
Fluoro, please.
Screen one more time.
Keep injecting. Keep injecting. So the main goal here is you want to delineate the stricture. You also want to make sure are there any secondary strictures, how high is the obstruction. You can see we're dealing with a very tight stricture right in the mid portion of the CBD.
Sure, ma'am.
And you have significant dilation of the common hepatic duct
Yes.
as well as the intrahepatic. So we'll inject further. I'm also constantly focusing on my endoscreen at the same time to make sure that we don't, it's an unstable position so that we don't fall out.
Sure.
Because then once you lose cannulation, that is one of the cardinal sins in ERCP is
Yes.
you lose a cannulated duct.
Yes, ma'am. So, ma'am, regarding that stability, ma'am, like as a long position or short position, ma'am, can you give a.
So your short position is always good. You always want your scope straight and in the nice J like we have it. But some anatomy doesn't render itself to that kind of a stability. So you will unfortunately have those long position ERCPs. The key is you keep watching your endoscreen and make sure you minimize your
Should not fall out.
insufflation, don't fall out. And even if you do, the goal is you suck down the stomach, go back in and, try again. So, Fluoro, please.
And one more
So-
doubt regarding that contrast, ma'am. As we know that it's a stricture. So, I mean, what do you prefer, ma'am, giving a contrast or air cholangiogram to see that dilated? Like, what could be your choice, ma'am?
So I personally prefer the contrast because again with air cholangiogram, this is a blocked up system. You do run the risk of an air embolism, so there have been reports. So I personally prefer full strength contrast for stricture cases. For cases that are stone, you don't want to use full strength contrast. For those, you could use half strength.
Thank
we
you.
don't have air. Okay, now we do. It's intermittent. All right, so we will get ready for a cut. We'll do our sphincterotomy. So exchanging, coming out. You're always talking with your tech, so because they can't read your mind, I'm coming out, we may lose the cannulation.
Yes.
So you're always talking to your tech, coming out, get ready for a sphincterotomy. Again, if you're pressing the pedal and nothing happens, make sure the cautery is connected to
Yes.
the sphincterotome. Little things which, in difficult cases may get lost. Can we switch the picture in picture? So we'll use the endocut mode. You never want to use a pure cut in this day and age. The electrocautery machines are so good that you're essentially always using a blended current. So I'm trying to now see the trajectory of our bile duct. We'll have a small bow. Again, we're planning to stent this patient, so we want to have a sphincterotomy. I don't put metal stents without a sphincterotomy because again you run the risk of post-ERCP pancreatitis.
Yes, ma'am.
So I'm slowly torquing left, coming back, checking my orientation. And you're using the tip of the wire to cut the sphincter. Perfect. And so you always have to remember the size of the initial papilla. So if this was a 3-hour ERCP, which will happen in your career at some point, if the ampulla gets swollen up, that part of the duodenal wall is in that ampulla.
Yes, ma'am.
So you don't want to overcut. You'd rather undercut, stent, and come back another day, because all that swelling will give you a false sense of a big ampulla. So always take a picture. I always take a picture actually even before cannulating. So you remember what the native papilla looked like. So we will unbow at this point and exchange to the balloon.
So that coordination is an important role in
Very
doing.
important right now because this is exactly where wires get lost. So you are essentially looking at the markings on the wire in the endo view. I even tell my techs, don't look at the hands. The reflex is that we look down to exchange. The main thing is if you keep looking at the endoscreen and do your exchange, the wire shouldn't move. As far as the markings are not moving, you're one-to-one with your tech. So I don't need to look at my hands, my tech doesn't need to look at my hands, you essentially focus on the endo view.
You said you're using the tip for sphincterotomy, ma'am. But usually they have a sheet, no, ma'am, which covers about 1/3. So could you put 2/3 of your sphincterotomy?
You can, you can. So that's a different tone.
Okay.
Which has the protective sheath.
Yeah.
The main thing is you want to use your cutting wire, and you want to have it at the apex of the cut. So you want to have that contact and tension of the wire with your sphincter to cut it. The main thing is you don't want to have too much tension because that's where you get zipper cuts. So you don't want to bunch up the tissue and then start cutting. You want to cut layer by layer like we did, exposing the ampulla, again reassessing how big it is. Did you get the sphincter completely? Because you don't want to do a partial cut. And once you get the sphincter, you'll see this gush of bile.
You want to continue? No, no.
So we're just putting the balloon now to get a better delineation of our stricture. We have two sizes of the metal stents in the room. We have the 10 millimeter by the 80 millimeters and the 10 millimeter by 60. We're going to decide on the length of the stent. The first number in the stent is always the diameter. The second number is the length. So we're going to traction. No. The stone extraction balloon for the cholangiogram. Yeah. Looks like we're talking too much. The mic is getting tired. All right, perfect. So we'll go back up, fluoro again. Going back up, Going back up. And this is also a good litmus test to see if your catheter goes through the stricture, then your sheath of your metal stent will go through. If your balloon doesn't go, then you may have to dilate the stricture to get even the sheath of the stent across. We'll switch the picture in picture.
So for dilating, what dilator generally?
4 millimeter should be
enough. We'll start from.
Yeah, to start off. All right, so fluoro please. Okay, going up, perfect. And you can see there's almost white bile coming out. So there's a lot of resistance right here. Perfect. So we will now inject here. Yeah. Fluoro please.
Screen once.
All right. Perfect. Yeah, inflate the balloon here. Perfect. And we'll inject here. So we're delineating the stricture at this point. So we may just need the 80. Actually, the stricture is pretty high up, but we're also magged in. Yeah. Let's inject. Fluoro, please. Perfect. All right. So there is our stricture coming down, coming down. So at this point, our stricture is almost in the proximal CBD. It's just below the common hepatic. Fluoro, please. Keep injecting, coming down. Keep the wire up. And I'm doing a sweep just to make sure we don't have any other strictures. So now the question is, we put the Can we mag out for a second? Reduce the mag. All right. No, not a problem.
We can get it from there.
Fluoro, please.
One time screen once.
All right. Perfect. So go down on the balloon. Down on the balloon. Deflate. Yeah, perfect. All right. So we'll.
While trolling the balloon, ma'am, like.
Right.
Talking of that scope can help to see that proper picture if any stone inside of it or not.
Right. So the maneuver you want is as my balloon is coming down, if you could give me a small balloon here. So as you see my hands,
just kindly
as you
focus
pull
on the hand
down,
also once.
You're pulling the balloon down, and then I hold the shaft. You torque right a little, and the balloon comes out. So it's a very gentle maneuver of just torquing right, scope rightwards, and you give that downward vector for the balloon to come out. So we'll deflate now, and we can put the 10 by 80. Yeah. So exchanging. Again now coming to metal stents. Now this patient is not a surgical candidate. We are using the metal stent as destination therapy. When in doubt, and you don't have a proven malignancy, you could consider putting a fully covered stent, and that gives you the ability to go in and change it out.
But ma'am, one more doubt regarding that. If the patient is having gallbladder inside and
that's a
putting
great question.
Fully covered same, so like
Right.
what could be the percentage of cholecystitis in that patient? Sir?
Right. So I personally try to use the uncovered as far as possible. Again, there are reports of acute cholecystitis when the gallbladder is in situ and you put the fully covered stent with the cystic duct getting closed off. You could consider putting a shorter stent in that cases, so you kind of avoid the cystic opening. And sometimes, and it's not that every patient you're going to put a fully covered stent, they're going to land up with cholecystitis. So you pick your the true indication. So I have used it in patients that have tumor ingrowths into stents, and you ablate the tumor, then you put the fully covered inside the uncovered that was placed earlier. I also personally use it for remodeling of benign structures.
And ma'am, what's your take on partially covered SEMS, ma'am? Like, will and compared to that fully covered or
No,
uncovered ones?
I personally either you're doing the fully covered or you're doing the uncovered. Because again, the main goal with the covering is you're trying to minimize tumor ingrowth. However, with the coating, it does increase your risk of stent migration also. So we're using the 10 millimeter by 80 millimeter wall flex stent.
Can you focus here? That stent we're using here. Can you focus here?
Lost our endo view.
I think you should open and show it. No, I think it's better. Already loaded there. Okay, okay, okay.
Yeah.
Yeah, it's been loaded there.
Yeah, so that's the stent we just loaded.
So just
Trying
focus
to-
it on. That what diameter and length we're using as per the depending on the stricture length.
Yeah, I'll just put the air on high for now since. All right, so this is the key moment because the catheter of the stent is pretty stiff. You want to be as close to the ampulla as possible because you saw how it wanted to push the wire down and out. So you want to be as close to the ampulla as possible to not let the catheter do that and to give that upward vector for the sheath to get into the duct. So we've used a longer stent in this case because the stricture is a little higher up. Fluoro, please. All right, perfect. So we'll get our wire a little more situated. Awesome. And you can see the tip of our stent that's now traversed the tumor. And we have, this stent also foreshortens a bit. All right, so we'll slowly start our deployment. And we'll keep the fluoro live. Yep. Keep the fluoro live.
Continue.
Yeah. 1 second. The stent is a bit long, but we'll make it work. All right, perfect. Yeah.
Continue, Flora.
Yep. Perfect. We will, just 1 second. Stop.
So just before deployment, man,
Yeah.
like how far should we go and all, like should be our cutoff mark and all, just kindly brief on it.
Right. So as you can see, we saw the top marker. So that's the proximal end of your stent. And now this is your point of no return is at the bottom of the screen. This stent, as I said, does foreshorten a bit. So we're trying to situate it here. All right. So we'll continue deploying slowly. Yep.
So from endo view, that yellow marker should help us to.
Right. So our yellow marker is still inside the scope. Can we recapture? Okay. Fluoro? All right. Perfect. So, long structure. Yeah, I think we should. Okay, perfect. All right. Yeah. Okay. Fluoro, please. Perfect. Okay, we'll do an exchange here.
Yeah. So we are changing a stent here, ma'am.
Yeah, the 80 is a bit too long. Again, our fluoro is really magged in.
So we are
So we're going to
60 here.
switch to a 60. So again, the key is you want to keep making sure your wire is good. So you have the radio opaque marker in your stent at the proximal end of the stent. There is a point of no return. That's why we recaptured it before the point of no return. So if you feel there is something wrong, it doesn't look right, that is your window. So we recaptured, we're going to switch to the proper length stent, which would sit right below the hilum.
Below the hilum. Yeah.
Right. Right, right. So we have our Boston Sci colleagues who said it's only possible with the Boston Scientific stent. Before the point of no return, you can recapture it and we could regroup and, put the, because uncovered stents, again, once you place it, the tumor grows in, you can't
Difficult,
remove
you can't.
these. Perfect. All right, so we're back in the groove. Stents going in. Again, moment of truth. We want to stay as close to the ampulla as possible. Fluoro, please. Okay. Can I get a gauze? So we're losing a little bit of the air. So, fluoro, please.
Screen once.
Just trying to make sure we don't lose our position. Can we switch the endo view? No, keep the fluoro also, but we're not able to insufflate. Perfect. Again, we're just trying to make sure we don't lose our position. Very important. There is fluoro, please. No, leave the endo big for now. There we are.
So, ma'am, while doing that procedure, both endoview and fluoroview simultaneously will
Are
have
very
to.
important. And that's why, the air is acting up right now. We're not getting our view. Fluoro, please.
One time screen.
Can we give some more Buscopan? Maybe that'll help.
One more, one ample more.
All right, so fluoro, please.
One time screen.
All right, and we're above the stricture. We're seeing our yellow mark now. Yeah, can you just hmm? Yeah. Yeah, change the knob. Having some technical issues with the air. Okay, life is much better now when the air works. All right. So again, real life troubleshooting, when things don't work, try to fix it, change something, change the button, but you need to have the view and you need to see what you are doing. So till you don't see it,
Don't go for it.
Don't go for it.
It's a dictum. Thank you, ma'am.
Yep. All right. So now we are ready to deploy. Perfect. All right. Fluoro will remain live. You're seeing our point of no return. You're seeing our yellow sheath. That's the end of the stand. And we'll start to deploy. We'll go slow. Yep. Can we make the fluoro bigger, please? Perfect. All right. We'll keep our eyes on the endo view. We'll keep our air working and we'll keep deploying slowly. Perfect. Keep deploying. Keep deploying. 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 Good. Keep going. Keep deploying. Keep deploying. Keep deploying.
Yeah, you can see it from there nicely, ma'am.
Perfect. You want about 3 to 4 diamonds out. We have that now. Perfect. We're reaching almost the point of no return. So you can see the marker that's moving. That's the
Yes.
sheath coming back. The bottom marker is the point of no return and the other marker is the end of the stand.
Yes.
Perfect. We'll keep going. Yes. We'll go ahead and deploy. Perfect. Perfect. You want to hold a little bit of traction because you don't want the stent to shoot
Don't want to
inside.
yeah.
So this is where you keep your patience. Perfect.
Nicely said, ma'am.
Perfect. All right. Again, you want to give it a few seconds to expand. If you yank it out,
It will come out.
you can dislodge
Chance
the
of
stent.
dislodge it.
So we will slowly pull it out. Fluoro, please. All right. And there
What
we
would
are.
be your take on it, like putting another stent into that same, like would it be beneficial or like?
No, we've traversed the structure. We're getting nice drainage. You're already seeing air on the other side, so you have good communication. But yes, that's why you don't pull the wire. You first remove the sheet. So if you need to put another stent in, you have your access. Because again, getting the wire through the sheath and the mesh of the stent may be difficult. All right.
Nicely, ma'am. It's perfectly,
you.
perfectly been done.
Thank you. All right. Perfect. Thank you.
Sunil sir, your mic on, sir. You are on live.
I'm on live, huh?
Yes, sir.
Yeah, okay. So this is a 70-year-old female patient, chronic liver disease secondary to hepatitis C. So here what we can demonstrate, this is a large GOV1. So there are going to be a few experts, so we could even decide whether we need to do glue for this large GOV1. And then there are large esophageal varices which will proceed with the banding, the regular multi-band ligator. So as we demonstrate the glue therapy for this GOV1, we'll tell you the steps on how it needs to be done, the precautions that needs to be taken. So always whenever we put in the glue needle, the scope needs to be in the straight position. If it's in the retroflex position, you will not be able to put your accessories through the working channel. So always make sure the scope is in a forward view or straight position as we bring out the accessory. So what we usually use for the glue therapy is a 21 gauge needle. So we have Dr. Triptesh Kotari with us. So I just wanted to know whether we need to do a glue therapy for this. It's a large GOV1, sir. Whether it could be left alone or do we need to inject? This is HC.
This is a straightforward one. We should
Definitely inject, sir. Would we be able to assess how much, how much of glue would be required?
So normally once we inject and based on the tension that we put with the catheter, we'll be able to assess how much you want to inject more or not.
So
is the voice coming?
So I've straightened my scope just to push in the accessory.
So Vivek, what are your steps? What are you planning to do in this?
Yeah, so first is what we do is I would like to inject into the base of this large GOV1, and as we inject, and always before we inject we have to have a mock run just to see that we are our position is stable, and then before we jab or before we prick into the varix, they usually inject saline through the catheter to see that the saline doesn't spill out from the opposite end, and you show that your needle is within the varix. Then followed by the glue. Usually we do not exceed 2 ml during one session of glue therapy, but at sometimes just maybe if the patient is not affordable, you could even go up to 3 ml.
Right. So basically that point what you said about jabbing and with your catheter into the varix is just because right now once you do the jab once more, just to show it to our audience, a gentle tap, it's soft, it's like a pillow sign.
Yes.
Compared to when we inject the glue and we jab our catheter again, it will be really hard, suggestive that the glue has been well infiltrated into the varices, and that will be helpful for controlling the bleed.
So and I would like to know, sir, would you like to inject in the center or just would you like to do it
I would
lower?
I would go straight in the center, to be
Center.
honest, over there,
Okay.
and because there is a good bulge Ravi, you want to add something to this?
No, I totally agree. I think when it comes to glue injection, the key point is having a stable position and then having a dry run like what you mentioned, because you don't want to puncture and then think through what you're going to do, because then you're looking for a disaster. It's going to bleed badly, you're going to lose your visibility. So always pay attention to having a very stable position, and then ensure that your assistant has prepared all the necessary things that she has to do, be it neat glue, your saline, all pre-filled. And then when you're all ready, then you decide to poke and then jab it. So in terms of where to poke, whether it is center or periphery, again it depends on how stable your position is. You can inject in the most bulkiest area, which is the center here, and then the volume you decide based on whether the varix is completely abradated or not, based on the softness.
Okay, but you could inject any quantity of glue, sir, even during with just
Let's start with the first injection of 2 ml.
2 ml.
Because it will be mixed with the interview.
Okay, sure, sir. Okay,
So, do you use neat glue or do you use lipoidal in your combination?
So what we use is the endocryl, N-butyl cyanoacrylate. I think there is less lipoidal compared to what used to be done previously. So the chance of embolization with this, they say, is lesser.
So you don't mix it with
No, we don't have to. It's already there mixed with the glue.
Right.
Yeah.
So we perform a mix at our place where it's a combination of lipoidal and dihydroxyl. So that way it's important at that point that once you make the glue and you start injecting, you have to take into consideration the dead space in the catheter as well, which is the 1 ml. So once you inject the glue, make sure that even if nothing is coming out, you still make sure that there is air injection going in, so that whatever is remaining in the dead space gets injected in the glue, in the varix, in the last.
So what at times maybe when you're starting off glue therapy, you could even lock the small wheel, so you could get your position doesn't move while you do the procedure. So like as we all decided, planning to inject into the center of the varix. Do you all lock the small wheel or it's not required?
It's based on the position, how stable you are, as Ravi said. But the goal here is to that make sure that you are stationed and you are not moving around too much. Because if we happen to have any bleed during the procedure, then the visibility is a big issue.
Sure. So does this look like a good position?
I would go a little bit, I will pull the scope a little bit so I can go in the center a bit. Yeah, there.
Okay.
Where exactly there is a divot, there is a scar type of thing. Yeah, that's a good spot.
I mean, regarding that GOV, in a particular this case, sir, like what would be both of your take on regarding that managing that is large esophageal varices, which is that patient is having that will take care of that GOV1, or that separately you have to put glue for GOV1, or what size of GOV1 like helps us to determine that key, apart from that banding, that extra glue has to be required for that GOV1.
So in this case, you can see this is GOV1. So what we will do, the extension on the stomach side is more. So you would want to treat the gastric portion of the varix here, where you can inject your glue and you obliterate this. The next step which you have to do is you have to either plan it or do it in the same sitting, or you can plan it where you obliterate the esophageal varices. You inject this part and then you don't do anything to the esophageal varices. In a couple of weeks they are going to come with esophageal variceal bleeding. So you anticipate that you want to obliterate the gastric part first, maybe 4 days or 5 days later go in again, you can ban the esophageal varices. So here you have to eradicate both. You cannot just treat one and leave the other thing behind. You can, if let's say you are going to do the gastric variceal obliteration now and you are confident that you have obliterated everything, there is no bleeding, your field is clear, in the same sitting you can band it too.
Okay, so shall I proceed?
Yeah, please go ahead.
Yeah.
But the order of treatment would be first you target the gastric, followed by that you go to the esophageal.
One more regarding thing that if the patient is having like large GOV varices or that small GOV varices or medium sized GOV varices, but the patient is having large esophageal varices with RCAs. Like we can see that cherry red spots or hemocystic spot there. So should we tackle that GOV one? I mean that the gastric varices first or esophageal varices first? Like what should be tackled first in that cases? Like it's a medium sized gastric varices without any like recent sign of hemorrhage or it's IgV1 or could be GOV2 like in that particular cases like but there is a no recent sign of hemorrhage or like any fibrin plaque or there but in a large esophageal varices is having that large cherry red spots and hemocystic spot in such cases which one to be tackled first.
So if I were to get your question right, if the patient has esophageal varices and gastric varices, but the gastric varices is small, but the esophageal varices is big, then in that case you treat the esophageal varices first. You can go and treat the gastric varices later because you have to understand the risk and benefit. If the gastric varices is small with no sign of recent bleeding, no stigma, then you can leave it alone to be treated later. And if your esophageal varices is big, you treat the esophageal varices. In this case, the gastric varices here looks at least it's 3-4 ml in volume and it looks big. So you can treat the gastric varices here followed by esophageal varices.
Thank you, sir.
Thank you, Sunil sir. We will move on the next letter, sir. Thank you.
Yeah, here start.
Morgan sir, your mic on, sir. You are on live.
Yeah, so welcome to the OT, and at the outset I thank Dr. VGM, Madhura, Vamsi for calling us, and I am surrounded by some of the greats. Amol is here, and Dr. Praveer Rai, who is my dear friend. So this patient has vomiting, presented with vomiting since last 2 years, and there was a evaluation done for gastric emptying times. I think that was prolonged, and moreover the EGG was also showing of pyloric obstruction, functional pyloric obstruction, which is important for us to choose the patient for pyloric directed therapies. Gastroparesis is a multifactorial disorder, and you cannot just do pyloric directed therapy. So the pyloric directed therapy can be either a Botox or anything which works on pylorus to reduce the pyloric resistance, either by putting a stent, balloon dilatation, laparoscopic pyloromyotomy, or even Botox. So these can work only when the pyloric the contribution from the pyloric spasm is more. If there is complete gastric atony, then even reducing the resistance at pylorus may not work. So it's important for us to determine which patient will benefit by pyloric directed therapy, and that's a $1 million question now in the endoscopy fraternity. Anybody who can tell. So people have used many things, including the prior treatment with Botox or stent. If they respond to that, that will automatically respond to the G-poem. And here I can see they have injected the Botox, and the patient had good relief. And I can see one scar there which may be of problem, but we'll try to negotiate. So my aim is to cut this pyloric muscle underneath the mucosa. So I have to go from the tunnel around 4 to 5 centimeter proximal to the pylorus and reach underneath the mucosa to this ring and cut this ring so that there is a reduction in the resistance at the pylorus. So let's start the procedure. So all the steps will remain same as we do in poem. In poem we tend to go into the stomach, but here we will not go into the duodenum. So that is the difference. So we'll start. Kannan is with me. Kannan is working with Professor VGM for last 20 years. So he's extremely experienced, and I'm really glad to have him with him. So now we'll inject. So needle is out, and no, what? Which needle is this? Okay, so we'll inject. So you can see nice elevation. Keep on injecting. So I inject slightly more as compared to the esophagus, because the gastric mucosa is much more thicker. So you can see, I can see the pylorus right in front of me, and I will make an incision now onto the most prominent part of this, because we are not supposed to do a very long myotomy in pylorus. It's just 1 centimeter. So tunnel, even if it is short, it's okay, because we are not supposed to do a pretty long myotomy. So I am using this RB knife. So I'll push the cap so that needle out, please. So I am using this I-type knife, and I will make an incision now. So I make a distal to proximal incision, and then push my cap inside to avert that out. And I can see there is slightly, so I'll make slightly more like this, and then do some dissection. The good thing about RB knife is that I have a lot of water available, so I can do dissection. Precise sect is not on. Precise sect. I use precise sect 4.5 setting. Okay, so this is for the dissection. So as soon as you arrive at the incision site, I start. Why it's not working? Why? Nothing is going. Now it's working. So you can see I am dissecting.
So Dr. Mohan, what is the position of the patient that you keep?
So left lateral is the position. So you can see the precise sect allow you to dissect onto the apex, and even if there are vessels, there is no problem. So whole aim is to get into the tunnel. To get into the tunnel, you need to have a proper dissection at the entry site, as we see in poem also. Unless you have that, you will keep on enlarging. See that now it's almost, I am inside that, and that you are.
Dr. Mohan, what's the usual length of this incision?
So length of incision should be such that the scope enters very easily. So the scope diameter is around 11 mm, or the cap diameter will be around 12-13 mm. So I'll make 1.5 times. So that will be around 1.5 to 2 centimeters. Okay. So you can see now I am entering. So that's the most difficult part. And once you have entered, then you have to see the SM3 layer. So now we'll decide about where is SM3 layer. So I'll gradually expose the muscle layer of the stomach. Well, that's the muscle layer of the stomach. You can see that's the gastric muscle layer.
So, Dr. Mohan, this SM3 stands for submucosa third layer.
The deepest part of the submucosa.
So you want to be as near to the muscle as possible.
Yeah. Out. Yes, that's because we are supposed to cut the muscle, supposed to go along the muscle toward. That can be a guide for us to reach to the. And you can see the second thing about SM3 layer is, you can see thick vessels. They are on top. So the
vessel will start from the muscle layer and they come up and start branching. So if you dissect in this layer, you will have more vessels. While if you dissect in SM3 layers, there will be one stem of vessel, but you will not deal with the branching. So then you can push the vessels up like this and keep on doing the dissection. So that's the advantage of SM3 layer 1. It can act as a guide for us to reach to the destination, that is pylorus, because we'll keep on following uh, the circular fibers. And then second is we'll get rid of these vessels. So there was some air into the channel, so that's why these bubbles have come.
So SM3 would be more subjective, in the sense that you want to be sure of the layer that is nearest to the muscle, that you call SM3.
That's a you can see now that so SM3 is layer nothing but a layer closest to the, there is no proper description. It's actually histological thing, where they divide the SM layers into superficial, but endoscope is used for just try to copy that so that anything above the muscle layer is known as SM3. So you can see now we are going towards this, and I'm encountering the, you can see the vessel which is coming from here onto the right and then branching. So I'm only, if I coagulate this, I'll take care of whole vessel. So that's the advantage. Because if there is some bleeding in the tunnel, that causes lot of smearing of blood, and then you will lose the planes. So best is to, so I'm trying to dissect as near as me, so that I can change some part of my track to and keep on going without coagulating this vessel. I don't.
So here you would like to come out and see whether you are moving to the right direction, or you are convinced based on this muscle that you are going in the right direction?
Almost convinced, but yet in the stomach you need to have, as compared to the esophagus, much more time you have to come out and check.
Okay. And even for this large vessel, you don't think you need a coag grasper here?
No, we'll need for this one. See that this is the artery. So I'm just trying to avoid that.
Okay.
But in stomach, always use coag grasper because they are high pressure vessels. I don't use the knife. You can see this is a big artery. And it will take a lot of time to coagulate. If you bleed and whole of the cavity will be filled with stomach, and then your precise dissection will suffer.
So this much vascular pattern is normal, or you think there is increased vascularity here?
No, it's normal. In stomach there is a lot of big vessels, always. See that's a pulsating vessel. So first we'll take care of this. Open. That's also an artery. You can see that's a pulsating. So you have to make it slightly parallel to the muscle. Turn right. Yeah. This is known as off spin. So off spin and leg spin. You play cricket? Coag grasper, you can make it soft coagulation. Soft coagulation, 70 watt. Keep on doing, keep. More. Stop. Okay. So now we are ready. Is the no Nessie, no? Okay. So this is the soft coagulation. Soft coagulation is slow, but it's quite deep. Force coagulation is fast and superficial. But is it working?
No, I don't think so.
Still? You see that?
Open. So I close. Okay, open. So that's how we coagulated it. And now we'll see this, because ultimately I think with the with my cap it will get injured. So you can see this, we are gradually moving towards right direction. Another 1 centimeter will be into the pyloric cavity.
Yes.
And this vessel I will block. Open. I'll hit right onto the, no, open. Unless I see, I don't do. So that's the way. Open. Can you leg spin? Leg spin. You are an off spin. No. Open. Okay. This one is okay. Close. Okay. Open. Close. Open. Open. Close. Open. So I block it at many places. Okay. So now it's okay. Better. So that's important to have a good hemostasis, even preemptive coagulation, because otherwise, if, as I repeatedly told, it's important to keep the clean vision. Close. So now, as you can see, we are reaching to the, so you have to follow this circular fiber and then you will reach to the destination. So that's important to dissect the muscle. Out. Knife out.
So, Dr. Mohan, the most common indication for GPOM is what etiology? It's idiopathic, diabetic.
No, so usually the if you see we have more number of diabetic gastroparesis, but more number of patient of diabetic gastroparesis does not qualify for GPOM, because most of them have less less pyloric problems. It is the post-operative patients which have the most, the commonly they have the etiology because of the pyloric issues. So in our series, it is the post-operative patient who responds well. But in Western series, in the gut paper, if you see, the most of they have all mixed etiologies. Even the patient who had diabetic gastroparesis have also responded well in their series. So I think that depends on the geographical area and institute policy, because they are all referral bias, because you are doing gastric poem in your region, so you'll get the, but your question is very important, because you cannot take all patients with gastroparesis for GPOM. You have to choose your patient very, very carefully. Otherwise, you do such procedure, invasive procedure, and there is no response. And then you have to difficult to explain the patient also sometime.
So diabetics in general have a poor response?
Poor response, yes.
So post-surgery, so what surgery in your series? Post which surgery?
Like post-esophagectomy, or even they have, I think post-esophagectomy is one of the common thing where vagus nerve injury happens,
Okay.
and then the patient will have pyloric spasm.
Okay.
And these patients respond to pyloric directed therapy more commonly. Quick grasper, please. So you can see there are many vessels, but we are taking our time. We are not hurrying up uh, to stop, to pre-coagulate them. So we'll keep the blade horizontally open. Yes. So I'll put this onto the bottom. Yes. Close. Soft coagulation. Soft coagulation. Confirm. Very good. Soft coagulation is very important, and you can see my quack grasper is attached to the muscle, but there is no visible, there is no mucosa involved here. So because the coagulation will travel down, it may burn the muscle where it is okay for me to burn the muscle, because ultimately the problem is with the muscle. I want to preserve the mucosa. So that is why I am not even seeing the mucosa. If somebody, suppose the vessel is here, if I burn, that can cause injury to the mucosa. So always do the coagulation once you are doing close. Once you are doing third space endoscopy, and decide whether the tunnel is being made for ESD, then your mucosa is diseased. Then you can coagulate more towards mucosa. While if your muscle is diseased, as happens in the muscular disorders like gastroparesis or in POEM, our muscle is diseased. So we want to remove the muscle. So even if you damage some muscle by coagulation, it's okay. Out. Needle out. Okay. So meanwhile, we'll go and out and see where we are. See that our tunnel is traveling down very nicely, and we are right on the track. See that it's only a matter of, I think we have reached here, and another few millimeter we will be inside. Is that okay, Pravir?
Yeah, absolutely. I think a very nice dissection and almost complete hemostasis.
Yeah.
So very important.
Okay, so out. Needle out. See, yeah. You can see now the vessel is getting cut. So now we are reaching to the, see that that's the vessel toward the mucosal side. So I'll give a small burst of the coagulation. That's it. So now we are reaching towards the pyloric ring.
So, Dr. Mohan, can we use TTJ knife here also?
Of course, yes. Any type of knife can be used. I will prefer to use a longer knife in the tunnels. So this is a longer knife, you can see. While if you use a dual J knife, it will be slightly difficult. And that's the pyloric ring, I think. We'll inject here. So we have to push the duodenal mucosa away. I have to expose this ring. That's the ring probably. Now we'll inject onto here. What happened? Huh? You have to concentrate here on. So we'll inject and then dissect. So we have to expose the pyloric ring. We'll keep on going out again because here we have to be very, very precise. I'm seeing vessel there. So I don't want to take any chance. I will catch this vessel by quark grasper. Until the exchange is being done, we'll go into the tunnel, out of the tunnel, into the stomach to see where we are. So that's our dissection, that's our, and then we have almost, see that I think we have reached here. I want more blue discoloration of the fluid so that once we come back from the duodenum we can see. So still lot has to be done. We have yet not. So can I have more darker fluid? Because see we are at the edge maybe. See this is our tunnel, that's our tunnel, and we are at the edge. We need to go slightly more. Can I have the grasper please now? Grasper.
So Dr. Mohan, are we able to see the pyloric ring?
Yeah, we'll see.
Right now
we are not.
Not, yeah. And from inside,
Open. Yes, open. Open. Watch needle. Close. Soft coagulation. Okay. So then we'll. Yes, Pravir, you are asking. I was.
Yeah. So from inside, can we be
open.
sure about the duodenal? We have reached the duodenal mucosa from
Yes,
inside.
we can.
We can.
We can. Yeah. So once that edge comes, I can see this is the edge. You can see that's the muscle layer. At that, it's ending here. Just make sure that there is no curve. Okay. So usually I don't take much more time in coagulating esophageal vessels. That's what I'm saying. You will not.
Yeah, but in stomach, I think vessels are bigger and
very
we need
big
to be very
and-
cautious.
Yeah. Out.
So have you ever encountered uncontrollable bleed during poem?
No.
No.
What happened? Okay, sometimes these sophisticated close. So we are now reaching there. Out. I think there is some problem with the knife now. Can I have TTG knife otherwise? It's not working?
TTJ knife.
It's not working maybe. There is some problem with the knife. It's got bent. Not coming out. Okay, so we'll change the knife because it's not coming out. I'll suck out the fluids, see the abdomen. Everything is okay. Give me TT.
He's bringing the knife? Yes, TTJ knife. Okay.
We're bringing the TTJ knife? Or it's working now? Let us see. Okay, I'll check. Close. Better to use one knife always because they are very costly knife. We have to be very, very cautious. Out. There is something coming out. No, it's not It has lost its function, I think.
Or if we have another hybrid knife.
No, no, hybrid nahi. TTJ de do. TTJ knife is also very good. The vessel. Give me the quack grasper by that time. There is a vessel there. What is it? TTJ. Huh? This is not TTJ. This is dual J. That vessel I need to coagulate. See that?
Yeah.
Quack grasper. TT knife is there, Sandeep? Open, open, open. Close. Soft coagulation. Huh? Open. Okay.
You can appreciate Dr. Mohan Ramchandran is a great poet. So he's doing a fantastic poem, but this is a G poem.
Yeah.
I have a question for you.
Yes, please tell
How
me.
do you know when to stop in G poem?
Okay, so that's
because
a very
you don't
good
want to cut
yeah.
the duodenal musculature.
Yeah. So that's why we are taking our time to make this dissection and then checking where we have reached. So once we reached into the duodenum and we suck out, we pull out, we see some discoloration of the back of the pyloric ring, which I am not seeing. So that means I have to go see that there is a
Yes.
discoloration right at the edge,
right
but
at the
not beyond.
Not beyond.
So I want to go and expose this pyloric ring first. So that's in my suggestion is the ring. You got the
So how do you differentiate Monji from the gastric musculature from the duodenal musculature? How do you?
no. So
what tricks?
there is no way we can go into the duodenum here. So only thing which we will see is a sharp edge of the pylorus, and that is our end point. We are not supposed to go into the duodenum.
Where it drops.
It drops, yeah. So out. So I think we have done with this knife. I think you don't because this knife is not working anymore. It's
You're
not
using
coming
what
out.
knife you're
So
using?
this is RB knife, but since it is with the curvature of the stomach, the scope is now in a very different curvature. It's not straight. So sometimes this knife, after some time,
Doesn't open up.
doesn't, huh? No, I want TTJ knife, Olympus TTJ knife. You have? Madura was using that type of knife. क्या है यार? This is TTJ. This is TTJ. Okay, so we'll inject. Inject. Yes. Out. Inject, please. Ah, that's very good.
perfect, stop. So I'll go very near to that and we'll dissect. All set? Cautery set? Precise sect or soft coagulation? Soft is soft, no. I want precise sect. 4.5. Okay. Okay, out. Yeah, that's the way it should be done.
So, Dr. Mohan, what's the advantage of this precise set?
Precise set is an intelligent current. Whenever there is a vessel, it will deliver the coagulation. And whenever there is a tough situation like a muscle or a fibrous tissue, it will deliver the current, the cutting current. So you can see now we have reached to the pyloric ring. So that's the pyloric ring. You can see the edge.
You can see the sort of circular muscle.
Yeah, that's the ending there. You can see that's the ending there. Inject here, inject. So we'll push the duodenal mucosa away. Inject, please. Stop.
Yeah, you can see the beautiful circular muscle fibers of the pyloric ring, and after that there is a sort of void.
Yeah, void.
You don't see anything. You see that?
Yeah.
That is where the duodenal.
So here, if you do too much of dissection, you will create a hole in the mucosa of the duodenum.
Duodenum, yes.
So here, inject, please. Okay. So now, so that's the end of our tunnel.
I think the spot where you're cutting is probably where it ends.
Yeah.
You can appreciate that that area so beautifully. You see the muscle fibers stop here, and then you see the flimsy submucosa over there.
So now, that's the now it's dipping down. It's the end of the muscle. So we cannot go inside.
That's a beautiful demonstration.
So now we'll go inside in the stomach and see the what I was talking about to know. So
he's just carefully pulling back
so
from the
that's
duodenal pulp. Yeah.
Boggy mucosa here. You can see
yes.
this.
Now you can see the blue color there.
See here, this one is the dipping down.
Correct.
So you cannot put the scope here.
Correct.
You can put the scope here and watch the muscle getting end here and the mucosa going down. So you can see this is the duodenal mucosa which has gone bluish. You can see the duodenal mucosa and then that's the pylorus. Can you see the difference?
Yeah, absolutely beautiful demonstration.
That's the blue mucosa of the duodenum and down into the stomach. So once you do a good submucosal dissection, you can still achieve the opening. You can see how big is the opening now. And we have gone 2-3 times into the duodenum, so that has also opened up. So now we are sure that we are, see that now? That's the duodenal mucosa dipping down.
Yeah, very well.
That's like
visible.
a curtain.
Yes.
So if you keep on dissecting like this, you will create a big hole in the duodenal mucosa.
So now what we'll do, Monji, once you start the myotomy, we'll switch to the other theatre
Inject,
where Amol is ready to demonstrate poem F.
Inject, please.
So, and then we'll show your procedure PIP maybe.
So you can see now this.
Sure. Beautiful demonstration.
So now here, now aim is to start cutting the muscle. So we'll cut the muscle like this, layer by layer. See that? That's a V which is being created. That's the broadening of that the pyloric ring. So the rim of pyloric ring is like this. We are making a V type of incision to loosen it.
Yeah, very nice, beautiful demonstration of the pyloric myotomy.
Yeah, so that's all duodenum there, duodenal mucosa, and this is the V being created
It will not be very deep and not very long. So maybe like this up till here.
So you cut only the circular muscle fibers or longitudinal also? Or
Also, everything.
everything. A total complete myotomy.
Yeah.
That's beautiful. It's just touching it and not doing anything. You can see the uh, flimsy serosal layer
Yeah.
outside. Yeah, a beautiful demo.
So that's the whole. That's the vessel
Yeah.
there. So
I think we can leave it
so
as
yeah.
such.
So
I don't
yes.
think we need
so-
to disturb.
Yeah. So see that's the cut end of the muscle.
Yeah.
This is the pyloric ring which has
Beautiful
been
demo.
opened up.
Beautiful. So how long do you cut the?
So that's enough, I think.
Myotomy. That's
That's
enough.
enough.
No?
Yeah, yeah.
Just the pyloric ring. We
That's
don't
the
need to do
no.
anything more. Very
So,
nice. See,
yeah.
beautiful.
So
You don't
that
need
will,
to
that
cut.
will see that now it will open up
Yeah,
like in it.
very well, very well. This patient will have a great relief.
Yeah.
And this electrogastrography showed positive GMAT score, gastric myoelectric activity test score of very high. It was in the plus. So usually it's in the minus. So electrogastrography is very useful in demonstrating which case will get benefited by GPOM or a pyloric balloon dilatation. We're going to show one more case. We're going to show the pyloric balloon dilatation also today. So after demonstrating the electrogastrography. And
Yeah.
also for viewers, we have a lecture from Professor Mark Knorr from Baltimore, United States on the role of electrogastrography in the dysmotility disorders. So where do we place it? How does it help? So beautiful lecture. So just watch out. So we'll just coming up.
So
through
that's
this
the muscle
program.
layer completely removed now. You can see the.
So just a 2 centimeter myotomy?
Yeah,
or
not
just
more
the
than
pyloric ring?
pyloric ring.
That's it.
That's
Just the
it.
pyloric ring he cuts and
Yeah.
doesn't touch the gastric musculature.
Yeah.
That's fabulous. Now we'll start clipping.
Clipping.
So
See
the
that there is
clipping,
no-
how do you start just like a poem clipping or?
Yeah,
you
I'll
want
use slightly broader clip first to
Or
approximate.
you want to use an endoloop with clips and then
that also
ligate
can
it?
be done, yeah, that
which,
can
which you
also.
want to, because you have a broad base here.
Yeah, it looks broad, but in fact, so you can see the muscle layer is totally intact here.
Yeah.
And then there's a huge flap wall.
Correct.
There is no damage to the muscle here, no damage to the mucosa here.
Absolutely.
It is right at the end where the muscle is deficient. So even if you do a proper approximation
Yeah.
without full airtight closure, everything seals off.
Perfect. That's very good. And we have a gastric musculature is
Yeah.
so thick.
So thick.
And it's one of the, what to say, one of the rarest forms of musculature in human body.
Yeah.
Because there are 3 layers,
Three
not
layers.
2 layers.
Yes, yes.
So because the retropulsion and propulsion movement, the antral mill function of the stomach is
Yes.
very important. So it's a one structure with 3 layers, 3 muscular layers in the muscularis propria. So God's creation is really amazing.
Yeah.
Just really wonderful. So as Mohanji starts his first clip and then opposes and shows that just the narrowing can be done by putting a large clip at the apex, then we'll move on to the other room where Amol is ready with the scope and waiting for a transmission. We'll continue showing the clipping PIP.
Open. Yeah.
What clip are you using?
So this is resolution 360.
Yeah.
From Boston.
Okay.
So can you move? Yeah. Open. Yes. Open, please. Very nice.
So it's a rotatable clip.
Rotatable.
And it just very faithfully stops. Some of these clips keep moving,
Yeah. So the first clip should be right at the apex. Suction is the most important. Close. See that? Close. Yeah. So you saw that how nicely
Yeah,
the
beautiful
so,
opposition.
Yeah. So that
So-
tenting is important. So first clip
Switch.
will create a tent for you, which you needs to like a zipper closure. You need if you see right in the proximally, it looks so broad, and you are frightened. So whether it will get closed or not, but if you do proper suctioning and first good clip application, your problem will be solved.
Very nice. We have amazing expert who we're going to see in action, Professor Praveer Rai, a great human being and a great professor and very skilled in endo ultrasound. He's going to demonstrate fantastic cases for you.
Close.
So over to Professor Praveer to continue.
Yeah. Thank you, sir.
So it's almost closed by 2 clips. One more, 2 more.
So second clip is also resolution clip?
Yeah, yeah.
Okay. So did you ever require to close this with loop and clips?
Yes, yes, many times.
Many times?
Yeah, yeah, because sometimes these are, the gastric mucosa is very tough and it does not
Friends,
approximate
we're
with
going
the
to
clips
see another.
open. So I'll
We're going to
push the
see
first
another
clip with
exciting
the
procedure here.
cap,
We
expose
saw
the cut
a lot of
margins.
third space procedures. A regular poem happening. Madhura demonstrated this morning. Dr. Madhura demonstrated a regular poem this morning. We saw just now a G poem being demonstrated by Dr. Mohan Ramchandani. Now we're going to see a poem F. So, like some of these patients after poem, if can develop reflux. So to prevent reflux, you do a fundoplication also using endoscope. And to demonstrate this, there is none other than one of our heroes of our nation, Dr. Amol Bapai, who does a lot of these interventions. And being a surgeon to start with, I think he has the resilience to stand and do for hours together with the same precision without becoming tired. I've appreciated the duodenal neuroendocrine tumors endoscopic submucosal dissection. Beautifully done. It might have taken long time for him to complete, but with so much of precision. So surgeons are always good, and he first demonstration I called Dr. Amol somewhere 21 years back to demonstrate in one of those endoscopy workshops that I organized. So Amol was kind enough to come and demonstrate, and now 21 years back, later, I'm so excited. We're going to see a fantastic procedure now, and ably assisted by the blossomed endotherapist, Dr. Vamshi Murthy. He was Dr. Amol's disciple also, so in his team. So now they both are going to team up. And he will explain what are all the accessories that you need here, because you need so much of a very elaborate setup here. 2 processors, 2 endoscopes, 2 carbon dioxide insufflators, and what more. So over to Dr. Amol for his demonstration of this poem F.
Thank you, Dr. VGM. Am I audible there?
Yes, sir.
Yeah, okay. So a big congratulations to Dr. VGM.
Yes, sir. Go ahead, sir.
Yeah. A big congratulations to Dr. VGM and his team, Vamsi, Madhura, and Mitra, and everybody over here. And always a pleasure to be back in Coimbatore after 21 years, as Dr. VGM rightly said. And at this fantastic setup. And great meeting, great cases. And this is again a new procedure, a relatively new procedure that we've started doing last 4 or 5 years now. And the data really looks promising, so we'll walk you through this procedure as we go along. So yeah, so Dr. VGM just updated me that there are 550 viewers on the 690 viewers as of now on the channel watching this live. So that is fantastic. That's a wonderful, really a global conference that is happening over here and workshop. So it's great. So you saw the history of this patient. She's a young girl with achalasia, type 2 achalasia, and we are going to be performing a poem in this patient. But as we know, up to 25 to 30% of patients after poem can develop reflux. We still don't know which are the patients who develop reflux vis-a-vis who do not. But then, as our surgeons and surgical colleagues always argue with us, the laparoscopic Heller myotomy is always accompanied with a fundoplication. So why not try and do an endoscopic fundoplication along with your poem procedure? And that is what Professor Inouye described about 4 years ago in 2019, and we were the second center across the world to perform the procedure, and we published also later our experience and the subsequent experience in the last 3 years, 3 or 4 years. We've got 3-year follow-up now, and that is really impressive. So you've seen what Dr. Madhura demonstrated the standard poem procedure, and she performed a posterior poem. Now the posterior poem is one of the standard ways to do a perform a poem, and it's a little bit easier approach to perform the poem. But when we are performing the poem with a fundoplication, we have to go anteriorly. So we have to perform an anterior poem, because the principle is that after we perform the myotomy, we enter into the peritoneal space by opening the peritoneum overlying the anterior wall of the stomach. When we go beyond the myotomy onto the gastric anterior wall, and once we enter into the peritoneal cavity, we grab the fundus and we pull it along, and we plicate it or fix it to inside the tunnel, so as to create a partial wrap and partial anterior wrap, which is very similar. You will see that very similar to that what you can get after a door fundoplication, a surgical door fundoplication. So that is what it looks like. So I have Vamsi over here with me to assist me, and of course the very able Ranjani, who has been the technician, and she assists for all the advanced endoscopy procedures at Dr. VGM's hospital over here. So I'm really privileged to have all these stalwarts along with me. And of course I can see Dr. Shivangi over here. So she is here, and Dr. Praveer is here, and that's really a great pleasure to have everybody over here. So let us start off, and the first thing we do is we measure the gastroesophageal junction. So the G junction is at 32. She's a small girl, and this is a 38. So this is a 38, and so we pull back now, and she has type 2 achalasia. So approximately a 4 or 5 centimeter myotomy on the esophageal side and 2 centimeter on the gastric side is what we are planning to do. We don't perform too long a myotomy on the esophageal side. So if you are performing a 4 or 5 centimeter myotomy, my scope presently is at around 31-32 centimeters, and this is the place where I will start the mucosal incision. So a 6 centimeter, the mucosal incision would be about 6 centimeters proximal. Now the second thing, I need to make sure that I have to go dead anterior at 12 o'clock and not at 6 o'clock. So what I am going to do is I am going to squirt a little bit of water, and we can see that the patient is in a supine position, and the water is pooling at 6 o'clock. That means the 12 o'clock on my screen is the 12 o'clock in the patient, and that is anterior. So now I will use the needle to make a submucosal bleb, and then we will start off with the procedure, and I will also show you and tell you about what additional instruments and accessories that we require as we go along. But let's start off with the poem procedure first. What do you think, Vamsi?
Yes, sir.
And then we will probably take things along as we go. Now one of the challenges whenever we are performing the initial mucosal incision is sometimes our needle or our incision hits a submucosal vessel. And with the X1 technology, we have the RDI technology, which can enable us to help to identify the submucosal vessels. So I'm just switching on the RDI technology, and you can see a reasonably large vessel over here at 12 o'clock. So what I'm going to try and do is, I'm going to go a little bit to the side of that so that I don't hit that vessel with my needle. Otherwise it causes irritant bleeding, and that makes things a little bit difficult. So give me the needle out, and you should start injecting as I tell you. Okay, start injecting, and I will poke inside, penetrate. Okay, and I pull back. Okay. Another 5 to 6 ml. Yeah, enough. Okay, needle back. Okay, let's see. I think that is good. So now we will take the triangular tip knife, the TTJ knife or the TT knife with the jet function. That is what I prefer normally. Entry very easy. See, when you are doing an anterior poem, entry is relatively easier as compared to when you are doing a posterior poem. And closure is a little bit more tricky with an anterior poem, but it is easier with the posterior poem. Otherwise, most of the things are quite similar. You don't need to do anything much about it. So give me the knife. Okay. Now you should watch the tip of my knife. It is very close to the scope tip because I don't want it to be too much outside because then the control becomes difficult. So what I'm going to do is I'm going to start with the cutting current, the endocut Q, effect 2, and I engage and swing my knife downwards. Okay, back, middle back. So we have incised, but we probably not incised fully. The muscularis mucosa is still intact. Give me the knife again. Sometimes that is quite thickened, and that can make things a little bit. Okay, middle back. Okay, needle. Mucosa is quite thickened, so I am going to increase the incision just by a little bit. Okay, and now we will undermine. Keep the needle out. Now, what is important is to undermine the edges. Cut in the submucosa and come from the apex backwards. And I am using the precise sect mode over here on the YO3, and which is very useful to cut, control these small bleeds.
So given a chance, you suggest to do posterior poem or anterior poem?
If you are not doing a fundoplication, then do a posterior poem so that you can go in later anteriorly if the need be. Back, needle back, and inject a little bit through this. So you should always, if you are doing singularly a poem, always do a posterior. Anterior poem you should reserve only if you are doing a fundoplication because you don't want to, traumatize the anterior, area, because if you have to go anterior later to perform a fundoplication, give me the knife. Yeah, you should keep that area virgin.
So recently there was a publication from AIG. It is an accepted publication. We are all waiting for it to get
the true reflux rates.
True reflex after posterior poem and anterior poem.
Yeah, so Mohan will correct me if I am wrong, but their study also, I saw the results, and they have also reported around 25 to 30%, reflux rates after poem, true reflux rates. So that is what the global results kind of this thing. If you look at only pH studies, then sometimes the reflux rates are even higher. Overestimated. But the true rates are somewhere in the range of 25 to 30%. Most studies have confirmed that. Knife. Yeah. Back. Back. So you can see the circular muscle fibers over here.
Yes.
Knife. Yeah. Little back.
So this patient is thin, but the submucosa is thick.
It's quite thick. Patient is thin, but the submucosa is quite fibrotic.
Yes.
Surprising. I never expected that, but probably
Long standing.
long standing. It's still a little bit tricky to enter.
Yes.
What I'm going to do is I'm going to inject a little bit over here. Inject. Okay. Because that gives you the cushion for you to make your entry. And then let's see if you can enter now.
So we are happy to have the innovator of Prem doing this procedure with us. Dr. Amul Bapai was the first person to introduce perrectal endoscopic myotomy
Give me the knife.
for short segment hair springs.
Yeah, that is another procedure which is very close to my heart. And hopefully it will be
So
picked up.
can we call all these procedures as extreme endoscopist? Extreme endoscopy.
I don't think they are extreme. See, it depends, because when you call any procedure extreme, it has a negative connotation to it. So it's not true. Any procedure in the right indication for the right indication is actually
Or high-end endoscopy.
Okay, inject here. So
Lot
you can,
of fibrosis.
yeah, you can see there is tremendous amount of fibrosis over here, which is making my entry quite difficult. Give me the knife. Now probably.
Now we
hopefully.
came into the
Now we are.
submucosal
I had
space.
to literally shave it off from the muscle. You can see the muscle is a little bit shaved out. That's okay. We're going to do a myotomy. Give me the knife now. Yeah. Now, as Madhura must have told earlier, I came a little bit late on that case, that while we are performing the submucosal tunneling, you have to be very careful about not over insufflating. Now, this is a small girl, and gas related barotrauma can happen very quickly in these patients. So, we have to use low CO2 flow and also have one eye on the end tidal CO2 on the boils machine over here, so that the patient's EtCO2 should not rise suddenly beyond a certain limit. At our unit, we usually keep 40 as the first cutoff, and then subsequently, if it goes up beyond 50, then we can sometimes have to stop the procedure and hyperventilate the patient for some time before we can continue the procedure again. The other thing is very important is to remain very close to the circular muscle layer and keep injecting in and making sure that your submucosa is blue, and this pale blue color is the correct stain, shade of blue that we like. Inject.
So as we can see, sir is always directing the axillary towards the muscle and not towards the mucosa.
Yes. Yeah, that is very important, because inadvertently if your knife touches the mucosa, it can burn a hole through the mucosa, and then you have to close it. Give me the knife.
And they can show us how nicely sir is literally shaving from left to right.
Yeah. Maybe you can show me the extra, show my hand movements.
Hand movements. How sir is easily trying to go from the left to the right and making tunneling look very, very simple and easy.
So one important trick when we are doing third space endoscopy as compared to other types of advanced endoscopic procedures like ERCP or EUS is we have to unlearn our usual tendency to pull and push on the instrument. So you can see over here that I am hardly touching my instrument or my knife at the suction channel or this biopsy channel, this thing, and I am only controlling the shaft and the wheels of the scope, and I am directing the knife tip only towards this. So the knife tip actually becomes an extension of my fingers, my hand, and that is the way I can control it in a much better manner. Inject. There is dense fibrosis here.
Yes, sir.
Because of that, we are sometimes leaving a little bit of submucosa over here, but behind we try not to do that as much as possible because otherwise you can sometimes lose direction within the tunnel. You have to keep watching the fibers. Give me the knife.
We kept the tough case for the big man.
No worries. It's not. It's just it has to be a little bit more meticulous and patiently you have to do it. That's all. Not that it's impossible or anything of that sort. And obviously, meaning the very fact that she is a long-standing achillesia and she's lost so much of weight, said she deserves a good response.
Yes, sir. Any tips which an endoscopist should be aware to prevent reflex after doing a poem?
See, there are certain standard steps which you have to take. Of course, with the recent paper from Zahir, probably that also may be a little bit suspect now. But as of now, whatever the guidelines say is, one is that you have to preserve the sling fibers. So particularly when you are doing the posterior poem, make sure that your myotomy remains to the right of the perforating vessels. And the second thing is that the gastric length of myotomy or the length of gastric myotomy should not be more than 2 centimeters. Typically 1.5 centimeters, 1.5 to 2 centimeters, because it has been shown that gastric myotomy length, as it increases, the incidence of reflux goes significantly higher, exponentially higher. So that is something that we don't want. So, and there is also some data which is actually now showing up that a very long esophageal myotomy can also predispose these patients to reflux, possibly because of poor distal esophageal acid clearance. Because once you do a myotomy, the distal esophageal acid clearance is compromised. So you are opening up the ileus, allowing more acid to come into the esophagus, and then not allowing the esophagus to push it back again into the stomach. So it's a double whammy, and then they have a chance of developing more reflux.
So as we are tunneling, if we are ready with one more case, we can switch over and we can come back when we do the myotomy.
Yeah, because you all have seen the tunneling in Madhura's case, and once you enter the tunnel, it's actually very similar. Only when you are doing posterior, you have to remember that the muscle is below at 6 o'clock and the mucosa is on top. And here the muscle is on top and the mucosa is at 6 o'clock. Yeah, give me that. Because I'm going to need a little bit of time because of the fibrosis, we are going to take a few minutes more to complete the tunnel. We'll get there, don't worry. Nice, nice. Give needle. Other important thing is when we are planning to do a POMF, you need to make your tunnel a little bit wider.
Right.
Because you are going to be working inside the tunnel also to fix clips and things like that. So you are going to carry your endo loop across all these things. So you need a little bit more space. So make sure you are taking these angles because they compromise on your scope movements and they can make things difficult.
So we can see how sir is carefully, wow, it's already skeletonized blood vessel and finished it.
Skeletonized and so yes, that's a small vessel. So
Yes, yes, sir.
are we across? Possibly not yet. Although we are almost at the G junction. Knife, needle. Injector. Okay. Needle, knife.
So we have Dr. Girinath coming from Vizag today.
How Girina? How are you?
Welcome, doctor.
Well, so far we have had to abandon one case in our 2,500 plus cases because of fibrosis. Usually, even if you cannot get in at that spot, you can just close that incision and try at another spot a little bit more distal or proximal. And what I have noticed is, particularly if you are doing a posterior poem and you cannot get in posteriorly, in those patients, if you can, if you look anteriorly, sometimes the mucosa in the anterior esophagus is a little bit better because when the patient lies down in a recumbent position, fluid stasis is more on the posteriorly, and because of that, the mucosal changes are more pronounced on the posterior aspect. Knife.
So as we are doing tunneling, we have Professor Truptesh Kotari who came from Rochester University from United States. He wants to enlighten us about FTRD. There is a short lecture for us. We'll continue seeing Dr. Amol Bapa in the small PIP screen, and we can go ahead with the lecture.
Yeah. Okay. Yes. Needle.
Amal sir, audio back with
जी
you, sir.
जंक्शन क्रॉस कर दिया, फाइब्रोसिस का भी था.
Can you show, there is a big vessel, Dr.
Yeah,
Amil Bapai
I'm
wants
going
to
to attempt coagulating with a knife. Now I'll just show you how we do that. Hopefully we'll be successful, otherwise we have the coag rasper ready. Because this is a perforating vessel, so sometimes may not be possible. But don't give too much tension. Just coagulate the vessel by the side, just by gentle taps. And do it in the length of the vessel.
Now, first we are tackling both the sides and then we are tackling the vessel. Now,
This can still bleed a little bit later, we don't know. But that's okay. But that's how we can do it. If they're continuing with Ruptesh's lecture, that's not a problem. Meaning they can come back to us.
okay, sir.
We are at around 41. Maybe another half to 1 centimeter and we are done. Inject a little bit. Inject once.
We have Dr. Mohan Ramchandani over here. Sir, any comments on your on recent publication about reflex about after poem?
Knife. Yeah.
Mike.
Zoom then. It's just Zoom. Anywhere you can download. Yeah, Zoom. We can shoot
Just. Check 1 2. Check 1 2.
Okay, Vinu.
Check 1 2. Okay, Vana.
Yes, okay.
Sir, working, sir.
எங்க கண்டுது அந்த இதுல
We good? Hi friends, I have a great pleasure in welcoming Professor Triptesh Kothari from Rochester, Minnesota in the United States. And this is not the first time he is here. He was there to demonstrate FTRD and also train our fellows on hands-on in the model. Also do live demonstration about 7 years back, if I remember right. And then now he's back here to also demonstrate FTRD, but he's going to talk to us on the tips and tricks in performing a successful full thickness resection, endoscopic full thickness resection, the EFTR. Over to Professor Kothari.
Thank you, Dr. VGM, and congratulations to the entire VGM team for setting up the Gastro Update 2023. It is a great lineup of cases and lectures. I'm Triptesh Kothari from University of Rochester in Rochester, New York. So today we are going to talk about the few tips and tricks in performing a successful endoscopic full thickness resection, that is EFTR. The objectives for this entire EFTR is first how to assembly the full thickness resection device on the scope, which again is a more technical tips that I'm going to walk you through. And then the bunch of tips and tricks for the successful EFTR. These are the two objectives that we're going to talk about today. So as we know that the full thickness resection is divided into two types. One is where we perform the full thickness resection and then the exposed part is taken care of with the help of closure. Here it's the opposite way where we close the perforation first and then take care of the lesion. And I'm going to walk you through the entire steps of how to perform an assembly of an endoscopic full thickness resection device. So here we use, depending on a colonic or a gastric FTRD, we are going to start there's a glitch over here. So based on the colonic or the gastric FTRD, we advance the knob and then try to rearrange and then pass the sleeve on the scope. It is the same concept of a varicose banding, but again, we are passing the thread retriever, and the thread retriever is slowly pulled through the working accessory channel. We get the thread retriever and then put it in the knob and roll it, and then try to tighten the cap on the tip of the scope. The sleeves are made in such a way that we tape the sleeves on the scope, and this is in order to maintain the snare in a very static position and it doesn't move while we're doing the procedure. So the next step of the FTRDs, there are three types. One is the colonic, one is diagnostic, and one is upper. The cap diameter for the colonic FTRD is 22 millimeters, and it has a depth of 23 millimeters, and the scope used is an adult colonoscope. Just going to move this out of the way. And we have to be careful about the working diameter channel in an adult colonoscope, which is 3.2 millimeters. So that will be helpful in passing our dilation balloons if required when it comes to anal stenosis. The next FTRD is the diagnostic, which is a smaller size. The cap diameter is approximately 19.5 millimeters. Again, the depth remains the same to 23 millimeters. And the scope which is used is a pediatric colonoscope. The working channel for this particular scope is 3.2 millimeters, which is accessible for the scope of balloons if required. And the gastroduodenal FTRD, again, it remains the same as the diagnostic. The diameter is 19.5 with a cap depth of 23 millimeters. Here we need a 1T scope, which has a working channel diameter of 3.7 millimeters. Now, the reason between 3.7 and the one in colonic is that we need to have a proper dilation, which is around 20 millimeters in the upper esophageal sphincter as well as the pylorus. So let's move on to a case which was performed at our hospital. And this is the initial cases when of sessile polyp at the appendiceal orifice. And the plan was to go with the FTRD. So the area is marked with a marking probe, which is provided with the kit. And then the grasping forceps is introduced. And make sure that the markings is properly grabbed. And it's pulled in the tissue and the cap. Making sure that you keep advancing. And then once you are tightened with the forceps, then you deploy the cap. And the indication of the cap deployment is that the band, which is right over there, disappears, indicating that you have successfully performed the FT, full thickness resection of the appendiceal orifice polyp. So let's talk about the tips and tricks for full thickness resection device when it comes to polyps. So I've divided this entire tips and tricks session into three subclass, which is the access, technical difficulties, and clinical difficulties and how to tackle them. So let's talk about first as the access. We often come across cases where we have inability to advance the device, which is almost a colonoscope with a 23 millimeter cap on it to the target lesion. And there are several other cases where there's anal stenosis. We can't even get into the rectum. And again, the other stuff is injury to the extraluminal structure. So how to deal with those? So let's talk quickly through each and every limiting capacity over here, that how should we deal with each and every aspects. So when there's an inability to advance the device to the target lesion, the most important step is basically keep your scope as straight as possible. There should be an aggressive water lavage, trying to make sure that you are actually visualizing what is in front of you. And there is no blind movement over there, or just a push is not a desirable maneuver in such aspects. Applying abdominal pressure will help guide the scope in a proper way, just like your usual colonoscopy. And if you're unable to get your colonic adult colonoscope through that, then you might have to switch to a diagnostic full thickness resection equipment in order to get through the small opening of the colonic wall. The second aspect of access is anal stenosis, where you're unable to even get into the rectum. The first and foremost step is generous lubrication. Once you're done with the lubrication with a rectal exam, and at the same time apply lots and lots of lube around the cap, and then try to dilate with a 20 millimeter balloon, which is provided with the cap with the kit sometimes. So dilation with a 20 millimeter balloon would help you at least get your device into the rectum and you can perform the procedure. This is a video which was a rectal carcinoid. And here they're talking about the extraluminal structure injury. So EUS was performed and it's a carcinoid. The goal of performing this EUS to show that there's a very thin septum between the rectovaginal area. And so over here, I would like to say this is the area where the carcinoid is, and this is the vaginal part. So the septum is pretty narrow and it's very thin. So when you try to perform FTRD, there is always a chance that you might have captured one of the extraluminal structures. So you have to be very careful with such aspects, and endoscopy ultrasound is a good modality to separate out that whether it's a feasible device for such lesions or not. So let's switch our gears and go to the technical aspects and how to deal with those with our tips and tricks. So proper assembly of a cap is very, very important in this scenario. So here we see a video where the arrow over here is showing the stoppers. The stoppers are placed right in front of the scope. And when we place the cap, we should not see those stoppers. The stoppers is basically indicating that how much of the tissue should be grasped in the cap. And then on the left, we see the thread. The thread has to be placed in working channel alignment just in order to make sure there is no crisscross or a crossover of the thread, which is obscuring your vision while you're performing the procedure. The next part is your advancing your grasping forceps through the knob. And where you will notice that you have to put the knob right across your chest, because if you are putting the knob across your chest, there will be no slacking of the thread when you are trying to advance the forceps. And here we can clearly see it's very well performed. That you're advancing it, you tighten it a little bit just in order to make sure there's no slack in the thread. And then place it knob right against your chest, and then slowly advance your grasping forceps. So here you will see that this, you do not want to see what you have noted over here on the left side of the screen. If you are placing your knob, you'll be definitely not having any slack in your advancement. Rehearsing or assigning the roles, which is a very important aspect which we have developed during our practice of FTRD. And it's very important to let the people know their roles, the technician, the nurse in the room, that what they are going to perform. So here we see three individuals. The first person is the endoscopist. One person is just holding the forceps, which has been, you have grasped the tissue and you have pulled the tissue in the cap. And the third person is with a snare, ready to go with the when you give this command. So once over here, we see that the tissue is pulled in the cap and you hold it with your finger, and one of your techs is going to hold the scope, and then you're going to slowly deploy the cap. So once you deploy the full thickness resection device and the cap over the lesion, you have to announce it that cap, you have deployed the cap. And once you say deploy, and then your tech over here who is holding the snare is going to say closed, snare closed. And once the snare is closed, then you go with your yellow paddle for the complete resection. So this synchronization is very important, and assignment of role is the key factor in the final step of FTRD. So other technical aspects is you go in and you press your biopsy force, the grasping forceps, but you're unable to grasp the lesion sometimes, especially when it comes to duodenal lesions in the D1 or D2. At that point, your goal would be either you can use a trocar as well, or even you might want to apply some suction and slowly pull the lesion in the cap while advancing the scope in the forward motion. And you have to pull the entire tissue in the cap until you see the marked margins which are visible. And that's the main purpose of marking the lesion, which should be approximately 1 centimeter outside the lesion, so that you have the entire lesion resected while you're performing the FTRD. So this is the final step when you have already deployed and when you're about to deploy and your technician is ready. He or she is ready to take the safety handle out. And now you have already deployed the cap, the FTR device, and he or she is closing it. And now you go for the yellow paddle, which in turn leads to complete closure of the snare and performance of the FTRD. So let's talk about the clinical aspects, which is the last sub-session of the polyps where you might have difficulties and how to deal with those scenarios. So generally, there are many other aspects, but the most two common are the diverticular polyps, how to deal with them, and any larger polyps which are greater than 2 centimeters. So I'm going to present 2 clinical scenarios, videos, where we actually have performed this procedures and shown how to deal with this. So this is a polyp inside a diverticulum. I would give a shout out to my dear friend, Dr. Shan Thakur, for providing me with the video. And this is a diverticulum. It's grabbed, entire polyp, which is inside the diverticulum, is grabbed into the tissue, and FTRD is deployed and performed. The main goal here is that once you have performed the full thickness resection, and if there is any extra lesions left, then you can perform EMR right across it. So you can convert that into a hybrid FTRD as well. So let's talk about the second scenario, which is a hybrid EMR / full thickness resection, where if you have a larger polyp and the goal is that one part of the polyp is unable to lift, you remove or you perform EMR of the polyp, which is amenable to traditional endoscopy mucosal resection, and the remaining part can be dealt with full thickness resection device. So this is a laterally spreading granular type adenoma in the cecum. And this is definitely more than 2 centimeters. So the goal is that we tried the conventional EMR technique, and a good lift was obtained with the methylene blue and normal saline lift. And conventional EMR was performed. After conventional EMR performed, the central part was unable to be lifted, and it kept slipping through the snare. So finally, after multiple attempts, it was decided, okay, this part now is not lifting and it's tagged as non-lifting polyp. So we go in with a FTR device. And then try to get as much as possible. And then once you get to the point, use your grasping forceps and perform the FTR. The white ring is the most important aspect. Once you see that the white ring has disappeared, that is an indication that the clip has been deployed. This is the final product. So post-procedure care that we need to take care of after intervention is that we normally keep our appendiceal orifice patients for 23 hours in the hospital just for observation. And we provide antibiotics for at least 5 days for patients with appendiceal orifice or diverticular lesions. And we start the antibiotic intra-procedure, and followed by that, there will be 5 days of post-procedure antibiotics. Liquid diet to begin with on the same day, and advance as if the patient doesn't have any signs or symptoms of any perforation or bleed. We perform routine blood work only if there's any pain or fever or any signs of infection. And again, in case of such symptoms, it will be followed by X-ray and a CAT scan as well. And I normally try to schedule endoscopies or colonoscopies for such patients who underwent FTRD at least 8 to 12 weeks. Again, it's very important. There's a question I always get is that, do we have to remove the clip? No, not necessary. The clip might fall off on its own. Most of the clips, they fall after 3 months, but I do have a patient whose clip is still intact and it's almost 1.5 years. So again, you do not have to take the clips out. That's a short answer. So in summary, the goal here is when you are about to perform an endoscopy full thickness resection, make sure that you have a proper case selection, number one. Number two, the assembly of the full thickness resection device should be very precise. There should not be any shortcuts. It should be by the book. And then if you follow these tips and tricks, what we discuss, I'm pretty sure that it will turn out into a successful FDR. Thank you.
Thank you, sir. Amal sir, audio back with you, sir.
Scissors, sir.
I'm
Okay.
open for any questions if anybody has any questions.
Hello?
Yes, sir. Go ahead, sir.
Yeah. So, in the meantime, we completed the myotomy. So, here I am just entering the tunnel. And you can see that the myotomy begins just distal to the mucosal incision. And we performed a full thickness myotomy. And this is dead anterior. This is the pericardium that we can see through the full thickness myotomy. And as we go down, this is the diaphragm. And beyond that, this is the diaphragm actually over here, and beyond the diaphragm, this is the anterior gastric wall that we are going to be seeing. So that is how it is. So we will be opening up this area now for performing the fundoplication. So give me the coagrasper. I usually try to go with the coagrasper initially, but with a precise set, not with this thing. So this setting, but no, I am on regular mode. Okay, open, close. So this loose areolar tissue has to be divided. Open, close. And it is important to have maintain very clean hemostasis over here, because any bleeding in this area is going to bleed intraperitoneally or subserosely, and that can be difficult to manage because it makes the entire area very red. It is difficult to identify any blood vessels over here then once the area gets stained, and it makes things absolutely a nightmare. Open, close. See, and now at some point I will need you to put in the scope.
Where is one?
Open. That's the liver. That's the left lobe of the liver that we can see is through the peritoneal surface over here. I am pulling back because I want to try minimizing the injury to the liver. Because I want you to put in the scope, pediatric scope. Because without that I don't want to make any irreversible step. Little bit of dissection. Yeah. No problem. Vamsi will put in the scope, and what we will do is. Okay. Is your light on? And Nishant, how do you make the image bigger? And you'll need suction on that scope. Suction and CO2 both.
How are you, Greenath? All What's up in Vizag? You came how? Here? Vizag.
Put it underneath. I think you can put the scope in, we'll position it, and then once your suction is ready, we can do that. We won't start the dissection, but we can put the scope and keep. There's nothing big to, yeah. She's a small girl, na? If it's difficult for you to enter, let me know. I'll pull out this scope. Sometimes it's easier to put that scope in and then go in with this scope because you don't get that much of push with that scope. Yeah.
Hi friends, we'll just very quickly, we are coming to this room. We'll again come back after switching back to Professor Amal Bapai. We have Professor Christopher Kaur, a very great friend of ours again, and he is here after probably 10 years and maybe 12 years to demonstrate cases here. He was here demonstrating from our unit in 2011, and we have him back here to demonstrate cases here. Here's an ERCP case where we're going to show spike cholangioscopy. Before that, he wanted to show you the C-arm image of the common bile duct, and then we, along with him is yet another expert, Dr. Rakesh Kalpala from AIG, will also be there to support and take this procedure. But very quickly, we're just spending only 1 minute here to for his comments on the common bile duct, and then we switch back to Dr. Amal Bapai's demonstration, and then we come back here. Thank you. Thank you so much, Dr.
Thank you, sir. Amal sir, audio back with you, sir.
Okay. So until then,
please.
Yeah. So just quick remarks about the audiogram that's on screen. This elderly woman, she's 94 years old, and she presented with cholangitis. So she's been stented for at least one or two very large stones in the common bile duct. But what you're seeing now on the cholangiogram is that the stones are a lot smaller. So and also there is a kind of an undulation on the right side of the distal CBD that you can see there on the cholangiogram. So what we are going to do is to put a spy scope in there, have a look at the distal bile duct, and also have a look at the appearance of the stones up above. But strictly speaking, you probably don't need to do laser or EHL lithotripsy. So we will send you back to Dr. Amal's room now, and then we'll get ready with this spy to show you.
Thank you, sir. Thank you, sir.
Thank you.
Amal sir, audio back with you, sir.
okay. Are we back?
Yes, sir.
Not yet.
Go ahead, sir.
No, not yet. I think I can still see. Yeah.
Yeah.
Okay, now.
Can you show us our screen? Yeah.
So we passed two scopes alongside each other.
Can you show the scopes over here?
And Vamsi, your scope has to be continuously retroflexed only. Yeah? Don't straighten it.
Okay, sir.
Because we are seeing the pylorus.
Okay, sir.
Pull back, pull back.
Okay. Yes, sir.
We're a little bit tight. So now my scope is the big image that you can see on the screen, and in the PIP you can see Vamsi's scope. I have gone inside the tunnel, and Vamsi's scope is in the fundus. And can we switch off the light of Vamsi's scope for a moment? Switch it off. So you can see the light over there.
Yes, sir.
Yeah, so that is this is just at the G junction. So probably we have to do a little bit more myotomy. That is how it is. Switch on.
Yes.
So this is the double endoscope technique also, which has been described. Can you give me the TT knife again?
So first time Guru and student are doing together.
It's a privilege for me.
Privilege for us. Sir. So this is a very unusual image. Only in GERDEX we saw once two people demonstrating, and now again we had an opportunity.
Inject. Inject here. Inject. Okay. Give me the knife. Is this one precise it? Yeah.
No,
Yeah.
we want to cut more
We want to
muscle.
cut more muscle. So I'm just opening up the submucosa a little bit because we were almost at the end of the tunnel. So I don't want to, because what happens is that the mucosa sometimes gets pulled up when we apply the do the wrap, and then that makes things difficult. Then you can injure the mucosa in that process. So this is the double endoscope technique. The problem is you don't know from outside when you're doing the tunneling, and when you go on the peritoneal side, knife back. Switch off your light again. Yeah. Maybe a little bit more, huh, Mohan? Inject here. Yeah. Okay.
So Dr. Mohan was discussing about
Nice.
recent publication from AIG,
Yeah.
reflex after poem.
Just publish.
Already published.
GIE, yes. We have two publications from our
Yeah.
this month's GIE.
One is Zahir's and one was Mohan's. Of course, both of them are co-authors in both, but I think as first author, one is one and the other is. So Zahir the Mohan's publication is about reflux, and that's really a fantastic publication because I think it's the first time anybody has measured true reflux. Where are we going?
It's a perforating.
We can,
It's going right from
now we can see it.
Yeah, that is a perforator. And so this is the place. This is the second perforator. Inject here. Little. Okay. Bas. Enough. Enough. Knife.
Okay, okay. Yeah. Quack grass.
Quag rasper.
Quite grasp.
Yeah, we'll do that once the grasper is in. Still haven't nicked the vessel too badly. Otherwise, we would have been in a pool of blood here. So this is the second perforator. I thought that it was a little bit too low down, but then probably it was the right. Okay, so I'm just coagulating the surface tissue on that. Open, open. Now rotate the grasper. Yeah. Okay. Close. Open. Open, open. Close. Open.
Dr. Jay Bapai, he came up with a publication with a formula to estimate
Yeah.
G junction.
Yeah, that's a brilliant thing, actually.
Yes.
Any comments on that, sir?
Well, that formula really works. And particularly even in sigmoid, when sometimes it is difficult to estimate the distance from inside the tunnel, it helps you to reduce your procedure time by having to pull back and go in and out. Obviously, it is not the only thing that one should go by, because it also depends on how strongly your scope is pushed against a tight G junction, because otherwise if the scope is too looped you can miscalculate. But it is a useful thing and adds to one of the additional things how to estimate the G junction. Let's just switch off your light again.
No.
No. Now we
can
can see it quite reasonably
Can we
well.
make this?
And I think we've reached the second perforator, so this is the place we will go.
Okay, sir.
That's what my plan is. Okay.
Okay.
So I'll just tell them what I'm going to do, so that they can follow us on the PIP. So I'm going to dissect in this region and reach the anterior peritoneal surface, and I'll wait for you all to come back to us until we will open the peritoneum and go inside. Close.
Amol, my question is there any way, landmark where we decide that this is the place where we have to go into the peritoneum, or it is more experience?
Well, what I have seen, Mohan, is open. Once we have done a myotomy up to the second perforator, we go beyond this. We go out at this point and dissect for another approximately a centimeter or so.
Vertically down.
Vertically down and gradually angle upwards. Usually we will see one large vessel which is running horizontally in this region. That one should avoid, because that is usually a pretty large vessel. Open. And then you don't want to damage that one, because that may not be controllable with your grasper. Close. This also is a vessel, so I'm just going to coagulate this.
Did you locate the second perforator?
Yeah.
Yes, they did. Already closed.
Open. This is the perforator from the outside, the one which I coagulated just now. And then at this point, Mohan, angulate sharply upwards and a little bit towards the left. If you go straight up over here, usually, now she is very thin, but in a slightly heavy patient, you will encounter a lot of fat in this region. But if you angulate a little bit to the left, you will find a little bit of clear space over here, which you can dissect. And these are some of the fibers of the phreno-esophageal ligament, which you can see over here. So those. See, so I am using a cut current, or the current which I use for the myotomy, the precise sec, but I am using the coagrasper because I want to have complete control on my instruments, and like surgeons I want to grasp the fibroalveolar tissue and make sure that I am coagulating every vessel over there.
Amal sir.
Yeah.
Thank you sir. Next room is ready. We will move on the next room sir.
Yeah.
Yeah sir. Thank you sir. Thank you very much.
And although these are muscle or the ligament fibers, they usually will carry.
Christopher sir, your mic on sir. You're on live.
Thank you, Dr. Mohan. Thank you very much. So what we have done here is to put a spy scope in, and the reason why we inserted the spy is the main reason was really to have a look at that undulation that you saw on the right side of the patient in the distal CBD. That's a little bit unusual, and sometimes we are surprised and we find something unexpected there. So we'll show that to you. And the other thing we wanted to do was have a look at those stones. So I'd like to point out, today what we have done, although the spyglass is actually built as marketed as a single operator cholangioscopy system, you can very well do it with a two-person procedure. And so I'm very privileged to have Dr. Rakesh Kalpala, on my right here, working together with Venkatesh from Boston, as well as Viswanathan from local team as well. What we can show you now is really the very clear images from the Spyglass DS that you see on screen. Are you seeing the Spyglass DS in the auditorium? I guess they are, huh? And so what's right in front of you now is just a little bit of mucin and a little bit of mucus. And on the right, you can see that there's some erythema there. Remember, this patient had two double pigtail stents indwelling for a while. And that has left a little bit of what's the word for it? Erythema, or I wanted to say, yeah. This is what we expect with the stent in there for a while. And I'm going to just pull back here with the spy scope, and so we'll have fluoroscopy. Can we irrigate at the same time? And just we need to remember that when we're doing cholangioscopy, we do put in large quantities of water or saline in there. And we don't want to be doing this in active cholangitis, so that is a contraindication. We generally want to be very careful if we're doing high cholangitis risk patients, for example, in primary sclerosing cholangitis as well. So it's very important to have one of your team doing the aspiration, the suctioning of the contents of the bile duct. So you can see we're in a dilated CBD here, and very soon, as we're pulling out, very soon you will come across. Can we have fluoro, please? And it's a lot more fun to do a kind of a two-person cholangioscopy because Dr. Rakesh can focus on getting the image and the positioning, and I am sort of just pulling things back very slowly, and we're looking out for our stone. And and we were just now, you can see the bifurcation in the distance, and this is all normal bile duct, relatively normal bile duct here. So now coming back, we should start to see some stones. Now we know from some pivotal studies, the first of which came out of Hong Kong a couple of years ago, that when you leave indwelling plastic stents, you can make the stones smaller. And there were further studies later on which confirmed this finding. So this is what we think has happened. The stones have become a lot smaller, and I'm going to pull back a little bit more. We got some air bubbles in there. Yes, and in the lower half of the screen we can see probably that's the stone. I think, okay, I'll just wait for Rakesh to do a little bit of manipulation with the right. Yes, so there you can see a brown mixed stone occupying the sort of like the right lower half of the screen, and with the normal CBD up above, I'm going to pull back a little bit. Yes, and so you can see the stone there. It's probably fractured a little bit, because you can see this concentric sort of lamellations on it. All right. So, oops, we've slid a little bit. Okay, that's fine. Rakesh, is it possible to sort of keep you in the middle of the lumen a little bit? Yeah, okay. So we can see a little, a bit more of the stone there. And looking at the size of the stone and comparing it on fluoro, it'll probably come out if we do a large papillary balloon dilation. But we're not going to do that today. Why? Because of something that we found down below, and we are going to come up to it fairly soon. Fluoro, please. Let's see how low down we are. X-ray screen. Yep. Okay. So we've still got some way to go. So if we can just irrigate some more stones down below. You can see those brown stones, very kind of irregular looking calculi. Yes, yeah, that's kind of a big one there. Can you appreciate? I think we can appreciate that. And we're going to slowly come down as we continue the irrigation. Okay. X-ray, please. Screen. Screen. Okay, around here. All right. We just have to be careful because we don't want to fall out. If we can irrigate some more, please. I'm keeping my finger off the air button. We have the scope slightly long so that we don't fall out because it was slightly it was unstable just now. Okay, right there on the left, you can see we're sliding a little bit. Fluoro, please. Irrigate, yeah. Screen, fluoro. Okay. Water. Yeah, just some adjustments now. Oh, we slid out. I think fluoro. I think we're out. Fluoro? No, maybe not. Maybe not. Okay, I'm just gonna try pushing. No, I think we're out. Yeah, we've actually ended up maybe in the channel. Okay, we've slid out. Okay, let's see if we can do a freehand cannulation here. So the spy is just very stiff, and I'm gonna have to shorten a little bit. So we do this with full scope tip up, and with the sphincterotomy was big enough for us to get the scope in. Yeah, can we switch to spy? Just hang on a second. We're going to switch to spy view. Okay. Okay. Now the scope is sliding.
Amal sir, your mic on, sir.
Yeah. Image not yet. Image is still the.
I don't know. Yeah, we're in now.
Go ahead, sir.
Okay. No.
Yeah.
Out.
Now it is. Okay. So we have dissected in the subserosal space, and this is the place where I have opened the peritoneum now. And I'm going to use the insulated tip IT2 knife to open the peritoneal incision so that my scope can go into the. Open it full.
Yeah. I'm kind of long
I'm going
here.
to use a quiet current.
So, yeah, I'm going to shorten a little bit, and then we'll try and get a slightly better position.
This scope has to go in comfortably, no? This scope has to go in comfortably. And then I have to also carry the endo loop later. Yeah, it will lacerate and then it will cause bleeding and all these things. So you don't want that to happen. That's the left lobe of the liver. So how's the liver look, Mitra? Is it okay? Okay, take this out. Give me the forceps. Now I'm going to use a grasping forceps. Now I turn my scope upwards and then to the left. This is, and I try and go towards the fundus. So I am still insufflating because we need to create a capnoperitoneum here now to be able to. No, you don't insufflate, Vamsi. Yeah. Maybe you might even want to deflate for a moment now. And this is a fat at the splenic hilum, and that is the fat that we need to identify. And this is the part that we are going to be grabbing. Usually we should be able to squeeze the spleen. I am not seeing it yet. Maybe I will turn the scope around and see if I can see it. Sometimes it is just hidden behind the stomach, the gastric fundus. She is a little bit small, this girl. So because of that, the scope turning becomes an issue. No, the spleen we can't see it because it is still. This is my scope, which is in the peritoneal cavity, and that is in the fundus, in the stomach. That is Vamsi's scope, which is in the fundus, in the PIP. And this we have entered from the anterior gastric wall. This is the falciform ligament over here. Yeah, but this side is a falciform ligament on the right side. We usually make an exit into the peritoneal cavity toward on the left of the falciform ligament, because or the left triangular ligament in fact, because if you go on the right side, then you have to penetrate through the falciform ligament to come on the left side. So then your wrap will come and the fundus will come through that side. So that makes it a little bit more tricky then. A couple of times we went there by mistake and then we realized that. Oh, okay. Okay. No problem. What I will do is I will just grasp this and see, because sometimes what happens is these patients, if her distension increases too much, then that can become a little bit tricky. Give me the forceps, please. Huh? You have the rat tooth? Not functional? Then give me one of the clips. Open the clip, no? Open the clip, no? This is the anterior abdominal one. This you can go down. There's a small bowel. This you can go down. So now we are retroflexed in the supracolic compartment and you can see the liver retroflexed. That's the falciform ligament. यूएस क्यों चाहिए गैस्ट्रोस्कोप से हो सके close it, open it, open. It's not opening, closing, because we'll be in upturn, no? If it doesn't open, close, then no fun. Take the clip. Take the microtech clip. Yeah, of course. And show me the packet also. Okay. Still not. Huh? Okay. Can you show the external image on the camera here? Babu? Who is there? Babu is there or Anand is there?
Yes, sir. Babu is there.
Yeah, Babu.
Yes, sir.
Okay. I think I need to pull the scope out because the tape of the scope, the cap is coming out. I don't want that to fall in the peritoneal cavity.
Sir, that is that Olympus guy, sir. Ask that Olympus guy, sir.
No, not Olympus guys. I want
Action camera, sir.
Your camera.
Yes, sir. Ready, sir.
Wait a minute. We'll go to the other room because I'll have to put the tape and come back.
Okay,
because
sir.
I don't want that to fall in the peritoneum because that will be a absolute hazardous thing.
Okay, sir. We will move on the next step and come back to you, sir. Christopher, sir, are you back with you?
तो नहीं हुआ किसी को.
Christopher, sir, are you back with you, sir?
Okay, thank you very much. So what you can see on the SPY screen is that this is distal cholangiocarcinoma. There's a polypoidal mass with a papilloform appearance and also some dilated vessels as well. If we can, we can't irrigate because we've got the SPY in there, the SPY bite in there, and we're trying to get it out. Now, I'm sure that my elevator up position is causing a little bit of obstruction. So is it better now? Okay, screen please, fluoro. So look for the SPY bite to come out at the 6 o'clock position. X-ray. Yeah, it's not out yet. Okay, so this is a little bit delicate. Yes, now you can see the tumor at the lower half of the spy scope. Okay, spy scope in now. I think we need to hang on. Yep, little bit. Yep. Okay. Okay. No, also because I've actually eased up on the elevator up as well, so that has helped us also. Okay. Yep. There it is. And yep. I'm gonna pull back a little bit. Pardon? Yeah. Okay. Now we can open. Oh, you need to push out a little bit. Yep. Okay. And you can advance the forceps. And I'm gonna give you a little bit of yeah. Could be a bit more than that actually. Yeah. Okay. Okay. Closed. Okay, I'm gonna ease up on the. Yep. Yep. Forward. Oh, careful. Yeah, we're actually getting the scope pushed back. I will just push that in a bit. Okay, pushing in. But it's okay. We're getting a yeah. We're actually getting pushed out. We're getting pushed out. Yep. Yep. Trying. Fluoro, please. No, you know why we slid out. That's why. We slid out. Fluoro check. Yeah. What does the spy view look like? I think we're out. It looks like we're in. Are we in? Okay. You want to try and do it in this strange position? It's okay. Okay. Let's try. Okay. So I'm further in now. So I need to pull back.
Kishore sir. Kishore sir.
Pulling back. Yes.
Sir, next room is ready. We will move on to the next.
Yes, we'll move to the next room because we're having a little bit of trouble here.
Yes. Kothari sir, your mic on sir. You are on live.
All right. Good afternoon, everybody. And Deb is going to present the case. It's
both the mic on sir. On sir. You can present the case history.
Yeah. Hello. Good morning. Can you put on the case presentation slide?
Yeah. Running. Go ahead, sir.
This is a 60-year-old female, and it's presented with a complaint of a loose stools over the last 2 months. We did upper endoscopy here, and we found there's a subepithelial lesions, which could be around 1 centimeter around the size could be in the second part of the duodenum. So we have taken the biopsy, and it proven out that neuroendocrine tumor, as per the WHO gradation, it turns out to be grade 2. So our next plan was to do that full thickness resection of that subepithelial lesions. So now, sir.
Thank you, Deb. So it's a D2 lesion right across the ampulla and approximately 1 centimeter. So goal was that we visualized the lesion before offline, and then we dilated the pylorus with a 20 millimeter balloon. Right now, as you see, we are dilating the UES area and with a 20 millimeter balloon, so that the cap, which is approximately 19.5 millimeter, can easily go down the UVS and the esophagus as well as across the pylorus. So if we can deflate.
I have a question to Dr. Triptesh.
Yes, Dr.
See, the Americans think that some of these neuroendocrine tumors that you get in D1 or D2 are just incidentalomas, and we don't need to tackle them. So what is your view? And I think recent NICE guidelines say that you have to treat all of them because some of them can metastasize later on.
Right.
So we should tackle. So what is your view? Would you tackle all of them?
So I would like to tackle basically depending on the indolent tumors like the neuroendocrine, mostly the gastric, based on how the WHO classification is. That's more important to take into consideration. Also, the mitotic index is very important in
Mitotic
such
index, and also would you like look at the size?
Yes.
You'll say above this I will remove and below this I won't remove.
Yeah.
Is there anything
So,
like that?
so basically, if it's greater than 2 centimeter, then definitely has to be referred to a surgeon, or an ESD can also be performed, a freehand ESD. But when it comes to a endoscopic full thickness resection, anything below or around 2 centimeter would be a good option to be tackled with this type of device. So if we can, I would like to show the audience the lesion. If we can just suction this, and we have successfully dilated the UVS area.
You use a 20 millimeter balloon?
It's a 20 millimeter balloon, and we can take that. And I'm going to quickly go through the area, because it's very important. Once you dilate, you have to go through the UVS, make sure that there is no rupture, no perforation. So looks fine. Scope is going down easily. It's a 1T scope. The G junction looks completely fine. We dilated the pylorus again with a 20 millimeter balloon. It was with the help of a guide wire. We advanced our 20 millimeter balloon, which is provided with the kit. The area looks good.
We'll quickly switch to the next OT number 3 to Amol, and then we'll come back to you.
Right. Thank you.
Amol sir, audio back with you, sir. Amol sir, audio back with you.
Yeah, audio is back.
Yes, sir.
Okay. So I was just waiting for you all to come back over here. So now we are ready. We are going to simulate the wrap. What I'm going to do is I'm going to turn to the left and grab the fundus. Hold the scope here. Somebody. My scope. And open the clip. Now I can use either a grasping forceps or a clip, a wide clip over here. So I'm going to take a big bite. Okay. Close this tight, but don't fire it. Huh? Okay. Close. Okay. So tight. Okay. Now I'm going to release your scope or your hand. Now I am gently pulling back until my scope comes into the tunnel. Maybe that is what happens, because we don't have the rat tooth.
But I think we got a good wrap.
We got a good wrap.
Yeah, I think that position
I don't
is
know,
okay.
that position was good.
Yeah.
So what we can do is we can just go ahead and put this thing.
Yes.
I think we can also put in a needle here now.
Yeah.
Because we need to put in, because now she is quite distended.
Give me gloves.
And her.
Give me good syringe.
It is CO2 will
And
draw.
some saline.
Yeah, she's quite tense.
Gloves.
And then entry over here becomes difficult, because you can't enter over here because all the tissues come together.
Okay. Saline.
No, 3 clips.
Saline.
3 clips, because you need to distribute the tension. So now what I'll do is I'll pull out the scope. I just want to make sure that after putting in the needle,
Spirit swab.
yeah,
Spirit
we
swab.
can see that. I'll just section out.
Saline.
I'll just section
is
out.
what,
Just
saline?
do a little bit from here.
Not formalin, no?
The saline, huh? Okay.
No, it's okay.
Normal saline, huh? Because it is going intra-abdominally, huh? Don't want. Yeah. So for now what Mohan is doing is, Mohan is doing an abdominal paracentesis. He's put in a needle with a syringe filled with saline, and you can see the air bubbles coming out, the CO2 bubbles actually. and with that, we are decompressing the peritoneum, because this patient, we have created a intentional capnoperitoneum, but you don't want the capnoperitoneum to increase too much, because that can have ventilatory and respiratory embarrassment for the patient. So we need a balance between the two. We can insufflate, but we need an exit over here. So that is the reason we have done that. And now I will pull my scope out. I will now use the clip, the same clip which I used, and I will carry an endo loop inside.
This is not good. Tape is better.
Tape is better. Tape. Yeah. No. This you keep. Now give me the endo loop.
Yes, sir.
Now we are using the microtic clips over here for the fundoplication. The advantage of the microtic clips is that the tail of the clip is very short. So you can apply multiple clips in succession and very close to each other, but you can still precisely place the clips. That is very important. Okay. And we are going to use the endo loop. Now today we are using the Olympus endo loop, but usually I prefer to use the detachable endo loop which comes from Leomade, because that loop can be carried without the handle inside. So that reduces one more instrument going through this thing. Preloaded, we'll use that one. हाँ मिड एक्सिलरी, मिड नहीं, मिड तो इधर आएगा ना, मिड एक्सिलरी पीछे जाएगा ना, ये इज एंटीरियर एक्सिलरी. Okay, so sister, now who is familiar with the handling of the endo loop? You will do that? Okay. So then sister, you focus only on the clip. Okay. So this is the open, and that is the, yeah. Now, just open it a little bit. Back. Yeah. Okay. Just keep it this much. Okay. Now open the clip. Now what I am doing is, I am holding the endo loop from the outside in the clip. Close the clip. Don't fire it. Now can you close the endo loop gently? Close. So that the loop, the laxity is reduced. Yeah, close it till the, yeah, this is good. Now I am pulling the clip back to the tip of the scope. Now give me some jelly. Now I am carrying the endo loop alongside my scope inside, and with the handle of the endo loop handle also. Now this becomes a little bit difficult sometimes, so we prefer to use nowadays the detachable, where you can only carry the loop without the handle, but that's okay. That loop is not available in all countries, so I think this is a better demonstration, because the Olympus loop is available everywhere. So this is something which more often people are going to use, I'm sure. Okay. Let us carefully inspect where our mucosal site is, incision site. And now I want to enter inside. Now at this point it is very crucial that my tip of my clip and my endo loop are in front of me, because otherwise the plastic sheath of the endo loop can sometimes get stuck on the mucosal edge and it can cause a laceration. So that I want to prevent. So I want to, don't open it, boss. You are opening the endo loop. I want it closed. Close. Because only then I can carry the sheath inside. See, it is still very open. See, it's so much open. Sheath close. Close the sheath. Close the sheath. Close the sheath. Close. No, no, no. Close. No, then close. Close. Pull this back. Pull this back. Pull this back. Yes, that is what I want. Now, wait a minute. Tighten further. Tighten further. Close. 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 Yeah. Not closing. Yeah. Meaning. Oh, yeah. This. What are you doing? Where is the sheath? Sheath is far behind. I think you are opening the sheath, sir, instead of closing it. I'll pull the scope back because without that we cannot do anything. It has to be tight. See, I want the sheath to be tightly up against the clip. Yeah, so this is open. Yeah. Yeah. Now keep it this way. Keep it this way. I don't want it to be, this thing because when I pull the clip back, the sheath goes behind, so I can't see it very clearly. Okay? So just keep holding this. Can I get some gauze here? Gauze. Yeah, because when I'm pushing, no, that there is a tendency for only the loop to go ahead. So there has to be an active counter traction on the. Yeah. No, no, it's getting stuck at the edge, no? That is the reason. Hold the scope here like this. See, again the loop is open, huh? Loop is loop is getting stuck. So I am now. No, no, no. I know that. That is what is happening. That is what typically happens. That is the reason it's getting stuck. Got released. Okay. Open the loop a little bit so that I can hold it inside itself. Let's see if it's easily possible. Otherwise, then we have to take it out because that can go under Vamsi scope sometimes and then makes it. Okay, open the clip. Keep the clip open. Close. Okay. Now close the sheath over the loop. Forward, forward. Okay, tight, further tight. The tighter you make it, it adds more like one unit. No, but I'm inside the muscle. So I have to go inside the tunnel. Now it is okay. Now I will follow. So this is the crucial step. Sometimes can get tricky as you saw over here, but with patience and perseverance you can usually manage to. No, no, no. We are not yet at the fundus. We are still inside the tunnel. The thing is that entry into the tunnel with this end carrying this endoloop sheath. No, no, I have not plicated yet. We have just created a simulation. And this is the next step. Am I still holding the loop? Yeah. CO2 is still coming out. Huh? Okay. Yeah, we can do that. The loop tight. The slack sheath can be.
Amal sir, we will move on the next turn and come back to you, sir. Yeah. 42 mic on.
Are we going on? Hold on one
Yes, sir.
second.
Go ahead, sir.
Okay. So we are back. We saw the lesion. And the lesion, again, just to recap, it was a duodenal D2 lesion which we saw. We marked the area with the probe. It's a D2 carcinoid grade 2 differentiation as per WHO classification. And we have mounted the gastroduodenal FTRD. And I explained to you how it was the entire assembly process in my lecture just 10 minutes ago. Now this is again a 1T scope. And I would quickly like to focus on the cap area. So if you want to focus on the cap. So basically this is a 19.5 millimeter diameter cap. The diameter is 19.5 millimeter with a depth of 23 millimeters over here. And it can fit into the 1T scope, which has a working channel of 3.7 millimeters as well. So we have dilated the area, the UVS, and we dilated the pyloric area. The goal is to get this device through the UVS and the pylorus into the duodenal portion to take care of the carcinoid. So we are going to start slowly. First make sure that the screen is clean. Can we have loop please? So the insertion part over here is very, very important. You have to be careful. We have performed the dilation, but again, inserting into the oropharyngeal area is very important aspect. So again, I'm not getting a good landmark, so I'm going to pull back. Have my tongue at 12. Slowly go in. Advance the scope. And I'm going to ask my anesthesiologist to deflate the cuff. So he's deflating the cuff while I'm trying to get my EFTR device slowly through. Is the cuff deflated? So we'll try to do the maneuvers. If we have the neck, we can just extend the neck a little bit. Deflate. And we are trying to go through the UVS. Again, be very careful while going through. We might use a chin lift over here. Okay. So this is a very important aspect while doing a EFTR, the intubation in the upper esophageal sphincter area, and we have dilated up to 20 millimeters. Still we are having some struggle. So I'm going to pull back, reevaluate, make sure if we can have a chin lift. Maybe even I might use some water over here just to.
Kothari sir.
Yes.
We are watching your video. We will move on the next turn and come back to you, sir, with our audio only.
Sure.
Yeah, thank you, sir. Kishore sir, audio back with you, sir.
Yeah.
Sir, your mic on, sir.
Okay, thank you. So we've in the meantime we've had a bit of trouble getting the laser probe out of the spy. We've removed it, inserted it, and now we're good. Okay. So out of the 6 o'clock, we are in position. We want it to be close, fairly close. Yeah. So we have taken the biopsies from the worked very hard at getting biopsies from the tumor at the distal CBD just now. So what we're going to do now is to work on that stone. Yeah. Oh, I thought we were okay. We're ready. Okay, we're ready to make mincemeat of this. Okay. So we should try and get a little bit closer because it just creates this slight snowstorm effect when you have all these particles, and of course we need to do a lot of irrigation and suction at the same time. Perhaps pull back on the probe a little bit, and so that I can go forward with the like this. Okay. If we're all comfortable, we can start again. Okay. And so you can see that the application of laser power is causing. Yep. And we're actually making a little hole in there. So, and actually some part of it has actually flaked off. Huh? Okay. So Rakesh, I know you're going to be moving the tip around a little bit so that we don't end up boring a hole there. Huh? Okay. Right. The light should be down. Let me just, like this. Okay. So Shivangi was asking, what are the settings? We didn't ask about the power. How much are we? 18 watts? Okay, 1.8 watts, 1.8 joules, is it? Okay, all right. Okay, I think we've fallen back a little bit, so I'm going to get closer. Let's watch. Yeah, I'm pushing the spy, and now we're doing it. Okay, we need to pull back a little bit on the probe. So this stone is floating a fair bit, and that's why. Yeah, I'm going to push the spy a little bit. Yeah. Can we irrigate some more? I can't really see where we are. Yeah, it's quite soft. Yes, aspirate please. I'm going to push forward. Rakesh, can you pull back the probe a little bit? Yeah, okay, there we go. Okay, here we go. We're going again. So blasting. Now the with laser, the amount of power applied per actuation is actually smaller compared to EHL, but we're actually doing very well. Huh? With just a couple of pulses already making a bit of a hole there in that stone. So the idea is to sort of make a few parallel holes and then end up in a big crack down the middle if you can. Okay, we're almost through. Yeah. I'm going to pull back a little bit. Rakesh, you pull back on this? Yeah, please. And then let's maybe choose a different spot here to blast away at. Okay, yeah, that looks good. Okay, okay. Yeah, this is nice. Aspirate. Yes, please aspirate. Fluid and aspiration. Yeah, again, it's making this whole. I beg your pardon? Yes, antibiotics already on. That was actually the first thing we asked for when we started the procedure, knowing that the patient is elderly plus, yeah. Yep, it is, it is, it is. Okay, yep. I think there is another bigger stone further up. Shall we just pull the probe back a little bit and we can advance the spy scope? Yeah, maybe not too far back because we might have trouble again. Okay, irrigation please. There's something in front of us. Okay. Just a bit of navigation now. Yeah, this is actually the, yeah, we're already all the way up at the bifurcation already. Let's pull back. So that's more stone down below. Shall we have a crack at this one? And then the probe will come out just on top of the stone, if we can get it out. Ah, okay, brilliant. Okay, okay. If you pull back some more, I think we have it just out. Yeah, just forward. Yep. I'm gonna a little bit back. Yeah. Okay. Yeah. Maybe in between. Yeah. This is good. This is good. Okay. This is good. I'm just concerned that we're skimming the scope right now, the stone right now. Okay. All right. Now blasting kind of like the surface of it. I'm going to give it a little bit of. This is actually still quite big. This stone. Yeah. Should we pull back a bit? Yeah. Oh, too much. Too much. Out. Some irrigation. Yeah. It's not out yet, no? Ah, okay, here we go. Somewhere in between. Okay, that was good just now. So I think if you're watching, you will appreciate that it's sometimes hard to keep this position. So this is one of these, this lamellated half stone. While you're doing this, I think it's reasonably safe as long as you don't keep doing it. Right. Yeah, the bile duct is relatively more resistant to trauma, I think. Yeah, yeah. No, the big one there just now. I'm gonna go a bit closer. If you, it's on the left, Rakesh. If you pull back a little bit, but not too much. Okay, there, here. Again, I'm not getting as good a view as we'd like. If you can, yeah. Yeah. Okay. Yeah. Okay. This is good. Yep. This is nice. Okay. Our view again is suffering a little bit. That may be enough, huh? Yeah. Broken. Okay. Yep. Yep. Is it stuck again? It's inside the scope. We can actually once we're happy enough, we could remove the fiber and then put some contrast in and have a look. Huh? Yeah, sure. Spy is not out. I think we have enough fragmentation. Okay. Yeah. Yeah, and I think we've sort of at least 50-60% fragmentation at the very least. And even if there's still fairly large pieces, we should be able to catch them with a trapezoid basket now. Yeah. Okay. Yeah.
Sir,
Yeah,
thank you, sir. We are watching you. We will move on the next set and come back to you, sir. Kothari, sir, your mic on, sir.
Okay, perfect. So we had a little bit of struggle getting through the UVS and the pylorus as well. Somehow with some manipulation, so the tips that again, how to get through the UVS, we extended the neck, mitigating the angle. Also, we made the patient a little bit in a semi supine position, so that way it helped us navigate the UVS. coming on to pylorus, where we had an issue again, getting the scope along with the FTRD device through the pyloric channel into the small bowel. What we did again was place the patient similarly in a supine position and had some abdominal pressure, and started that way we were able to navigate that area. So this is the lesion that we had initially seen, and the white marks that you see is made by me. It's along with the marking probe, approximately 1 centimeter away from the lesion. Now if you see that I'm able to have a good look of the entire lesion in my cap, so approximately this lesion seems to be between 1 to 1.5 centimeter, because the cap itself has a diameter of 19.5. So again, we can go with the steps what we talked about few minutes ago, is that we are going to have the grasping forceps. So Yagnesh is there, who is going to give me the grasping forceps, and this is the FTRD grasping forceps called the FTRD grasper, which is provided with in the kit itself. So if Yagnesh, can you open that please? So if you noted my lecture, I said there is a rehearsal. So just before,
ma'am, please switch on your mic, ma'am.
So just before any big event, we do a rehearsal, right? So this is a big event for us, and we need to do a rehearsal in order to make sure that everybody involved in the play knows their role, what to do. So this is the FTRD grasper.
And also if the lesion will come into the cap, so do you do that mark before you go ahead?
Perfect. Yeah. So we have Yagnesh, who is going to hold the grasper. We have Kanan, or Prabhat, who will be holding the snare. So I'm going to advance. First and foremost, as we showed in the video, you tighten the knob, put it against your chest, very important, and then slowly try to advance the the FTRD grasper through the area. So if you notice, we do not have any slack over there near the cap, because the knob is attached exactly to my chest. It is giving a tension. If I let it go, there will be a chance that there might be some slack, but we don't want to do that. So gradually we are passing our grasper. So we have to open the grasper outside the cap. So I might ask Yagnesh, please open. Now the point of making the marking is that you need one end of the grasper to touch those marking points and the other on the other side, ensuring that you have got the entire lesion. And the grasper should be right in the center. So please close that. So this is just a mock that we are doing. We are not going to implement the final step right now. I'm just trying to show that this is what we're going to do. Mild suction, and along with that I'm going to slowly pull it in my cap. Now you see that there's tethering of tissue over here. But again, we have to be careful that we are not going to pull too much over here. We do not have to do a red out. It's not like a varicose banding. So I would let Yagnesh please open the forceps. Alright. And now this time Yagnesh is going to close the forceps. I'm going to pull and close and hold it with my pinky, that is a little finger. And then Prabhat is going to be ready with the snare as well. There will be a rehearsal, that is I'm going to say deployed, that is I'm going to do a clockwise move of the knob, which will help us deploy the clip. And if you want to notice, there is a white ring. As I talked in my lecture, we have to look out for the disappearance of the white ring. Once I deploy, the white ring is going to disappear. Once I say deploy, Yagnesh is still holding his forceps, and then Prabhat is going to take his safety net out, that is a safety locker, which is written as number 2 over here. He will take it out, and he's going to do that right now. And then he's going to close, and he's going to announce loudly. When I say deploy, he's going to say close loudly, and then I'm going to press the yellow paddle over here with the settings of high cut of 4, and 200 watts. So that's the standard setting what we have for the FTRD. So again, I would say deploy. Prabhat is going to say close, and then I'm going to press the yellow pedal. Yagnesh is going to make sure that his forceps is closed all the time. So let's try to see if we can make this happen. Close. I'm going to suck slowly. At the same time, I can push my scope a little bit in. So this is a very crucial step. Now I'm going to hold it with my little finger, and this is the point where we are going to start deploying. So I'm going to say deploy once I deploy it. So look out for the ring.
We can see the marks.
Deployed. Close. And I'm going to go for the yellow pedal. And that's where the polyp is removed. So we are going to bring back, and also we'll bring you back for a look of the final product.
Sir, may I ask one question, sir?
Yeah.
Sir, I mean, is there any relation, like, do I need to proper sit on that lesion, like in case of variceal banding? It's on only. Like.
Open. Okay, take that.
Kothari sir, thank you sir. We are watching you. We will move on the next theatre and come back to you, sir.
Yeah.
Amal sir, audio back with you, sir.
Okay. Still don't have the video. Yeah. So we've applied 3 clips on the fundus and 3 clips inside the tunnel. We have anchored this endo loop using these 6 clips, 3 on the fundus, 3 in the tunnel. And now we are going to close the endo loop gradually. As Vamsi, in the small image, you can see that maybe what you do is you pull back a little bit and now inflate. Keep inflating. Yeah. So we will see the wrap being created. So what we are going to do is, now gradually you close, but don't jerkily close it, because otherwise the loop can cut on the clip. So gradually you can close, and I'll guide this. Yeah. Yeah, it's moving. So I can see that. Yeah, show the big image, Vamsi's image big, and my image small. Yeah. Okay, are you? Okay. Push your scope in. No. Why don't change that? Oh, you want to see the loop, huh? Okay, wait a minute. Okay. So it's tightening. So see, once you tighten fully, then further release a little bit and crunch, 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 2-3 times. Right? Keep that PAP so that. No, you have to show Vamsi's image. Yeah. So in the PIP small image, you can see that the loop is completely tightened. So all the way down. And now once it is completely tightened, maybe you can release and then crunch, so that the tissues come together, and that is how. And you can see that the wrap is being formed on the slim scope image. The fundus is still not completely inflated. That's also partly because of the capnoperitoneum which the patient has. But as the air passes off, but we can see that there is a nice wrap which is being created over here.
Yeah.
This is the wrap. So that's how it looks. It's a partial wrap. It's about a little bit less than 180, I would say, 160 or so, and that gives a good protection against the reflux. At the same time, does not allow dysphagia to occur. Now that we are completely crunched, okay, now release the loop and we come out. I open the, yeah. Now we release the loop. Done. So this is done. Thanks. I think I had the honor to have Ravi helping me with the endoloop. Because the endoloop sometimes is a very nasty instrument, and they cannot. It's a very temperamental instrument. That is what I always call it. It has a mind of its own. Okay. So now let us do one thing. What is this? This we have taken. Yeah. Now let's put the endoscopy image over here. No. You are showing Truptesh's image. Yeah. So you're getting Vamsi's image. So Vamsi, congratulations, you've created a fantastic wrap over here. Very good. The scope is in your hands. Don't tell me that. Don't make excuses. So that's how it is. Now give me the IT knife. Because we need to cut this endoloop. Normally I would cut this endoloop and trim the tail of this endoloop using a loop cutter. But unfortunately we don't have the loop cutter over here, so I'm going to try using the IT2 knife and hopefully loop cutter or scissors, any would be okay. Okay. Give me, if you have the scissors, let's try this thing. That may not, this thing, it usually slips. Give me my vision big now.
Can we switch and come back?
Yeah. Now we can go. Now we're done with this thing, closure. You can pull out the scope now.
Kothari sir, audio back with you, sir.
Okay, perfect. So now the goal is that to see the final result, and it's the moment of truth. So this was the area where we were struggling. We dilated up to 20 millimeters. We have to make sure there is no laceration, no perforation, no rupture, which looks good.
That's absolutely perfect, that area. And that's all because of your patience, and you really took your time and worked your way there. We all appreciate that so much.
Yeah, patience is the key. And your G junction was completely fine.
Dr. Triptesh has the largest series on appendicular adenomas in FTRD.
Yeah, so we did an international multi-center trial from Johns Hopkins was the main center, and we were one of the participating centers and of the appendiceal orifice polyps with the EFTR, and it was the first published paper on EFTR for the appendiceal orifice polyps. So this is the pyloric area. We went through this as well. Looks okay. There is no tear. And then we want to see the final product, and we have completely removed the polyp over here. Some bleeding which is self-limiting ooze, we can also control that either with a gold probe or epinephrine injection, or also spray collagen. So that's
a full thickness which we can see,
which
there.
is a complete full thickness. Even a coag grasper would be a good option in such scenarios. So we'll control that mild ooze. We'll wait there for 2-3 minutes, see how it goes. If it still keeps oozing, then we will control that with coagulation grasping forceps and take care of it. But this is a complete removal of the neuroendocrine tumor.
Okay, sir, thank you, sir. We will move on the next step and come back to you, sir.
Thank
you. Kishore sir, audio back with you, sir.
Okay, thank you very much. Okay, can we have fluoro, please? So while you were in the other room, what we did was to fragment, well, we saw that the stone has largely been fragmented, and we worked on it a little bit more with this trapezoid basket over a guide wire. And what we're going to do now is just to trawl out here. What are we going to do for this patient in the medium term? Well, she's 94 years old, and She has what appears to be a distal cholangiocarcinoma. I think it's really much more than just a reactive change in the distal biliary epithelium, because there was obstruction to the trapezoid basket as we were trying to put it in just now. Now, can you see all those fragments here?
So, Chris, your preference of trapezoid basket over a
Close,
balloon?
please.
Any
Yeah,
specific intention for that, or
yes,
you're
the
more
reason
comfortable?
I use both, but in a situation like this where the distal CBD is a little bit narrow, and we think because of the relatively early cholangiocarcinoma, we don't want a stone to get stuck. And so we certainly have more options when we're using a lithotripta basket, such as the trapezoid. We're kind of a
I
little
think
bit
that's
stuck
good
there.
fragmentation. You have almost
Yeah, we do.
cleared
And I'm
everything.
trying to get the basket out for another pass at this. Here we go. Okay, so always stay close, full scope tip up, let your elevator down, and then you see we're getting a little bit snagged there, and I think it's because of that, partly because of that tumor down below. Screen, please.
Screen, fluoro. Screen.
X-ray. Same thing. Okay, if we continue to have trouble here, then we may just swap this out for a balloon and then finish it off with a balloon. The problem is using the second time, the basket doesn't quite close all the way down, and so you're left with a bit of a shoulder. Okay, we're in. Fluoro, please. Yeah, usually with a bit of effort you can get yourself back in. Okay, so open the basket, please. Yeah, open fluoro, X-ray.
Screen.
Open baskets, please screen. There's a fair bit of air in there. Jiggle. Line up against with your bile duct by putting the scope in. And then fluoro, please. Fluoro. And then trawl back out. And there'll be more stuff, as you can see. Close, please. Now back in for another pass. And so we need to leave her with some drainage, because we expect that with the narrow distal CBD, there's going to be stasis and more stones forming, or potential for more stones forming. One potential solution for this elderly woman is a little bit radical, in the sense that you can put a fully covered wall flex stent, and keep the bottom end open, and all the small stones will fall out. So that's actually not a
Do you
bad.
still prefer if she has an intact gallbladder or fully covered?
Well, for the 20% or 15% that might get cholecystitis, then we can drain them fairly easily. But we do have the option. Yeah.
Right.
Yeah.
Okay.
And then there'll be a axios to show. Okay, fluoro, please. Fluoro. Okay, open basket. Unfortunately, we don't have a fully covered wall flex. No, that's unfortunate, because that would be really good for this lady. Minimize
So
the number of
any tips for the beginners, Chris, how to do this basket trawling? Whether you have to put your
Yes.
scope very near to you or away from you.
Yeah. So what we
you
want
often
to do
tend
is,
to slip.
Yeah, this patient, I think, is difficult because of her anatomy, and the scope keeps slipping. But when we are doing, one of the early principles I learned about stone removal is that you need to line up with the bile duct. Maybe we can. Why don't we put a balloon in here? And the
So
idea.
you want a stent or you want a basket?
No, we're going to just pull a balloon through just to demonstrate some of the principles involved in balloon trawl of the bile duct.
Yeah.
And principles really for success. So the idea being that if we look at the fluoro, can you turn the fluoro on, please? Now, if we just pull the basket, the basket or balloon like this, right down at the bottom, you are no longer parallel to the bile duct. right? And so you don't have that the great mechanical advantage that you have when you are pulling parallel to the
Got it.
the bile duct. So what you need to do in that situation is to push the scope in and turn right, with the balloon all the way down, and I'll show that to you in a minute.
Okay.
Okay, so we're getting our balloon in. Okay. Fluoro, please. Okay. All the way in. Yeah, pull back on
Kishore sir, we are
okay.
watching you. We will
Okay.
move on the next set and come back to you, sir. Yeah, thank you, sir.
Oh.
Alright. Amal sir, audio back with you, sir.
Okay. So we've, yeah, same clip. You can give. I think we'll need about 8-10 at least. So we're now closing. We've completed hemostasis. We've made the wrap and everything. So now all that remains is closure. So anteriorly when we close, we again start at the apex and then move proximally. Your first clip is the most important clip because that opens up your apex and the angle where your subsequent clips can be applied. Now open the clip. So I'm using the Olympus clips over here, the EZ clips. And now it is important to have the clip oriented exactly perpendicular, perpendicular and this way to the mucosal edges. And for the anterior, you have to lift the clip up like this, and then suction and then push out.
1, 2, 3.
And then fire. Yeah. Right.
So how beautifully Dr. Amol is demonstrating the clipping technique in the anterior myotomy. So and to all the viewers, we're not going to have any lunch break officially, but however the procedures will continue. So please grab a sandwich and Coke if you want. If you're not a hepatologist, not worried about the calories, then you can grab a Coke and have a good okay, not worried about reflux? Yes, you should grab something, keep eating, keep munching and keep drinking as you're watching further procedures. So we saw three beautiful procedures which happened parallelly. In one room was the full thickness resection, the EFTR, endoscopic full thickness resection that went on for a lesion in the duodenum, a neuroendocrine tumor in D2, which is sitting opposite the ampulla on the mid part of the D2, and Dr. Triptesh Kothari did a beautiful demonstration. He just removed the specimen and then gone ahead and then also coagulated any possible vessels with the endograsper and then has come out. And on the other side, Professor Chris Kaur and Rakesh Kalpala were doing the ERCP, spike cholangioscopy, and a large calculi sitting on top. And the reason for that was a villous adenoma at the distal end of the common bile duct, which they beautifully demonstrated using spike cholangioscopy. They've done biopsies, and then they went ahead with laser lithotripsy, and using holmium laser, they just blasted the calculi. This is a new holmium laser machine that has been supplied by Alangers. So it works beautifully. They just blasted off the stones. They just went ahead and did balloon trawl and then delivered all the fragments, and they have put in a stent. And now in this room, which is going live, we saw what is called a poem F, and Dr. Amal Bapai did an anterior myotomy poem. So he took an anterior route and then beautifully demonstrated, went ahead, crossed the diaphragm. He demonstrated the mediastinum, the pericardium, and then showed the diaphragm. after crossing the diaphragm, he just took the plane after looking at the liver and um, ligament, the falciform ligament, and then he took to the left and then made a perforation in the peritoneum, the visceral
Sir,
peritoneum, and then went out into
BGM,
the
sir.
peritoneal cavity, and then went on to put microtech clips on the fundus, and then he applied 3 clips on the fundic side along with the endoloop. The first clip that he took had an endoloop at the tip of the clip, and once he went in, he just fired the first clip, and then uh, you know it was loosely held. The endoloop, open endoloop, was loosely held by Dr. Ravishankar, who was very ably assisting him. And then he went on to put 2 more clips holding one limb of the endoloop. And then after that, they pulled the whole assembly into the tunnel. So that fundus had a wrap which is pulled into the tunnel. And once he was inside the tunnel, he just again deployed 3 more clips, clipping the whole, like endoloop limb onto the musculature, the muscularis propria that he had cut inside the tunnel. So this way, he had completely, tightened the wrap, put the whole wrap inside, and then also clipped it to the tunnel so that it doesn't slip back out. And then after checking for proper hemostasis, he just pulled out the scope, and now he is closing the tunnel. Now we are using Olympus metallic clips, the hemo clip, which we're using. So multiple
Sir.
clips are being used. We started with the apex, down below. The first clip is always of paramount importance, where we use the first clip at the normal edge along
Sir.
the normal tissue, and then we start clipping one after the other. Almost the tunnel closure is going through, and we had put in a needle and syringe filled with saline and in a sterile way, and then the capnoperitoneum was getting continuously let out. So now there is no more carbon dioxide flowing out. It's completely, abdomen is soft and relaxed, and no more capnoperitoneum here. So I think the last few bubbles, I'm just pushing to release, and then we can get out with the needle. So the procedure has gone on so beautifully, and I think everybody in this room will give a big round of applause to Professor Amal Bapai for that lovely demonstration. Uh, yeah, it was a pleasure to see you in action. So the master teaching us on Poem F. So we have with us Dr. Chenduran, Dr. Sangameshwaran, and Dr. Girinath from Vizag. They're all here, big stalwarts. They're going to also, teach us in the afternoon session. They will also have more sessions to demonstrate to you. So we are going without a lunch break again. So please, yeah.
Okay, sir.
And Dr. Harish, and Harish, doctor, please come here. And Dr. Majid is on the other room. They both are our anesthesiologists and intensivists. They did a fantastic job along with the anesthesia team and the entire nursing team, which I'll very soon introduce to all of you. So we'll have an introduction of the entire team.
Sir, thank you, sir. We will move on to the next lecture, sir. Thank you.
Yeah, thank you.
Ma'am, you can proceed your lecture, ma'am.
You can start.
I can start. Perfect. All right. Thank you, Dr. VGM, Mitra, Madhura, Vamshi, for inviting me to this wonderful conference. And it's been a great day. You've been seeing some great cases by experts. And we are going to talk now about nightmares in ERCP. We saw some really nice cases during the live demonstrations, and we will talk about when things don't go as planned. So in this talk, I will review some ERCP challenges and nightmares and discuss some interesting and challenging cases and some tips and tricks on how to overcome those challenges. This talk is in no way intended to discourage the young faculty from performing ERCPs. And another disclaimer, all the complications shown in this talk are not mine. So as Dr. Cotton very famously said, ERCP is most dangerous in those who need it the least. And it is truly an advanced endoscopy procedure. We primarily do it as a therapeutic intervention. It is resource intensive, invasive, with a high litigation potential, and does require commitment. It is extremely gratifying when it's successful and but extremely painful when it's not. So your standard no fuss 10-minute ERCP, you're in and out and you feel great and you feel like you've conquered the world till you have the next 3 hour long difficult case and you're dealing with various nightmares and that is the humbling experience. So nightmares do start when you're not even able to see the papilla. If it's an intradiverticular papilla, there is tumor infiltration, altered anatomy, and nightmares continue when even after cannulation there is a bleeding or perforation, or you encounter stent migration that are causing complications, or dealing with difficult stones, as we just saw in the prior case. The main do's and do nots when you encounter any nightmares during ERCP, or for that matter, any procedure, the main thing is stay calm and understand it's inherent to what we do in the world of endoscopy. Anticipate it in difficult cases, and early identification and intervention during the procedure is key. Call for help, call for a second opinion, senior partner to be in the room if you know you're dealing with a difficult case, and listen to your staff in the room. Multidisciplinary management is key. Make sure you have your favorite surgeon or IR backup when you are in trouble. Communicate, document, and learn from the case. Don't discharge the patient if they're having symptoms. Don't panic, and don't try to fix the problem inadequately or cause another problem while trying to fix the primary one. Keep good communications and do not beat yourself or lose confidence. So, starting with cannulations, difficult cannulations are one of the first nightmares that we encounter. And, if you have greater than 5 contacts with the papilla or more than 5 minutes, that has been defined as a difficult cannulation. However, difficulty gets even worse when you can't even see the papilla. And here you can see a patient with an intradiverticular papilla, and then EUS guided rendezvous is performed. The bile duct is punctured using a 19 gauge needle. The scope is in the short position when you're doing the rendezvous. Contrast is injected to delineate the bile duct, and the guide wire is advanced across the ampulla. The EUS scope is withdrawn, and then the ERCP scope is advanced. And you could either cannulate alongside the wire that has passed out of the ampulla, or grasp the wire, and then the procedure can be successfully completed. However, not all papillas look that normal. This is an ampullary tumor invading into the duodenum. And the main thing is you want to spend enough time evaluating the area. And lo and behold, you can sometimes find the biliary opening. So spend time, stay calm, and don't give up. And we were able to cannulate the bile duct. You could see a distal bile duct malignant stricture, and a metal biliary stent was placed for palliation. This is one of the largest ampullary adenomas I've seen, and not all ampullas can be found. And this patient needed an endoscopic ampulectomy. Altered anatomy is another nightmare that we encounter. I've had the privilege to work with Dr. Anastvad for the ASG to write the document on this, and I would encourage everyone to read it. Going into every detail is beyond the scope of the talk, but the main new kid on the block in altered anatomy ERCP is the EUS directed transgastric ERCP, where a lumen-opposing metal stent can be placed between the gastric pouch and the bypassed stomach. And here you can see under EUS guidance, we find the remnant stomach. Contrast is injected along with saline or water to distend the bypass stomach, and then a lumen-opposing metal stent is placed to create a gastrogastric anastomosis. and the ERCP scope can be advanced across the stent to the major ampulla. However, the nightmares don't end there. This was a difficult cannulation, and the guide wire advanced in the PD, and then needle knife access of the bile duct was performed, and the stones were subsequently removed. So nightmares after cannulation. So you got in, and then you're dealing with the adverse events associated with the ERCP. And again, I was fortunate enough to be a part of the Standards of Practice Committee to write the document on adverse events in ERCP. Post-ERCP bleeding can occur in up to 1% of the cases. It's classified between mild, moderate, and severe based on the transfusion needs, and if IR or surgery is needed as further interventions. Thank to Dr. Desai for Pankaj Desai for sharing this case, and so it looks like our video is not working. But anyway, the main thing is a multimodality therapy for post-sphincterotomy bleeding that was then managed with a fully covered metal stent. The main thing is to make sure you minimize complications. You collaborate with the cardiologist, the neurologist, use blended current rather than pure cut current, and adequate resuscitation is key. You watch the site. If you're having a post-sphincterotomy bleeding, make sure you've lavaged the site, watched it, and severe cases may need IR or rarely surgery. So what happens after a perforation? It's an endoscopist's worst nightmare. The incidence of perforations during ERCP range from 0.8 to 0.6%. There are 4 types, 1, 2, 3, and 4. Whether it's scope-related duodenal perforation, type 2 is the periampullary perforation or sphincterotomy related. Type 3 is the ductal or duodenal perforation, and type 4 is the guide wire perforation or presence of retroperitoneal air. If you look at the ESG guidelines, endoscopic closure is now recommended whenever possible for endoscopic perforation. So if there is a duodenal perforation, the main thing is focus on the gas shadows on the fluoroscopy. Early recognition is key, and you could use either endoscopic clips, over the scope clips, endoscopic suturing, various devices to close the perforation. Periampullary perforation, avoid zipper cuts. You could place a fully covered metal stent. Guide wire perforations are usually small and they heal easily. The main thing is to make sure you stent the bile duct. This was a G junction perforation that occurred at the ERCP scope was passed out into the retroperitoneum. This was immediately identified and an over the scope clip was placed. However, the area was completely occupied by the clip, and thus a fully covered metal stent was placed across the G junction so the patient's secretions could pass into the stomach, and contrast injection revealed that there was no leak, and this was 8 weeks later. The site had healed well, and the patient did well. This is a CBD guide wire perforation. The patient in pancreas cancer. The guide wire advanced. However, on the cholangiogram, you could see that the guide wire and the contrast were in 2 different planes, and a perforation was immediately identified, and a fully covered metal stent was placed across the area, and the patient did well. Migrated stents are another area which can cause nightmares. They can cause luminal perforations. They can cause peritonitis. So the main treatment is that you remove the stent and you close the perforation. So this, we published a case where the plastic stent had migrated out and perforated through the lateral duodenal wall. And then we actually cut the stent with endo scissors. And here you can see the stent is perforating the lateral duodenal wall. And we actually cut the stent using endo scissors. And the main thing is you're using CO2, you're doing this under controlled circumstances, make sure you've given antibiotics, and then the shaft of the stent was removed. and then the cut portion of the stent was removed using a rat tooth, and the perforation was closed using endoclips. The patient actually had PSC, so that we couldn't have just yanked the stent and pushed it up into the intraheparix. And here, using endoclips, the perforation was very successfully closed, and this was 2 months later. This is a metal stent that migrated distally, and it was an uncovered stent. A long stent was placed, and it perforated through the lateral duodenal wall, causing ulceration and bleeding. And we did endoscopic welding with APC, and then the back wall had tissue ingrowth. So wire by wire, the stent was cut using endoscissors, and then the migrated distal portion of the stent was successfully removed. So even metal stents have their own set of nightmares that can make things very difficult and cause ulcerations and bleeding if they do migrate. Difficult stones have their own challenges, as we saw in the last case. However, laser lithotripsy and electrohydraulic lithotripsy have revolutionized how we manage these. And, a study by Dr. Kashaf that we were also a part of, we did show that difficult stones can be managed successfully with cholangioscopy and with DHL and laser lithotripsy. This is a nightmare where the nightmare continued. Large stone cholangioscopy performed, beautifully fragmented stones. Fully covered metal stent was placed. However, at the subsequent ERCP, the stent had migrated proximally. And then using cholangioscopy, the distal end of the metal stent was grasped and the stent was successfully removed. So you could see sometimes the challenges in the same patient can continue, and you just need to come up with creative solutions to fix the problem. And then the cholangioscope was again introduced into the bile duct to document if there were any stone fragments remaining, which were then subsequently removed. So the main essential take-home caveats are: make sure you have an appropriate indication for the ERCP, you've taken a detailed informed consent, and early identification of any complication is key. You have the appropriate infrastructure, resources, staff, and you work as a team. Open, clear communication, especially if things are going south in the room, is very important. It can be a life-altering procedure for the patient as well as the endoscopist. So make sure you anticipate a difficult ERCP and you're prepared to manage any complications, and also that alternative exists when ERCP fails. So difficult situations may need creative solutions. Partner with your surgeons and IR, but main goal is always keep your patients safe. Thank you.
Thank you, ma'am.
Thank you.
Sweet memories keep haunting me, and deep in my soul I know you are mine, and my heart belongs to you.
Dr. V.G. Mohan Prasad, Chairman of VGM Foundation, for this initiative.
Sweet memories keep haunting me, and deep in my soul, I know you meant, and my heart belongs to
Doppler, please.
Velama.
Dr. Ravi sir, you are on live sir.
Can I see the image again? Scope tip.
So Dr. Praveer Rai is here.
Sir, ma'am, your mic on.
Dr. Praveer Rai is here to demonstrate. This is a 65-year-old lady who was is a known case of metastatic hilar cholangiocarcinoma, and she underwent biliary metal stenting into the right system, and she did well for a month, and after that she developed some features of cholangitis, and subsequent ultrasound showed the left system to be dilated with internal echoes suggestive of cholangitis. She had fever and counts elevated, jaundice, and those are her images there. Next. So here we are trying to demonstrate EUS guided biliary drainage, hepaticogastrostomy. So it's indicated for benign and malignant biliary obstruction when conventional ERCP is unsuccessful, whereas here we want to access the left system and do a hepaticogastrostomy. And there are different techniques, and here we are going to go with the hepaticogastrostomy. And over to Dr. Praveer Rai.
So a very good afternoon. Firstly, I would like to thank Dr. V.G. Mohan Prasad and his whole team for providing me this wonderful opportunity. I'm really impressed by their warmth and the humility they have shown. So I think it's amazing. So coming to the case, so what I'll do, I'll just quickly show you the linear EUS anatomy before we go ahead and try to establish the biliary drainage while hepaticogastrostomy. So the standard technique that I follow is usually the evaluation of the mediastinum, evaluation of from the stomach, and then evaluation from the duodenum. So I'll just start with the mediastinum. So in the mediastinum, what usually I do is I try to focus first the IVC, try to localize the IVC, and if you see right now the linear anechoic structure that you are seeing right now should be the IVC. And if you trace the IVC, so this structure that you are seeing is the IVC, and the IVC goes to the right atrium. This is the right atrium, and it's pulsatile, it's pulsating, and then if you just pull back, keeping this in view, the other structure that you see is the left pulmonary, the right atrium. So right atrium, and if you pull back, you see the left atrium. So right now, can we have the marker there? Can we have the marker? So the structure that you are seeing on the left side, just below the probe, this one is the left atrium, And on the right side we have the pulmonary artery. So this is the pulmonary artery. The space in between these two is known as subcarina, or the station 7. So this is one of the most crucial stations that you want to know. And here you can look at other structures as well. So right now if I just do some clockwise movement, then you can see right now the aorta, the aortic valve. Are you able to appreciate the valve here? Just below the cursor, down, down. So you can see this valve here, and this is the aorta. So first is a subcarinal space that is known as station 7. And then if I just trace the aorta, you can see the linear again anechoic structure, that is the aorta. Below this you have the mirror image, that is known as reverberation artifact. If I just pull this back, keeping aorta in view, the aorta starts arching. So once the aorta starts arching, you push in a centimeter, and then rotate. So if I do that, what I have is on the right the aorta and the left the pulmonary artery. So this is the pulmonary artery. Cursor is on the cross is on pulmonary artery, right side of the aorta. The space near to the probe is 4L, and space below between these two structures, this is 4L and this is station 5. So this is known as the AP window. So AP window, mind you, is station 5, and again you can have lymph nodes here. So if lymph nodes are present in this area, they are usually pathological. So this is the important anatomy that you have in the mediastinum. Coming to imaging from the stomach, your home base is the aorta. So you can see the aorta right now, and from the aorta, if you see take off from the aorta, that is the celiac artery. So that is the celiac artery above. This is the celiac artery emanating from the aorta. And if you see a linear, again, hypoechoic structure, a black line, that is known as the crust of the diaphragm. So what you have, crura, you have celiac, and then if you see another structure, below the celiac, another structure that is emerging, vessel that is emerging, is the SMA. Are you able to see SMA? Just put the cursor on SMA. So just below, so that was the celiac. Below this, no. Yes, this is the SMA. So these are just like two fingers pointing towards the pancreas. So you have the aorta, you have the celiac, you have the SMA. You just push in, and once you do that, you fall on the pancreas. So right now the structure that we are seeing is the pancreas. So if I describe the pancreas right now, it has got some hyperechoic strands there. The rest of the pancreas looks okay, but you have hyperechoic strands present in this pancreas, which is obviously not normal. The typical appearance of the pancreas should be a salt and pepper appearance. And if you see this, if we rotate from here, you see I'm doing a clockwise rotation and slight pull. You see the kidney. So you are seeing the kidney right now, again with the cortex and the medulla. If I pull back further from this, then you should be seeing the spleen. So you should see the spleen. So this is the spleen. Again, going back, if you go back again, you see the kidney in picture, and above the kidney you should be able to appreciate the adrenal, which should come into picture. And then if from this again you fall on the, so that is the pancreatic duct you are visualizing. What you can see here, the pancreatic duct, the walls of the pancreatic duct are a bit hyperechoic. That is another one of the feature of chronic pancreatitis. So at least 2 features, you need at least 4 features to say early chronic pancreatitis. So if I just, you see a vessel, 2 vessels there. So the vessel near to the probe is the splenic artery. Another vessel just below that, the larger one, is the splenic vein. So you can put Doppler to confirm that these are vessels, and I'm not, yes. So if this is a splenic vein, they should combine with remove the Doppler. If this is splenic vein, they should combine with the superior mesenteric vein to form the portal vein. Let's see whether it does or not. So this is a splenic vein going, and then you have the splenic vein going. We are still not seeing the union, but then if this forms the portal vein, that should go into the liver. So this is, we are still, so I'll just try to focus it. This should go to the liver to form the portal vein. Okay, we'll just come to that again. So you can see some lymph nodes also. These are peripancreatic lymph nodes. Just point in the lymph nodes. Yes. So those are the lymph nodes. These are again elongated lymph nodes, not typical of the malignant lymph nodes. And again, you from here also you can trace the bile duct and the portal vein. So if you see, this is the liver, this is the portal vein coming out, this is the portal vein coming out of the liver. So just focus on the liver. Yes, so this is the liver. So just put Doppler here. Yes. So this is the portal vein coming out, portal vein coming out, portal vein, portal vein. And below this, ideally we should be seeing the bile duct. Just remove the Doppler, please. Below this, we should be, are you able to see something inside the bile duct, which is possibly the metal stent, which it is? So can you just focus the metal stent? So that is, metal stent is seen as whitish defects. So yeah, so this is the metal stent that has been placed in the bile duct. I'm just tracing it, and this is coming almost up to the hilum. So this is the metal stent, you can see that, and reaching almost up to the hilum. So that's what, and you have got some artifact here because of obviously the metal stent, and just put Doppler here, put Doppler. So this is the portal vein, and if you see below, you are seeing some mass lesion inside this portal vein. Are you able to appreciate, just remove this Doppler, please? So can you see that? Some echogenic area inside, this can well be a tumor thrombus. So that is one of the things that you can have in the portal vein. So now let's go straight away for the procedure, that is the biliary drainage. This patient you have dilated, so the ducts are not significantly dilated, the peripheral ducts are not dilated, though the central ducts I can see significant dilatation in the central duct. How the peripheral ducts are not significantly dilated. So once the peripheral ducts are not significantly dilated, you may sometimes have a problem. So this is the dilated duct that I am able to figure out. So for so first we should see that we need to puncture the segment 3 duct. That's what I am trying to figure out. Yeah. Yeah. So right now the ducts that we are seeing. So if I just so ideally you have the segment 3 and segment 2 separated by the left hepatic vein. So can we just put Doppler? Okay. So the structure that you are seeing right now, so here what I think is that this is the segment 3 possibly. Segment 2 is just above it, which is not significantly dilated. The duct that you are seeing right now, it should be the segment 3 duct. Just remove this Doppler, and once you can just trace this and see whether it unites with the segment 2 and forms the bile duct or not. So you can see the stent, since the stent is in place, I think the main bile duct is not dilated. Yeah. So you can see quite thrombus intraluminal in the ducts. You have a significant echogenic material present, which can well be sludge there in the ducts. So let's go ahead and try to puncture the segment 3 duct, which this should be the segment 3 duct. So I need to be sure, I need to be sure that we are not going through the G junction, otherwise it will be a transesophageal placement, which is not a good thing to have. So you want to do a transgastric drainage, otherwise there is a risk of mediastinitis. And I want to see the position of the scope. So can I have the position of the scope on fluoro, please? Okay. So this again may not be the best position to have, because what you want is your needle should ideally be pointing towards the hilum. Otherwise it becomes difficult for the wire to move up to the hilum. But unfortunately this is the best position I am getting where I can see and puncture the duct. Okay. So that's known as a moving scope technique, or that can be done, but the best is to have a position where the needle is pointing towards the hilum. Okay, so can I have the fluoro again? Fluoro, please. Can we have a better image? Okay, that's okay. Okay, so I think we can go ahead and puncture this. Madhura, what do you think? We can apply Doppler?
You're the expert.
Okay. So Doppler, please.
We need it to be 4 centimeter into the.
So normally the hepatic parenchyma intervening should be between 1 to 3 centimeter. However, if the length of the hepatic segment is less than 2.5 centimeters, then the chance of bile leak is more. Okay, can you have fluoro, please? Okay, so this is the best position that I am able to achieve. Can we have the needle, please?
You're using a 19 gauge needle.
So first we'll use a 19 gauge FNA needle and puncture the duct and then try to aspirate bile. After aspiration we need to inject contrast. Okay. Okay. So we'll just focus it again. Okay. Fluoro. Okay.
From the fluoroscopy, you're determining the angle of the needle and is it towards the hilum? Is that what you're determining with the fluoro?
Yes. So you want obtuse angle ideally between the needle and the hilum. So that's what you want. But again, that may not always be possible, and we may. So this positioning is very, very important, or I would say one of the very crucial steps, because if you don't select the duct right, you may obviously have difficulties. Can we apply Doppler, please? Fluoro? Okay. Can you just remove the fluoro? Okay. Fluoro, please. Okay.
You can notice how every time he is checking fluoro and the position. So that is the puncture is the most crucial step. So the angle and the site of puncture has to be checked every time. When he put in the needle, the angle changed. So he's repositioning again.
Fluoro. Doppler, please. Off. Fluoro. Fluoro, please. Okay. Doppler, please. Okay. Just remove the Doppler. So we are trying to again Doppler once more, please. Yeah, please. So we are just nearing to the G junction, And we are going to the dilated duct here. So okay. 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 So aspirate bile, please. इधर से आना पड़ेगा. So what we have done is we have punctured the duct, segment 3 duct, and I can see a lot of intra contents, possibly sludge there. And we'll aspirate bile first. Can I have the fluoro, please? Okay. Yes, aspirate. Please. Okay. So let it come.
You can focus on the aspirate here. Can you see on the, can you focus on the aspirate?
Yeah. Yeah. Wire. Fluoro. Contrast. Please, contrast. Less pressure. Too much pressure on the needle. Fluoro. Okay. Okay, so we have punctured very near to the, so this comes out to be segment 2 duct and not 3 duct. But what I am convinced that it is below the G junction.
Absolutely.
So that should be okay.
Yes. We can see the diaphragmatic above it.
Yeah. So
we will make sure that there are no bubbles in the contrast because it will disturb the EUS image, or is that usually so?
So you can pass the wire now. So normally we tend to avoid segment 2, which because it's usually trans-esophageal, but here what I am seeing is my scope is well below the G junction, so it should not be an issue. Okay. Fluoro, please. So there's a lot of, I think the contrast possibly was not diluted, and that's the reason we are seeing a lot of contrast there. And wire, can we see the wire, please? Oh, wire has gone down, is it? Fluoro? Yes, it was down, yes. I think that should be okay. Yeah, deep. Yeah, that's okay. So we'll exchange this wire now. Exchange. Okay. Fluoro. So what we have done is we are exchanging this wire, and then we'll pass a 6 French cystotome.
Would you prefer an 8 French or a 6 French usually?
Fluoro. 6 French, please. Okay. That's okay. So I need a cap of this and then the cystotome over it.
So the delivery system is going to be 8.5 French, so we need to...
Yeah, so I think routinely in all patients we are using a 6 French cystotome, and what I can tell you is that with 6 French cystotome, usually it's not an issue. So though I know that the delivery device is higher, but the stent usually goes in easily. The reason I don't want to dilate much is the main concern here is a bile leak which you want to avoid. But obviously, if you're not able to insert a stent, then obviously we'll struggle. That's also is true. But we have been routinely using 6 French cystotome without any dilatation, and it usually goes in.
Do you also use any dilator like a Sohendra over it or
No.
nothing? That's
So
it. That's the
it's
only
a 6 French cystotome alone, and usually it does the job. So let's see.
So you can notice that Dr. Praveer is holding the position absolutely stable, and you have turned off the endocarbon acids, the carbon dioxide.
CO2
and
is not
CO2
required once you have position,
yeah,
because
so everything is off so that
yeah.
the image is perfectly in position.
Fluoro. 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 Just give me some CO2.
So you're using a dry cut or a pure cut to go for this, or what do you use, sir?
Yeah. So normally, I think with normally endocut, the things goes in easily. Usually not an issue. But in case if it doesn't, then you can use a pure cut, effect 4 and 100 watt that you can use. So fluoro, please. Okay. Fluoro, CO2 off, please. Okay. Please, cautery. Yeah, this is quite slippery actually. Okay, we'll just try with this. Fluoro. Fluoro, please. Okay. Fluoro, gone. Let me just go in further.
Praveer sir,
Please keep wire in place. I'll just pass this further. Yes, please, sir.
Yeah. No, actually, what the faculty was feeling was, is
Yeah.
it truly
Fluoro.
a grossly dilated system? There's a minimal dilatation, so it doesn't
Fluoro.
warrant drainage.
Yeah.
Was a
So
question.
I think there is no doubt the system is dilated for sure. I think once we have bilirubin which is up, right system is drained, we obviously have an indication to do it. Fluoro. So
That was
Just
exactly how I felt also. After draining the right system, 1 month the patient did well. And then again
I'll
went
exchange
ahead
this
and
again.
developed
I'll go in 2-3
jaundice
times.
and
Fluoro.
cholangitis, rising
So what I'm
bilirubin.
trying to do is I mentioned that this is a 6 French cystotome. I'm just trying to ensure that we have a smooth passage of the stent, because this is 6 and the stent, fluoro please, and the stent would be your 8.5. So that should be okay. Wire deep please. Your wire somehow is, just take the wire and let it go through the stent if possible. Keep the wire, because I don't know where it is going. Yes.
Now
Yes.
you're in.
Good.
Yes, beautiful.
Good. Okay. Okay. So that's okay. So now the last step would be the deployment of the stent, and we'll go ahead and do that. What you need to ensure that the position is stable, and as I mentioned, I would definitely have preferred the segment 3. I thought it was segment 3, but again segment 2, and what I was checking in between is that we are not going through the esophagus above the G junction. That is what I wanted to check. To me it appears we are below the G junction, so that should be okay. Fluoro please. Off. And then comes the last step, that is the deployment of the stent, and what we are using is a geobore stent which has 3 centimeter which is uncovered, which goes inside, while the 7 centimeter is a covered portion that basically bridges between the liver and the stomach, just to ensure that you don't have bile leakage. So I'm using a 10 centimeter long stent, and then and this is a 10 centimeter long and 10 millimeter diameter stent. So 1 centimeter in diameter and 10 centimeter long stent. So this is what we are using right now. So if you can focus on the stent, so this is what the stent is. This is Taivung by 90S, and these are the specifications. That is 10 centimeter long and 10 millimeter in diameter, 3 centimeter uncovered and 7 centimeter covered portion. Okay. So what you want to achieve primarily is that around 3 to 4 centimeters of the stent should be in the stomach side. And the reason why you want to ensure this is that the risk of migration is avoided, because if you have migration in such cases, obviously there is very less that you can do then about it. So you have to be very, very cautious that the stent does not migrate, and that's the reason we are choosing a long stent, that is a 10 centimeter stent. So this 10 centimeter stent I will choose in each and every patient of mine. We rarely use 8 centimeters, it's always a 10 centimeter long stent, and you should try that you have 3 centimeter segment of the stent in the gastric side. So that's what you want to ensure. Fluoro. Wire taut please. So I think it has gone in. We obviously don't want it to be too deep. We want it at the level of hilum. There, that's where exactly it has reached. So I think that should be okay. Can I have the fluoro please? Yes. Wire taut please. Okay. So that's okay. Then we can, the last step, that is the deployment of the stent, we can go ahead and start that. So please open up the stent. Huh? Fluoro. Okay. Open, please. Open, please. Please. Don't pull. Okay. Open. Please. Open. Can you see the marker? Actually, a lot of contrast, and it's really hampering the vision of the seeing the stent properly. So that is a problem here. Anyways, Fluoro, please.
And this also shows that this system is not getting drained.
Yeah. Fluoro. Okay. So that's looks okay to me, and we now will go to the endoscopic image.
We can see the expanded stent well inside the
yes,
duct.
that we can see. Yes.
Beautifully. Now endo image
yes.
bigger, please.
So, and I want CO2, please. Fluoro.
Okay. Yes, there we go.
Okay. Yeah, please. Go ahead.
So the deployment will happen within the esophagus and then it will retract, or you want to deploy it in...
So I'll deploy it in the stomach.
Stomach.
Fluoro. Fluoro, please. Just wait, just wait.
And is there a yellow indicator here?
Yeah,
there
we
is.
have.
Okay.
Fluoro.
Which means we need to...
Opening. Just wait. Fluoro. Okay? Go ahead.
Perfect.
Go
inside
ahead.
You are very much well inside and...
Yeah. Okay. Okay.
Wow.
So
That
we
is
have
amazing.
around 3-4 centimeters in the stomach, and I think I'm perfectly happy with that.
Fluoro. Yeah.
You can see the bile draining nicely
good.
as well.
Draining very well.
So slowly. Please, Fluoro. Fluoro, please. Okay.
Yes,
Just slowly.
See, slowly, trying to remove the obturator so
Fluoro.
it doesn't get caught, doesn't pull the stent. I think, we made beautiful points. Professor Praveer Rai very clearly demonstrated this is a dilated obstructed system, because once he put in contrast, it was not draining into the other side or down.
Yeah.
So which means this definitely requires to
Fluoro.
be drained. Fluoro.
So I'm very happy with the position of the stent. That looks perfectly all right to me.
Absolutely.
Yeah. Thank you.
So great delivery. Please give a big round of applause. So the
Thank you.
Geobar stent, which was deployed in the left system, and already we have a metallic stent, self-expansible metallic uncovered SEMS in the right system. So this is a beautiful demonstration of the Geobar stent deployment in the left system. So. Now friends, Professor Mark Knorr from United States is going to give a talk now on the role of electrogastrography in the diagnosis of dysmotility disorders of the stomach. So following this will be an array of cases. There are a lot of interesting, exciting cases that we're going to witness. So please stay on with us, and we'll go live in a few moments as soon as the lecture is over. Over to the lecture, please.
India, especially to my dear friend Dr. VGM, and thank you very much for this kind invitation. Today I'm going to talk to you about electrogastrography and the water load satiety test, especially as we use this to define gastric myoelectrical activity, which then defines patient subsets of disease. I want to especially cover some new developments. In other words, what you need to know in 2023, which is actually what they already knew in the 1920s, but were unfortunately forgotten. Today, we're going to look at what we need to relearn. I'd like to cover the anatomy and physiology of the gastric myoelectrical activity, and in particular point out that we are not directly measuring motility, but actually measuring the electrical energy that is reflected by motility. I want to talk specifically about a new concept known as the ICC motor unit, which is quite important. And one cannot discuss the anatomy and the physiology with, of course, paying homage to the Walter Cannon story, or what we will call 3 pumps, 2 bumps, and a true sphincter. Then I'd like to get into some of the GMA-specific diagnostics where we can link GMA to disease states and subtyping, and how that, along with AI-suggested diagnosis, can lead to disease-based intervention with improved therapeutic outcomes, thereby personalizing and optimizing outcomes, and perhaps changing the diagnostic paradigm. Let's first begin with the most important thing, which is that EGG detects the ICCs of the smooth muscle. And this is the key to motility, but it does not end there. We do know from previous publications that the electrogastrogram is as though you were doing a full thickness biopsy of the stomach muscle, and you would be able to see the number of ICCs, which is normally 5 per high power field. When there is normal 3 cycle per minute activity, we know that there is normal numbers of ICCs, in particular 5 or more per high power field. And when the 3 cycle per minute activity is low or absent, we know that there is either an absence of those ICCs or something that affects what we will now call the ICC motor unit. The ICC motor unit really is an all for one and one for all phenomena. It is made up of the circular and the longitudinal muscle layers, as well as the myenteric neurons, and then of course the pacemakers, the interstitial cells of Cajal, discovered by the famous Spanish anatomist Ramon y Cajal, for which he received the Nobel Prize in 1907. These make up a motor unit, and unless all 3 are functioning normally, then you cannot have normal motility or contractility of the stomach. This is a very important point, especially when we talk about the hyponormal or absent 3 cycle per minute activity and the potential etiologies. But first, let's talk about the master physiologist and give homage to Walter Cannon, who published The Mechanical Factors of Digestion all the way back in 1911. Walter Cannon was a master physiologist who, using direct observation of gastric contraction, was able to show us actually how the stomach worked that could explain not only how we can explain disease and why disease occurs, but also what we're actually seeing with the EGG. In particular, we'll call this the 3 pumps, 2 bumps, and 1 sphincter approach to anatomy and physiology. When we look at the stomach itself, of course, we know that the ICCs are the most highly concentrated in the area below the fundus in the proximal body of the stomach, and they give rise to the slow pacemaker settings, usually the serosal 3 cycle per minute slow waves that begin a circular contraction that extend longitudinally. This helps to build the gastric pressure gradient, which is necessary but only possible in the presence of a normal functioning high compliance sphincter known as the lower esophageal sphincter. This is the first pump, which is in the body of the stomach, as you can see here. Pump number 1. Now, What's interesting is at the bottom of the corpus is the angularis. And just as I've defined one of the highest areas of ICCs being here in the corpus, in the proximal body, the angularis is actually devoid of ICCs and represents essentially a mechanical speed bump. So the food comes down, propelled through the corpus, pressure is developed, and then it runs into that speed bump. So only a certain amount of food can make it into the antrum, which is pump number 2. The antrum is a high compliance, slow motility zone. This is the second pump, and it only contracts at 1 to 2 cycles per minute, as opposed to the lower compliance, higher frequency corpus of the stomach, which is 3 cycles per minute. The antrum then contracts, and the food moves back and forth, moving between 2 bumps, the first bump being the angularis, and then the second area that is devoid of ICCs is actually the pylorus. By the way, the antrum is the highest concentration of ICCs in the digestive system. So thus you have the first pump, the corpus, the second pump, the antrum, the 2 bumps meaning the angularis as well as the pylorus. And then finally, the third pump is in the duodenum. Now, the most interesting thing that Walter Cannon published is that these 3 pumps do not work simultaneously. When the corpus is contracting, the antrum is usually silent. And when the antrum begins contracting as it fills with food from the corpus becomes silent until food enters into the duodenum, or the third pump area. Once that third pump area becomes active, the corpus will reactivate again. And you can see this quite nicely if you look at standard video upper GI barium studies. So again, it's a completely different way of looking at things, but once we understand that the active areas are the corpus, pump 1, the antrum, pump 2, and the duodenum, pump 3, we then understand what we're really seeing in the electrogastrogram and where any particular misfunction or malfunction is taking place. Let me explain further. Here is what the typical summary graph result is when you perform an electrogastrogram. You'll notice here that this is your normal 3 cycle per minute activity in this right upper quadrant box. I will point out to you that the broken red lines represent population-based normal, and the blue line will be your patient result. This, in this case, would be normal. The Brady, and we're changing the nomenclature, and I'll come back to that in a moment, is actually your antral contractions, which run in the 1 to 2 cycle per minute range. They are normally in the normal range, unless there's an absence of the normal 3 cycle per minute activity, in which case it becomes relatively dominant. What we call the duodenal in the lower right-hand side, these are your typical duodenal contractions that occur in the range of 10 to 15 cycles per minute, and very little changes that. And then finally, what we used to call tachygastria, we actually know now that these are re-entry rhythms that begin in the absence of the normal 3 cycle per minute pacing, that they take over as pacemakers, and again are seen dominant only when there is an absence of 3 cycle per minute activity. Now here is where these 4 graphs correspond to with regard to the stomach. Again, you'll remember the first pump is here in the corpus, and this is where you find the dominance of your 3 cycle per minute activity. Your second pump, which is down in the antrum here, is this slower wave activity. Here is your duodenal, which is your third pump. And then finally, the tachygastria, which are your re-entry rhythms that occur only in the absence of the 3 cycle per minute activity. So what we are seeing when we look at an electrogastrogram and its result is exactly what's happening with each region of the stomach, which helps us to understand both health as well as disease. Now, I mentioned that we're going to talk about some of the new things in 2023, and in this particular case, we're talking about the revised nomenclature. So again, the body of the stomach, which is pump number 1, are your corpus contractions, and that is where you see the normal 3 cycle per minute activity. Antral contractions, we call the gastric slow waves. They are actually quite dominant. because they slow digestion down, because there's only contractility in 1 to 2 cycles per minute. Now, those are typically seen as dominant only in the absence of 3 cycle per minute activity. This is formerly what we used to call bradygastria, and you will see these changes start to take place in your reports in some of the newer versions. Of course, your duodenal contractions we've talked about, this would be pump number 3, and that would be 10 to 15 cycles per minute. And then finally, what we used to call tachygastria, these are really your gastric pacemaker reentry contractions, only seen dominantly in the absence of 3 cycle per minute activity and occurring in the 4 to 10 cycle per minute activity range. These are ineffectual type of contractions leading to poor emptying or poor motility in the corpus of the stomach. Now, when we put all of this together, we're trying to subtype disease. And we do that by focusing on the normal corpus, because this is where we have the majority of the knowledge base. We subtype into either the normal 3 cycle per minute activity, the hypernormal 3 cycle per minute activity, which you can see manifested as the patient results above the broken red lines, or the hyponormal, indicating some dysfunction of the ICCs or the ICC motor unit. This helps us focus not only on diagnostics, but also on therapy. When we look at a patient, whether they have gastroparesis or whether they have dyspepsia, because we now know from the National Institutes of Health studies and over nearly 1,000 patients that these are both the same disease, and they're both manifested as problems with the ICC or the ICC motor unit. If we look at the patients in the hypernormal group, these represent typically 20 to 25%. Because they're in the normal or hypernormal range, we know that this means that the ICCs are in the normal range of 5 per high power field. And we also know that this is due to something known as functional pyloric outlet obstruction. You can also see it in mechanical outlet obstruction, but typically that's easy to see endoscopically. The functional outlet obstruction you will only find using EGG. These things respond to pyloric therapy, either surgically at about 78% or using balloon dilation therapy with a 20 millimeter TTS balloon, and usually there's a permanent response at 93%. Those patients that fall in the normal range of normal 3 cycle per minute GMA, we also know have normal ICCs of greater than 5 per high power field. This is approximately 40 to 50% of the population, and here we can further subset these patients based upon their symptoms. Now, you will recall I mentioned that controlling all of this, that is very important because you have to maintain a gastric yield pressure, is that high compliance lower esophageal sphincter. And if those pressures if that sphincter is insufficient to maintain the pressure, then you can actually have the development of dyspepsia or gastroparesis because of the presence of reflux. And in publications, we see that whether it be an endoscopic correction of reflux or a surgical correction of reflux, we see resolution of the GERD and the dyspepsia in up to 85% of the cases with correction of the GERD. Those patients who do not have reflux dominant symptoms, this is typically going to be due to poor contractility. You'll usually see a lot of tachygastria in these patients, and these are the ones who we expect to respond to meds, sometimes to pyloric therapy, and sometimes to pacemakers such as Entera, in up to 72% of these cases. Now, a very special group are your hyponormals. In this case, we suspect that there must be less than 5 per high power field of ICCs, or there is dysfunction of the ICC motor unit. Now, this can be between 25 and 40% of patients. What we begin to do at this point then is to look into the patient's history and say, do we have a problem with ICC insufficiency, deficiency, or malfunction? Or do we have something that's myogenic in etiology or neurogenic in etiology? And when I talk about myogenic or neurogenic, so for instance, infections such as COVID or other viral infections will create a neurogenic defect. In other words, the vagus nerve or other myenteric neurons are affected by infections, and this can therefore lead to non-operability of the ICC motor unit. It can be metabolic. It can be due to endocrine conditions also. Now, with regard to the muscle, if we have collagen vascular disease such as scleroderma with fibrosis and thickening of the muscle, that would be affecting the muscle as part of the ICC motor unit, and that would be your underlying cause for poor motility. Other conditions such as connective tissue disorders like Ehlers-Danlos or loose joint syndrome can also do the same thing, as well as endocrine conditions like diabetes. Now, diabetes is very special because you can have one of two things happening with diabetics. In poorly controlled diabetes, there can be poor microcirculation, in which case these patients may respond to something like oral nitrous oxide to rebuild the circulation, and we may see then, therefore, improvement in the EGG and improvement in the contractility. In other cases, it's actually because of a disorder of an imbalance between the M1 and the M2 macrophages. And so with control, restoration of diabetic control, then what we end up seeing is a rebalancing of the M1, M2 macrophages, and therefore a decrease in the inflammation of the ICC motor unit and a restoration of function. Again, hyponormal is always a reason to look for the underlying disorder and try and fix it. If you cannot fix it, these are some of the most difficult cases because they will not respond to surgical therapy. They are typically not going to respond to gastric stimulators or vagal stimulation either. Oftentimes, if it's infection, this will improve on its own. Now, I'd like to talk a bit about using this information to see some of the expanded uses of EGG we're beginning to see. In particular, with regard into the field of obesity, with regard to bariatric surgery, we find that by applying these same principles, we can avoid complications and even prevent complications and assist in the procedural selection process. The same thing for implanting Intera pacemakers or other pacemakers. We know from the literature that if the EGG is hyponormal, these patients typically will not respond. We also know that if the patient is hypernormal, we would want to correct that pyloric malfunction first before placing the Intera, because that's the subset of patients who get worse. And of course, the patients who have normal EGGs are the ones who typically respond quite well. Same thing when we talk about reflux surgery. Reflux surgery is, like bariatric surgery, what we call a pressurization type of surgery. So by restoring the lower esophageal sphincter to often higher than normal pressures, what ends up happening is you pressurize the stomach. And if we are not careful, we do not do EGG as a preoperative evaluation in these cases, we could avoid the fact that there's functional pyloric outlet obstruction. And so by over-tightening the lower esophageal sphincter and not fixing the problem with exit out of the stomach via the pylorus due to dysfunction, then you end up with increased pressure. And then these are the patients who typically will have surgery. The reflux will get better for a month or two, and then they will begin to recur, again, because of this overpressurization. Another area are going to be for those surgeons or gastroenterologists who are treating gastroparesis, either surgically or via G-POEM. In order to have improved patient selection and avoid procedural failure, once again, EGG will help to identify proper functioning of the body of the stomach, as well as the antrum. And as long as there is no functional outlet obstruction or there is no hyponormal activity, the patient should respond to therapy. In particular, I want to focus for just a moment on the bariatric challenges that can be helped with EGG. This is because bariatric disease is a chronic complex disease. It's a difficult clinical problem, and patient selection for the proper procedure and prediction of results is often difficult. Another important thing is that if you do EGG in the obese patient, normally in the normal population, only 20% will have a gastric dysmotility, but the obese population, 80% have a gastric dysmotility, the majority of which is hyponormal function. So they are already starting at a disadvantage. If we want to avoid complications due to gastric pressurization, and again, a gastric sleeve is a gastric pressurization procedure because they take out the low compliance fundus as well as most of the body of the stomach, leaving a very high pressure tube. If we do not recognize in advance the fact that there's pyloric dysfunction, you end up with 40% post-sleeve refractory reflux, up to 7% staple line fistulization or leakage, which often can often lead to death, if not severe infirmity, and multiple additional days in the hospital. Another question comes up is, would it help in deciding who should have a sleeve versus a bypass? So your hyponormal patients, because they don't have the contractility, which is really required for a sleeve to function, may be better for bypass. We would look at these patients as typically those that have to be converted from sleeve to gastric bypass, which occurs quite frequently. About 50% of the reason is due to refractory reflux. So subtyping of the disease using EGG may hold the key to proper selection of successful therapy and avoidance by pre-surgical identification and treatment of pyloric dysfunction, avoidance of the 40% post-sleeve refractory reflux, as well as the staple line fistulization. Why is this important? Because the bariatric surgeons are now beginning to recognize that they want to use EGG for that pre-op evaluation to avoid the unintended pressurization. And again, this is what it would look like during an EGG. We would see these patients as either hypernormal or they would have an elevated GMAT calculation, in which case you would want to treat that in advance, either surgically or with balloon dilation. This is typically what the pylorus looks like in these patients. It looks normal. And following a 1 to 2 minute dilation, the pylorus doesn't look remarkably larger. It just is slightly larger. And what you see is that hypernormal condition here goes back into the normal range with that dilation. We know from published studies that when we look at the gastric myoelectrical activity compared to patients who are normal versus hypernormal, we see significant improvements in the gastric myoelectrical activity. We also see significant improvements in the dyspepsia symptoms and other symptoms of abdominal pain and bloating and early satiety, fullness, and nausea, again, only in those who are hypernormal. And then finally, when we look at the gastric emptying, and of course these days we're told not to look at gastric emptying any longer because it really isn't a reliable test, but we did note that the hypernormals only were the ones whose gastric emptying improved. What we did is we then created an artificial intelligence threshold value, so you no longer need to look to see if it's hypernormal only, you just really look at the calculated threshold value, and if it's greater than 0.59, then you know that this patient is suffering from functional outlet obstruction and would benefit from a pyloric therapy. How do we know this? Because when we did the study, we found that we were successful in permanently correcting this problem 93+% of the time. So finally, when we look at something like bariatric surgery and other diseases, other conditions will follow. Our primary objectives, of course, in bariatric surgery, define the efficacy and safety thresholds in which EGG will help. So by subtyping of the disease, we hold the key to successful therapy, and pre-surgical identification and treatment of pyloric dysfunction will avoid post-operative reflux in these cases. Not only in things like
Ready?
Vijim sir, your mic on, sir.
Yeah. Hi, friends. Now, in this room, we're going to have a challenging case. And to demonstrate this is Dr. Amal Bapai, and also along with him, my good old friend, but good and young, not truly old. Dr. Chenduran, who's a third space guy, he has decided to come out of his third space and spend time here. So, Chenduran, you'll hold the mic for me. I'm going to introduce. Can we have this case, the details of this case? Can you put up the PPT, please?
Yes, sir. Just a second.
We'll first need the needle. Huh? Yeah, 10 cc needle and then.
Dave, you can introduce this case, no problem. It's okay, go please.
Okay, sir. Thank you, sir. So this is a 28-year-old boy is having a diagnosed case of chronic GERD over the last 10 years and outside underwent laparoscopic fundoplication 3 years back. And the patient is having the postprandial dyspeptic symptoms like along with nausea, bloating, and patient came to us, we did endoscopy, and endoscopy we saw that post fundoplication status along with some antral gastritis. We took IUT to rule out H. pylori and it came out negative. Then we went for that functional test including electrogastrography, and electrogastrography GMAT score showed 5.48. Sir, over to you, sir.
Yeah. Okay, you hold the mic.
Sure.
See, basically, this patient had undergone, one second. Yeah, this patient had undergone fundoplication outside, and this is the endoscope finding. You can see here. Can you focus here? Okay, that is a wrap. Okay, the wrap is there, but not too very strong. However, he didn't have too much of reflux symptoms. So we went ahead and did a manometry, and this is a manometry where the LES pressures are 12 and 26, and there is no hiatus hernia. It's a type 1 morphology. Basal LOS pressure was normal. Okay, so peristalsis was also normal. In 85% were weak, about 15% were strong. And then we went ahead and looked for Helicobacter pylori by the breath test, which was negative. Then, like this patient had chronically was complaining of bloating and dyspepsia. So we were puzzled why, but still we thought we'll go through the, 24-hour impedance pHmetry, which shows that the D Meester score is only 4.5. The composite score of less than 4, has to be below 14.7. It's only 4.5, which means the plication, even though it appears a little weak, is still working. And there's not too much of reflux. And the LES pressures are reasonably normal. I wouldn't say very normal, but then there's not much of reflux. So with this background in mind, then we wanted to see why this patient all the time was complaining of bloating and dyspepsia. It gone around several hospitals and has been prescribed not only PPIs, and then we just tried some prokinetics, some improvement, but not a complete improvement. And so what we did, we went ahead and did an electrogastrogram. You're seeing here, and this is the normal curve. You see here the red lines, the upper and lower, or the upper normal and lower normal in the 3 CPM activity, this corner graph. And you'll see that initially the patient's graph, the blue line, was inside and then went out. So, and then we calculated the gastric myoelectric activity test index, the GMAT score, and it was found to be 5.487. Normally, it has to be below 0. So, it has to be in minus. And here, it was a plus 5 point something, which means the gastric myoelectric electrical activity score was very high. And then, however, the interstitial cells of Cahal, the 5 per HPF are preserved here. That means there is no peristalsis. And also fundic accommodation, you can guess from here, because the patient has ingested 800 ml of water in one go, which means there is no fundic accommodation defect. Obviously, this is a patient of gastroesophageal reflux disease along with functional dyspepsia. It's an overlap. And the type of functional dyspepsia was a postprandial distress syndrome. And here, it is again divided into 3 possible causes. The first possibility is a fundic accommodation defect, which is ruled out because a patient could consume 800 ml of water. and the gastric peristalsis is normal, which means there is no gastroparesis. And finally, it boils down to a functional outflow obstruction. So it is important. I'm sure surgeons like Amol. I mean, even though he's qualified surgeon, but he doesn't operate at the moment. Does all endoscopic surgeries. But many laparoscopic surgeons have a problem after doing a fundoplication. The patient comes back like an albatross syndrome with a postprandial bloat and fullness and dyspepsia. So in all these subset of patients, you need to rule out either a gastric peristalsis or a functional outflow obstruction. Here, I'm handing over this, patient. Already Amol is inside, the stomach. He is going to take over and describe more about this, and Dr. Chenduran will, be the commentator for this case. Thank you.
Amal sir, your mic on, sir.
Thank you, Dr. VGM, and it's really an interesting case. And we had a lot of discussion even before we came onto camera, because this patient also had a little bit of bile in the stomach. So there is also probably the gastroparesis may be a component, but there may also be some small bowel dysmotility as well. This is what I believe. Yeah. It may not be just limited to the stomach. That is one thing. The other thing is, what we have noticed is, we have found in some of these patients is that treating them for H. pylori, if they are positive, really improves their motility, because many of these patients have a lot of dysmotility when they are because of H. pylori infection, and they have to be screened and treated for H. pylori if possible before we embark on any invasive therapy, obviously. So
absolutely, and I agree with you totally.
Right.
And endoscopically, we did multiple biopsies. It was negative for H. pylori. Also, we reconfirmed using the breath test. H. pylori was negative.
Right.
So this, and there is no gastroparesis here, because the 3 CPM activity of the stomach is absolutely normal.
Right. So that's really, and the other important thing which Dr. VGM mentioned about patients of GERD or patients with symptoms of GERD who actually have gastroparesis or functional dyspepsia, but some overlap of GERD symptoms, and they're rushed into a fundoplication, and their symptoms only get aggravated post-procedure because of the gas bloat. And there is a significant overlap, and actually we were discussing this earlier as well, that just 3 days ago I gave we had a meeting in Pune in the Surgeons Society, and I was speaking about exactly the same thing when we were talking about endotherapy for GERD. And it's very important to differentiate and accordingly treat to these patients, otherwise it gets difficult. So you can see the pylorus over here, and I'm going to try going across that. I have the cap on the scope. It's not very tight, but still at the same time, it's not very supple what you would normally expect it to be. So there is probably some element of antral and pyloric dysmotility, spasm, something of that sort. Now Mohan has also shown you a G poem earlier today. So what we are going to do is, we are going to kind of repeat the same steps, maybe a few differences in technique, whatever. And those are idiosyncrasies rather than technical differences. Each person has their own, comfort levels. So diathermy, these are different, lengths are different. So usually I start my G poem about 4 to 5 centimeters proximally. I start the tunnel in the flattest part, and I'm starting the procedure with the patient in a supine position, because I'm getting the pylorus pretty much face on. If I was getting this too much to the right, then I would have turned the patient left lateral. But otherwise, I prefer to do it in supine, because sometimes, if they get distended, then you don't want a problem because of that. So give me the needle. I'm going to use the hybrid knife for the dissection, but I'm going to make the initial injection with the needle. Yeah, inject a little bit more. Yeah. Yeah, that should be enough. Thank you. Yeah, needle back. Now, some differences between the stomach and the esophagus when we are doing tunneling procedures, poem versus G poem. The gastric mucosa and submucosa are pretty much vascular. They are much more vascular than the esophageal mucosa and submucosa. The submucosa is also more fibrotic. And because we are targeting the pylorus from a very wide gastric lumen, you have to narrow down to the pylorus, and there is a very high chance that you can lose your way on the way. So you have to keep targeting the pylorus every time, because otherwise, if you lose the way, then you waste time and you unnecessarily dissect too much. That is what happens.
So just a minute.
Yeah.
They're just putting the
Okay.
pad, yeah.
Yeah.
So as sir is starting, I think sir you can enlighten us on your preference on the settings, because you use the precise. Usually people use sometimes spray and
Yeah.
swift. So
Right.
how do you prefer? And
So
what are the
if you've got the YO3, I think the precise sect is really the best mode to use in the YO3, and maybe you can focus on this.
show-
So the mucosal incision is using the endocut Q, and my preference when I'm using the hybrid knife is cutting interval of 3 and cutting duration of 3 on the effect of 2. And once I enter the submucosa, I am going to be making the deeper dissection and incision using the precise sect, which is a coagulation current, but it's an intelligent coagulation current which also takes care of hemostasis to a large extent. And obviously for the larger vessels, I would use soft coagulation 4.5 again. So that's how it is. So let's start with the procedure, mucosal incision. Can you give me the knife? So I'm using the T knife. I like the T knife because it hooks a little bit better. I think Mohan demonstrated the I knife earlier today.
Good. Yes.
So the gastric mucosa is much thicker. So you have to really penetrate and go in deep, because otherwise it's not going to go through and through. And now I injected further to elevate, and now I'm going to pull.
So while
Sometimes-
making this mucosal incision, you use only cut, or first you use a cut and then start using the coag
No,
cut?
for the mucosal incision I would prefer to use only cut.
Only cut.
Because otherwise the incision becomes too jagged. That is the problem.
If some vessel comes in between,
Then you can coagulate
just little bit, just a touch, or you don't mind, because once we go
I
in,
would
there is a
usually go on with a mucosal incision full in the full length, and then pause for the coagulation. That's unless there's a major bleed or something of that sort.
because anyhow there'll be a tamponade effect when we get inside with the
Yes.
scope. Yes, so
Knife. Still not the mucosa, probably.
the blood is gone.
Yeah. The bleb goes off much faster as compared to the esophagus. Basically because, again, it is a function of the vascularity. So there we are seeing the submucosa now.
Coag. submucous,
Yeah.
clearly.
Knife. Now, as in the poem,
We do the same.
we do the same
Wedging,
wedging
yes.
and undermining the edges.
Is there a maximum limit for the incision size, or is it just to our comfort, and or there'll be an increase in use of clips? It's like that? Or we
See,
should
the
mainly
gastric poem, G poem, you have to remember that the gastric mucosal incision has a tendency to splay open. So, if you make a too big of incision, later on bringing it together with the clips can become a difficult task, and then you might have to use endo loop and things like that.
Then I'll go show a pyloric balloon there. And
Okay, sure.
that take hardly 2 minutes.
Are we on incision, right? This size.
So it's always better to keep the incision minimal, mucosal incision.
Yeah,
the gastric,
meaning whatever is needed.
Unlike we use in the esophagus.
Yeah.
Little
Esophagus you can be more liberal.
Liberal, exactly. So.
The knife.
Amal sir, next that is ready. We will present the case history and come back to you, sir.
Sure.
Thank you, sir.
No problem.
No.
Sir, your mic on, sir.
It's another room. This is another room. So you guys intubate for all ERCPs? You don't.
Sir, your mic on, sir.
We are on? Okay.
Yeah, sir. On, sir.
Okay.
Slide running, sir.
Yeah. So as you see on the screen, there is a 30-year-old female. Oh, yeah, sorry. Yeah.
Hi guys, this is a 30-year-old female who has not come for follow-up following her ERCP CBD stenting for gallstone and pancreatitis. Later, when she came presented with cholangitis, we could not retrieve the broken CBD stent, which is still in situ. So now Rakesh sir is gonna try and remove the stent, which you can see on the fluoro. This will be coming up. So first step, we are trying to do the conventional procedure by using the balloon. Using the balloon, we are going to try to retrieve the broken stent. And if not, then we are going to next step using the cholangioscope.
Okay. Thank you. So thank you, Dr. VGM and his great team for having me here. And in fact, I am privileged to have the stalwarts behind me, Dr. Shivangi and Dr. Chris Kaur, who will be guiding and assisting me. So as you have seen the history, this is a young female with a retained biliary stent, and they did a second biliary stent to prevent cholangitis. So I have in fact, for saving time, took out the second biliary stent, but as on fluoroscopy you can see a migrated stent with a pigtail in the left hepatic duct deep inside. So now the main aim is to retrieve the internally migrated stent. So conventionally you have couple of methods which we opt for. One is you put in a guide wire and then try to trawl it with a simple balloon or using a basket, or number three is using a biopsy forceps or a biliary biopsy forceps. The fourth part, if at all nothing works out, is spy cholangioscopy with a spy forceps which you can take it out. So I just want to ask Dr. Shivangi about the opinion in this scenario. What is her preference in her unit when she has this kind of case? Shivangi?
Yeah, no, thank you. It's an honor sharing the same screen space as you. So, I think we will try with the balloon first, try the conventional methods, and as we discussed, if those fail, then we will plan to put the spy up. That's always the option.
Right. So I'm not doing a cholangiogram because I could see a very nice fluoro view of the stent being migrated. I'm taking out the cannulotome with the guide wire in situ. This is a VisiGlide guide wire. And now I'm going to take a balloon and then trying to trawl it. And if at all it comes out well and good, or let's see what happens. Can I have a balloon, please? So this is the same stone extraction balloon what we use regularly. And the methods in this is, as you see here, the stiff guide wire, which is a VisiGlide, which is being used now, is in situ. And I am going to railroad the balloon onto this and then go up above. There is no definite, the area specific, but obviously because it's a long stent which is migrated, I go probably up to the mid CBD or the hilar area and then inflate the balloon and try to trawl it down. And as you see here, the sphincterotomy is wide open, so it's easy to manipulate any of these accessories. Can I have the balloon, please?
And I think another thing in this is when we put in stents, we always ask patients to come back, and it's our prosthesis that is in this patient was again did not come through COVID, and now the stent was fractured and is now stuck in the intrahepatic.
Okay.
Just you brought up an interesting point about patients coming back, and I think it's a problem the world over. They getting lost to follow up. So in the U.S., is there a? Do individual institutions have a program to track these stents?
Yeah, that's a great point. We actually have a stent log. Every stent that goes in, we track that if it's planned to be removed in 3 months, that the patient is on the unit's radar, and we have a per nurse just dedicated to maintaining that log.
Well, that's fantastic, but it takes a lot of resource.
Screen. Okay. Inflate.
Yep, it does. But again, in long scheme of things, your plastic stent, you're responsible.
Screen.
So we try our best to keep our log. Again, there are patients that are lost to follow up, or patient just doesn't come. But that is one thing for the young ERCPs to be mindful of.
Screen. Deflate. No, it didn't come. So let me go about on to the, I think we are offline. We're offline? Okay. Screen one more. Oh, it's taken a complete pigtail. Okay. Yeah, okay. Now we inflate. Screen. Keep screening continuous. No. So it won't come. As you said, yeah, that's right.
Rakesh sir, we are watching you. We will move on the next set and come back to you.
Okay, right.
Mohan sir, your mic on, sir.
Okay.
So we have an elderly male patient who underwent a screening endoscopy recently for dyspepsia. There was a small nodule above the G junction, and it was a fleshy nodule, and
NB off.
biopsy, it turned out to be a case of suspicious adenocarcinoma. We'll be showing you the lesion, and we'll try to show a new technology. It's called RRR, Rapid Removal and Resection. And we have one more with us, that is Ram Chandani, Mohan Ram Chandani.
So Vamsi, so you are very nice. So let's see. We are at the G junction and we find a nodule just, and you can see a nice squamous area between the suspected Barrett's and a nodule there. So this is basically a gastric inlet patch or heterotopia, which has converted into some adenocarcinoma. So I have marked that area for you. We'll go to the NBI and show. And you can see here, though there is no zoom available, but anyway, we can see a demarcation line there, and since that lesion is a smaller one, we need to remove in toto to have a proper histopathology. So we'll go ahead and do the ESD for this. So I am using a new knife known as speedboat knife, which will use this to do the dissection. So can you inject a needle out, please? There's a needle which is very big here, and we'll inject please. Please inject, keep on injecting. Yes, inject. Yeah. Stop. So we'll go ahead and inject on this side, out. Out, needle out. Inject. Inject, please. Yeah, inject. Okay. So that is our lesion. So I'll make a first mucosal incision. Can you make it flat? Yeah, yeah. I'm making the mucosal incision like this, and then I will inject inside now. Inject, please. Needle out. Inject. Yes.
I have a doubt to ask Mohan.
Yes, sir.
Nowadays, he doesn't travel by ordinary boat, it seems. He travels by only speed boat.
I never traveled for normal boats, sir. Not even normal boats.
Not even. That's very interesting. So, how do you find it in terms of speed and use of ease?
So, yeah, it's a new technology, so which we are not well taught with, but it's a bipolar device. So since it's a bipolar device, it does not require any grounding pad, and moreover, we will have an integration of a knife which can do everything for us, including the coagulation, including the the cutting. Can you make it supine? So it's a very important role of like this. See that's a, so we'll make it rotate. Yes. Rotate. Okay. So rotate, please. So that's the important role of the my technician also. So I will just engage this here and do the cutting. You can see now we are onto the muscle layer.
How do you assess the depth of cutting here?
So the first of all you have to do first mucosal incision should be such that very shallow, and that will expose the submucosal fibers. Inject please. You can see the submucosal fibers there. Needle out from a distance, yes. Yeah, and then we'll inject underneath this. Inject please, yes. So that's how we elevate this, and then we get into the planes.
So you just do an incision in order to create a submucosal saline cushion,
Yeah.
and then you go to tunnel your way.
Tunneling, yes. Since this lesion, I will just ask him to do yes, yes. Now it's enough. So we'll now cut. See that? Up till to the mark which we have achieved, and then I go into that flap and expose this submucosa, and then I cut here. So that's a very small lesion.
Yeah, we can see the. Is that muscularis propria or just the muscularis mucosae that you
Yeah,
have
that's a
dissected?
very good question actually. So
Looks quite superficial.
Yeah, but
But
whole
anyway,
of the
it could-
mucosa is
yeah,
above.
yeah,
so
yeah. Could be the propria
yeah,
layer
not propria. Still not propria.
Not propria as yet. So the submucosa is still below.
Yeah. So now whole aim is to get this in toto. So we'll keep on injecting again. Please inject. As Dr. Mohan Prasad has rightly pointed out, we have to see whether it's a, still we have to go more deep. Needle out, yes. Inject. Yeah, inject please. Yeah, okay, stop.
So
now-
the boat is being operated by Mr. Venkatesh, who's
Yeah.
been my
Yeah.
good friend for years now.
Yeah.
A lot of expertise in the field of assisting all complex procedures.
So you can see now we are going into that proper depth. Can you move right up? Right up, please. Yes.
So it is the edge that cuts, right?
Yeah, it's that cuts. Yes.
The flat portions are insulated,
Flat portions are insulated. Yes.
so that makes it safe.
Very safe.
So that you don't transmit to the underlying tissues.
Yeah. So we'll keep on washing again.
This you can still use the RDI mode even though the scope is a therapeutic scope. Can you switch to RDA and check what happens? Yeah. Just
Yeah,
see.
so see
yeah,
that RDI?
That's good. This way, I think all these scopes which get connected to the RDI processor still can avail this function of RDI. So it can any bleeding vessel can be easily
So I
picked up.
can see the bleeding vessel here. So I'll apply the microwave coagulation there.
Wow. You can do the microwave cooking here, so which is very gentle and it doesn't affect the depth.
Yeah.
So
Flush water, please.
some more ooze of blood is there. I think it will stop.
No, not yet. I think
Almost stop because
Ah,
of the
almost,
microwave cooking.
Yeah.
So it's a slow thing to coagulate. So compared to the regular
So
coagulation,
it
current.
requires at least 10 seconds.
Yes. See how Mohanji is applying steadily for at least 10 seconds. So it cannot be just a pulse application and the depth of penetration is low. So that makes it safe.
Yeah. Flush, please.
Probably a little bigger vessel there. underneath.
Yeah, and there is some mucosal fibrosis also. See that?
Yes,
It's
yes.
very.
You can see that. That should be secondary to the biopsy that we did.
Yeah.
Of this lesion. It's a small lesion which we have done biopsies. When you do biopsies, it always produces fibrosis.
There's severe
So,
submucosal fibrosis
yeah.
there.
That makes dissection little more difficult because it can be little bloody.
Yeah. Injection, please. Injection. No. The vessel is slightly bigger, so I'll use more coagulation. Flush, please.
You can see very well once the mode is changed from the white light to RDI, the red dichromatic imaging. Immediately, like you get better visibility of vessels and the pool of blood looks yellow and still allows the vessel below to be seen.
Yeah.
That's a great help with the RDI and
And
again
also
it's
the
bleeding.
mental anxiety is less.
I know, because we're not sure where the bleeding point is under the pool of blood. So here the visibility is much better.
Yeah. The problem is as soon as I am removing the cap, the bleeding is happening. Otherwise, it's not happening. So somewhere.
Yeah, the cap probably
And-
is giving
yeah.
some tamponade, preventing the feeders.
And the submucosal fibrosis is so severe that there is almost no submucosa there. Yeah, you can go ahead.
Now we are quickly switching to Dr. Rakesh Kalpala's demonstration of ERCP as we are trying to control this bleed. But nevertheless, the microwave ablation is very slow but definitely is safe.
Yes, sir. Thank you, sir. Rakesh, sir, your mic on, sir.
So we tried the conventional way of retrieving it with a balloon retrieval extraction catheter, but it couldn't. So finally, we now have switched on ourselves to the SPY scopy. So for people who haven't, who have seen in the morning Chris performing the SPY, so the SPY scope, this is second generation spyglass cholangioscope, and the reason why this is being used in this particular case is under vision you can see the stent, and then it has got couple of accessories, the SPY bite which you have seen in the morning for taking the biopsy. Then you also have a SPY laser which you have seen in the morning to kind of pulverize the stones, and you also have a SPY forceps which is especially used to retrieve the migrated stents like this in this particular scenario what you see. So can you just manipulate the SPY and show me the stent? Okay, as you see on the screen, the PIP is the endoscopic picture, and on the mains, yeah, Chris or Shivang, if you can just operate. So as you see on the endoscopic screen, can you flush and then show them? I need somebody to manipulate the wheels and show them the stent. 1 second.
Chris is gloving up. Actually, in my talk that I gave this afternoon in lunch,
Yeah.
I showed a migrated, fully covered metal stent that had migrated into the proximal CBD that with the help of the SPY bite, I was able to retrieve it out.
Yeah.
Same thing, the ballooner, nothing works. It makes it harder for these migrated stents.
Okay. So now as you see here, there is a stent on the 11 o'clock, 12 o'clock position, and that's the hilum with two right and left hepatoduct seen. So what I'm going to do is I'm gently pulling the SPY out, and you can see the stent there. Yeah, okay. So Chris has come to rescue me with guiding me with the SPY. As you see, there's a nicely seen migrated stent inside, and I'll pull back the SPY scope. Can you appreciate there? So now you have seen the stent in position. as I told you, now the next part is important thing is you need to have the spy accessory, that is the spy forceps, which is a very thin forceps. And to catch the stent, because this is a wide diameter, I need to go to the distal end of the stent and then try to see the distal end and then use the spy bite. So you see here, yeah, that's the distal part, right? Is it right, Chris?
Yep, that's right.
Okay. So now with this in position, I am going to take the spy forceps, which Chris is already loading in, and let's see if it can easily come out of the spy scope. Is it moving freely or you have any resistance? Okay, perfect. So in this case, you need two operators probably, because there are multiple accessories which have to be. For a diagnostic spy cholangioscopy, definitely yes, you can mount the spy scope on the duodenoscope and do. But some things like this where you need to do a spy bite or do a retrieval of a stent using a spy forceps, you obviously need a second operator who is also well versed with the system. Okay, can you? Okay, so what I'll do is I'll leave my elevator so that the resistance will come down. Okay, let me, yeah, now you see. Okay, 1 second. Yeah, now you're not comfortable to push. I'm in a straight position. Or what we need is we can take out the spy, load the biopsy forceps and then get in. Well, anyway, it's no. Okay, now you see now. Okay, okay. Oh, it's moving, but okay, it's okay. So what you do is you just get the spy forceps out, and then I'll go in. Can you go in now freely? Yeah. Okay. 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 Take it inside. Okay, so now I'll go into the papilla and then let's see whether we can. Okay, yeah. Yeah, so the wider the papilla, the sphincterotome, the is it to manipulate. Okay, so I've gone in now. I'll switch on to the bigger screen. Can somebody flush so that we'll have a better view? And Chris, can you manipulate, adjust the wheels? Okay. 1 second.
Yeah, the forceps is crusted with this.
The forceps is out of the scope?
This mark on top of the forceps.
Okay. No, there's some mucus plug which is obstructing our way.
Yeah, try and flush some more, please.
Try to flush it. No?
Otherwise, I may have to pull it. Yeah, I may have to pull it in.
Yeah, the forceps is this, right? Okay. So now let me pull the spy and see the lower end. Okay. Yeah, 1 second. Let's not rush. Yeah, okay. So that's perfect. So now if you can take the biopsy forceps out. Yeah. Push the forceps out. There's some mucus plug which is obstructing the way.
Try opening now. Is it open?
Yeah, just push the forceps or take the forceps inside so that the plug will be dislodged.
Okay, then we'll need to close it first and try again.
Close. No, you should see the distal end of the. Yeah, now you go. Push the forceps down. Push the forceps inside. Yeah. That again the mucus plug is playing a foul play. Okay, should we flush it again? I mean.
Flush hard and suck at the same time.
Yeah. Now it's. So that plug is one which is on the forceps, I think.
So it's really annoying. Yeah. Okay, let's do it one thing, no problem. So now you pull the, get the forceps out and see so that we can dislodge the mucous plug. Okay, okay. So this is a little teething, but once as soon as you get the lower end of the stent caught with the forceps, then it will be easy to do. Yeah. Okay, now hope we can go. So let me position myself and then get in the spy inside. Okay. Oh, sorry. Yeah. One second. Yeah, 1 second. Just let me suck. Okay. So one important thing here is again, you have to also manipulate your wheels to kind of get in. That's another trick. Oh, sorry. Let me do it again. I'm in. Okay. No, no. 1 second. No, it will go. It's just. Yeah. Let me just suck. Okay. Ay. Yeah, okay. So we'll come back. We'll just go to other theater and then we'll come back in 2-3 minutes.
Thank you, sir. Thank you, sir. Mohan sir, audio back with you, sir.
So I am at the last part of my ESD. Unfortunately, this is a very small lesion, so could not continue for long. You can see now, we'll push water some. So there is a bleeder there. Again, you can see the bleeder. So what we can add this and do microwave coagulation. So you have to wait for 10 seconds. The good thing is that once you identify the vessel, you can coagulate it very nicely. So can you make it now? Yeah, so that's very important role of the assistant here. So he can, so if he has to do what the orientation is demanding, that means if I want him to do, so what I call is left up, right up, and then you can see now we are almost done. There are some tissue left here. Can you do the, so now we have to do a dissection from here. So it's very easy because I am not bothered about the muscle layer, because I can rest my knife onto the muscle and cut it. There is some bleeder, so we have to tackle it first. Where is that? Yes. Can I see the? Yeah. Flush. Yeah. Yeah, that can be done, but ultimately the goal is not to waste too much of accessories, and also to do end block resection. So once you are using a snare, you may lose that advantage sometimes. Though I know you are saying that the lesion is small and can be tackled by snares, that can be done, no doubt about that. Yeah, that's what. But okay. So I'm just trying to achieve the hemostasis by microwave coagulation. This is totally different from other coagulating devices where we have a monopolar coagulation. This is bipolar coagulation. So it won't go deep. So now we know that there's this hole completely removed from here to here, but still there is some bleeding point. Oh yes, we saw that. So whenever we see the bleeding point, we just go push the tip and do the microwave. And push, because it won't go deep. So you are not bothered about muscle injury here. You can see now it is completely achieved the hemostasis. And now we are left with the left quadrant. So I will ask him to inject, please. So this needle is quite long. So we'll inject here. Inject. Please inject. Yes, see that it's getting elevated. Yeah, more inject, please. Yeah. So now, so sometimes even the smaller lesion we may require some sort of traction device to make it. Yeah. So he now again we will do yes. So now I'll rest my knife onto the muscle layer and cut onto this side. You see that?
Mohan sir, we are moving next step and come back to you, sir. Venkata sir, audio back with you, sir.
Yeah. Okay, we are on.
Yes, sir.
Okay, I can. Okay, so welcome back. Now we see on the screen, I have put the spy cholangioscope, and the spy forceps is come out of the spy cholangioscope. As you see, Chris is manipulating, and you see the on the screen the open biopsy forceps. So now, Chris, can you push the biopsy forceps so that it will catch hold of the stent? Okay, push, push. Okay, yeah. So now you close the biopsy forceps. My tech is doing it. Yes, close. Close. Okay. Okay. Now, can I have the fluoro to show them whether continuous fluoro? Okay. Can I come? Shall I come out? Yeah. Yeah. So now you see it's firmly caught. Now I am going to remove the, unlock my wheels. And can you show the fluoro, please? I think they also should. Okay, I'll pull the spy. Okay, Chris. Yeah. Okay. Where are we? I want the fluoro, please. Fluoro, please. Okay. So shall I pull the scope? Yeah. It slipped? Okay. Okay. No problem. We'll do it again. Close the forceps. Okay. Yeah. Please adjust the wheels. Adjust. Flush, please. I want the flush. No, it's okay. Yeah. Yeah. Flush. You have to adjust the wheels. Adjust the wheels and then let's see. No? Yeah. Okay.
So you can't get spy and fluoro?
No, okay. You switch off the fluoro and we want the spy here. Yeah. Adjust the wheels. Okay. Yeah, where is the stand? Okay. Let's here. Yeah. Let's see the lower end. Okay. Okay. Yeah. Okay. Can you push the? Can you push the forceps? Is it coming? Okay. Perfect. Yeah. 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 Forceps up. Out. Coming. Okay. Okay. So let me push the spy a little more deep. Okay. Yeah. This is push the forceps out. Forceps a little bit out. Okay. Yeah. Open. Close. Is it caught? Can you feel it? It's not holding? Okay. Yeah. 1 second. Push it, push it. Yeah, yeah. Okay, okay. Hold. Close, close. Yes. Okay. Yeah. Okay. Okay. So let me. Yeah, it's coming. It's coming. Hold tight. Hold tight. Yeah, we are on the screen. Hold tight. Yeah. See, it's coming out. I'm slowly pulling it. Okay, okay, okay. There you go. Okay, no problem. So now what we can do is, if I have a snare, then I can pull it out. So the main purpose of doing this is to get the stent out. You don't have to get the stent out completely with the spy forceps itself, because spy forceps is a very small one. So now what I'm going to do is, there are two options in this. One is taking a biopsy force or the rat tooth and then catching it, or taking a snare and catching it. So it's always wise to use a snare if you have, because rat tooth sometimes, because it's an old stent, the stent might break. So that's that disadvantage, but let me try. Okay, gently, don't push. Okay, close, 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 close. Yes, okay. Yeah. So now I caught hold of it, and now it's pretty much inside, outside the scope. So I'll pull it out. Can I have a fluoro, please, for them? Fluoro, fluoro. Fluoro picture, please. No need of spy. Change to fluoro. And what about the endo view? Okay. Okay. Got it.
So it's an excellent demonstration, sir. Friends, yeah.
Yeah,
Yes, sir.
we'll just do a balloon sweep and then close it. So now what we're going to do is go back and then clear the residual sludge and stones, if any, so that she'll be free of the stent. That's very important.
So we have seen how challenging retained biliary stents can be even for the experts here. So thank you for the demonstration.
Right. So the main take-home message is the spy, how to use, and then what is the essentiality of the biopsy or the spy forceps, how to make use of it to retrieve the stent out. Thank you.
Thank you, sir.
Thank you, sir. Mohan sir, audio back with you, sir.
balloon.
Open. Close. Oh, yeah.
Mohan sir, your mic on, sir.
Okay. So I'm on the last stage, so I'm using a traction device because I'm not able to delineate the lower anatomy. You have the clip? Dental floss? Yeah, clip. Oh, any microtech clip or reopenable clip? No. Yeah. No, that he'll cut with this needle, scissor, a blade.
Mohan sir, we can come watching you. Amal sir, your mic on, sir. Amal sir, your mic on, sir.
Hello.
Yes, sir.
Okay. So am I audible there?
Yes, sir. Go ahead, sir.
Okay. So we are continuing in the tunnel. What I will do is I will just pull out and show you what we have done so far. So we started about what we thought was about 5 centimeters proximal, but then as we dissected, the stomach has a tendency to distend, and because of that your actual tunnel becomes much longer. So that is the reason one has to be very conservative with your first incision, otherwise you will tunnel through the entire stomach and you will waste a lot of time. So the gastric submucosa is always much more vascular and also fibrotic, so it takes a little bit longer, and also you have to keep watching your path. Anything? So we are almost at the pylorus now. Give me the knife. And that mucosa, can you see, Kirti?
Yes, yes.
These vessels, now that is indicating of the duodenum.
Yeah.
That is the duodenal mucosa which is coming up on the other side. So now we have to be very careful. We have to inject at every step before we this thing, and probably another 3 to 5 millimeter of dissection, and probably we are done. That is how it
We
is.
are entering into the more sensitive
Yes.
thinner part actually.
Yeah. Are we done? No?
Still not done. We'll change the knife for this.
Maybe we'll change the knife, whatever.
We'll change the knife. You can get the TT knife.
Because this is a place where actually the hybrid knife would be more useful, because you have to inject in this thing, because again all the settings will have to be changed.
That's a dual knife, huh? TT knife, huh? So TT knife, okay.
TT knife, and later on I'll need the IT knife
IT knife,
for the myotomy. TT knife and TTJ, na?
TTJ. Connector. inject. Yeah, either syringe. Loaded with the indigo gamma.
Syringe, inject, I need to inject. Okay, inject. Okay, enough. Give me the knife. Yeah, full out. No, the settings they have not changed yet. Change the settings. Change the settings from hybrid knife to TT knife.
இருக்குது எப்படி நினைக்கிறேன் அதிலே தானே incision tunneling in my atomic. Okay, va? Precise site 4.5, no, sir?
Yeah.
Okay.
Give me the knife. Yeah.
Okay.
No, nothing happening.
Sorry, matra.
What is happening?
Connect.
Just get another machine. Get another machine.
No. Okay.
Diathermy seems to be giving us trouble.
Now it will be okay. So just see.
Amal sir, we will move on the next set and come back to you, sir. Mohan sir, audio back with you, sir.
Okay. So now you can see I have applied a traction device to delineate the anatomy, and I am cutting beneath this. Very simple. You there? Can you see? So that's our dissection plane, and very simple. So you can see now the tumor has gone up. Bleeder will tackle. Can you flush? We'll see the bleeding side. Stop. Okay, so we got that slightly above. Okay. So again we'll push the tissue there, and that's our tissue. I'll make a stretch. Can you make it? Yeah. More on that side, please. Yes. This is now gone. So it's like somebody holding for us. So that's why the last part of even a smaller ESD is slightly difficult. So that's why traction device. That's the last part of the mucosa. I think that's so that finishes our ESD. So I'll close this dissection. Can we have this one? A loop closure. I want to close with the loop. We don't have the loop. We have? Why it is not coming? you can keep. Do you have the quack grasper, please? I'll use quack grasper to. Water, please. Water. Yeah, open. No. Close. Open. Flush. Open. Close. Open. Flush water. Open. Close. Open. Flush. 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 Open. Close. Open. I think that must stop. Do you have loop? Know how big it is? Hmm. That's enough. I want to close this, but I have to close. But you don't have the clips also, no? Olympus clips are you having? नहीं यार इमेज में मज़ा नहीं आया पता नहीं कैसा लग रहा है वैसा वेरी हेजी आई एम वेरी स्ट्रगल रियली स्ट्रगल टू डू ये So I'll close this incision because I fear there can be more bleeding and I can't see anything. Waste time. You have the clip please? Which clip? Olympus? No. Boston, one first Boston clip, then Olympus. This one. This one is there? Open, open, open. bed division. ओपन ओपन अरे अभी इतना टाइम नहीं है ओपन ज़्यादा नहीं क्लोज what happened huh what? It's okay no no but
Okay. Mohan sir, we will move on the next step and come back to you, sir.
Okay.
Yeah, thank you, sir. OT1.
Yeah. Hello.
Live, sir.
Yeah. Am I audible now?
Yes, sir.
Yeah. Okay. So this is a 48-year-old male, sir. It's a diagnosed case of diabetes and hypertension as well, and was on regular medication. It's not uncontrolled diabetes though. Presented with a GERD and a long-standing postprandial dyspepsia over the last 7 years. And we did endoscopy here, and when the patient came to us, endoscopy showed there's a lax alias. Along with that, there is a corporal gastritis. So after that, patient was on conservative medications, but still the patient symptom was not relieving, and the patient was not satisfied with that medications and other management. So we did all the functional tests, like as our previous test, like electrogastrography and EGG test. Here showed that patient had GMAT score 1.44, means in positive.
Where is the NBI mode? Narrowband imaging. Yeah, that. Okay. Hi friends. Very
Yes, sir.
quick case that we're going to do. So this is slightly lax alias. Can we increase the brightness, please? Increase the brightness. More. Okay. Fine. So you can see some mucosal breaks here at the distal end of the esophagus. So probably grade A reflux esophagitis. So the OG junction, what is the level? It is at 38 centimeters. And yeah, there's a mucosal break here which is very evident, indicative of GERD. Okay. So now remove that NBI. Please go to white light mode, please. Okay. So there we are in the greater curvature of the stomach, and there I'm going in. Just always, whenever sedated patient, please turn around to the fundic side and suck out all the fluid, because otherwise these people can aspirate. This is very important in all therapeutic procedures we have to follow. Now, again, going to the pylorus is like you fly like a plane and do not swim like a ship. So you just keep rotating the big wheel towards you, and then there you go towards the antrum. And this patient, they didn't show you that EGG. Probably they can show the EGG at the end of this also, the PowerPoint presentation. This patient had electrogastrography where the fundic accommodation was normal and the peristalsis was normal, but the problem was the GMAT score, the gastric myoelectric activity test. The GMAT score was high at 1.444, indicating there is a pylorus spasm. See, this is not as tight as the previous case, but however, there is spasm which has been shown by electrogastrography. See, I'm unable to just straight introduce like this. I need to use a little bit of force to enter here. So it just enters with a snap. Okay, that is a sort of pylorus that we have, which means there is a functional outflow obstruction. So this is the second part of duodenum, which is absolutely normal. And we have already done endoscopy on this patient, so I'm not going deep into the D3, D4. I'm just pulling back until I get the incisor angularis, and then I rotate the big wheel all the way towards me and hold just to check for any laxity that I could see here. It seems to be a slightly lax LES, maybe Hill's type 1. That's how it is. So there is history of reflux and an overlap of functional dyspepsia, postprandial distress syndrome, as we were seeing in the case in the other room. So what I'm going to do is another quick technique, of very simple technique. Even people who are not oriented to doing G poems, not having enough adequate accessories, you can go ahead and do either one of these two things. either you can inject Botox, so which you can inject on the usually we inject at 12 o'clock position and 3 o'clock and 9 o'clock. We leave the 6 o'clock position uninjected, so that later on, if there is a response to Botox, that means this patient will respond to a G-poem. That's what it shows. So now what I'm going to demonstrate is a pyloric balloon dilatation. Simple, quick technique. It hardly takes 2 minutes. So if there is any resistance for the accessory to come out, what you need to do is just keep your scope straight and try to push through. And now the balloon is out. So what we are using is a Shiley balloon, 20 millimeters from Shiley endoscopy. That's what we are showing here. There's a long sort of balloon. So we're going to introduce it into the pylorus a little bit so that we enter into the duodenum a little bit, but not too much. Yeah, I will get first the balloon out of the endoscope channel, so which means I'll have to move back. So yeah, there we go. So that is a blue indicator indicating that is the end of the balloon. I don't want to go too much inside, but I'll keep it here. Ideally, half the balloon should be inside and half the balloon should be outside. And but this is a long balloon, so we can go ahead and dilate using what machine you using?
Can you focus that?
Yeah, can you focus here? How this is being rotated. The screw is rotated, so the you show here the dial. Show the dial. Yeah. See, the balloon is now getting inflated. We just need to maintain the position so that it doesn't pop in or pop out. So once it has assumed a reasonable size, then you just keep inflating and just supporting. Like with my finger, I'm supporting the balloon catheter just at the level of the biopsy valve. So now, what is the pressure you reached? 4. So what is the pressure that is recommended for a 20 millimeter size? There's only one size balloon, right? Yeah. What is the maximum pressure allowed? Usually it's here. Can you read this? The flag?
Can you focus that little bit?
Yeah, the flag is here. So what is the balloon size with what pressure? 8. For 20 millimeters, what is the 18. Okay, so it's an 18 millimeter balloon. So we just 19 is what? 19 is how much? Can you read it for me? 4.5 and 20 is how much? 6. So 6 atmospheric pressures is what we have to reach in order to get a 20 millimeter balloon. So patient is getting some pain. What is the ATM that you reached? 3. Because a long balloon, I'm just keeping a little bit away so that we don't produce a perforation in the duodenal bulb. The control radial expansion balloons from Boston can also be used. So we just inflate for 2 minutes, deflate, again reinflate. Now deflate.
So during this inflation, sir, may I ask you one question, sir?
Yeah.
So before that, you told us that we can use Botox also instead of that pyloric balloon dilatation, sir.
Yes.
But somehow
now you can you re-insufflate?
And sir, somehow if the patient is supposed to be posted for G-poem in later date, so preceding giving Botox, will it be helpful for G-poem, or could it be it may cause some submucosal fibrosis which can hinder the G-poem procedure later on, sir? Like, what is your intake, sir?
Exactly. So that is why the question. I don't know whether you heard the question. The question is, will Botox injection prevent the G-poem from being done in future? That is why we don't inject Botox all around. We inject only at 3 quadrants. We inject at 9 o'clock, 12 o'clock and 3 o'clock.
Yes.
And then we just stop. We don't inject at 6 o'clock because we usually go along the greater curvature of the antrum in order to do the G-poem. Whereas here we're going to break all the fibers. We're going to produce fibrosis at the pylorus. So this one may produce some fibrosis. So at a later date, if you want to do a G-poem, might be a little hard, but you still can do. There'll be more submucosal fibrosis here. You can. You can. Already inflated or no? So I'm just pulling back because of the long size of the length of the Shiley balloon. So I don't want to go very deep and create trouble. So, but ideally, any balloon with which you are dilating a stricture, the center portion of the balloon should exactly coincide with the stricture. That is the ideal way to do. But this is a pretty long balloon, so I'm worried about going deeper. Yeah, you can deflate. Now we'll start deflating the balloon. So we have inflated up to 20 for 2 minutes. Just relax. Again re-inflate for 20 millimeters of balloon. Here it is 8 atmospheric pressures. Then after that you just deflate and pull it out. So you use the machine, the gun to deflate, and then what you should do, you should also probably use a syringe to completely pull out all the air and water in the balloon, because these balloons, if you are reusing, they develop winging, and when they go through the biopsy channel of the scope, they can crack and break. So whereas abroad, all these balloons are single use, so they just can dispose of straight. So now a negative suction is given and held by my assistant. Still there is a resistance, so I will wait. There's still some more winging. Yeah, as much as possible you should aspirate all the water, all the air, and then we get out.
Sir, they want to shift to Mohan Ranchal.
Yeah. Yeah, you can shift.
Thank you, sir. Aman sir, audio back with you, sir. We are on live.
Okay. Can you give the video as well?
Yes, sir. Running, sir.
Yeah. Okay. Give the endoscopy video. People are anyway fed up of seeing me on screen. So are you getting the endoscopy video over here?
Yes,
Keep the
sir.
knife back. Keep the knife back only. Back only. Yeah. So this is the pyloric ring, and this is the duodenal mucosa. I am probing with the knife. This is the duodenal mucosa, which is falling vertically down beyond the pyloric ring, and this is the ring. Now what I am going to do is, over here I am going to inject a little bit of fluid, inject here, and then we will switch over to a insulated tip knife, because otherwise the duodenal mucosa is too close and sometimes you might injure that. You don't want that to happen, so inject a little bit more. Yeah, inject off all that. Okay, enough. Right. And now give me the IT knife, and then we'll perform a short, maybe 1 to 1.5 centimeters myotomy, full thickness. It is necessarily has to be full thickness, because otherwise you're not going to get any relief. Okay, give me the knife. Go there. Hook your knife beyond, but make sure that the mucosa is not folding over, because otherwise you might nick the mucosa. And then gentle traction and pull back. Now you have to use a.
Precise quack.
I use a little bit of quack, a little bit of cut, basically because I want a swift movement downwards, but sometimes there can be vessels down here and they can bleed torrentially, because they are all branches of the right gastric and the right gastrohepalvic. So I start with coag and then finish the cut with a cut. That's how I do it. Knife, yeah.
So it's basically from down up. You pull it. So you
Yeah.
just use only the scope, or you use even the knife's sheath to pull it back.
No, basically hook it
Yeah.
and pull with your
the scope.
with the scope and the down wheel of your scope. That is basically the idea. So that is nicely opened
Nice.
up.
The ring is opened up nicely. Yeah, the ring is opened up nicely.
Maybe one small. Give the full knife.
Open it, open it.
I think that
Yes,
should be
it's
enough.
just opening up, it's just giving away. Nice.
Yeah, that is nice
That's
and
nice,
open.
yes.
I think that should be adequate. I don't think we need to do anything more than that.
So you stop there, you don't
You just stop
extend.
there. You don't
No,
extend.
you don't extend.
Because
Just
if
only
you
that part.
extend too much onto the antrum, the patient may actually develop further gastroparesis because the gastric pacemaker is in the antrum. You don't want to damage the gastric pacemaker. So it's very crucial to perform a very short myotomy. Under
No,
2.
no, just
Under 2, I would say. Even under 2.
less than.
And look at this, Chris. Look at this. Look at this.
Yeah. Just
Wide open. Wide open.
Beautifully.
Wide open.
That was a wonderful demonstration. Initial, we had some hiccups because
The suction
with
is
the
not
equipments and things. So
Is it full?
entering took time, and then once we were inside, more carefully
Very
with the
weak,
vessels.
suddenly.
And then identifying the ring is the challenging part. Once you identify the ring, and then very short myotomy, what we have learned.
So just a quick recap as to what we did. That was a mucosal incision, and then we wet in. Gastric muscle is more resilient, so you can nick it a little bit more than the esophageal sometimes. At the same time, the submucosa is quite fibrotic, so you have to be careful. It's vascular also, so that is how it is. And then this was the yeah.
After this, since your clip closure,
Yeah.
can they do the Apollo overstitch? You may have
Yeah,
to
of
run
course,
with
I know.
Yeah, we have decided already about that.
Yeah. So Ravi is standing here. We already called him over here because I have to leave because I have a webinar to log into and then my flight.
So we have
Ravi
created a
has kindly-
bigger space for the suturing. Because no clips, there's only suturing.
So I will take your leave and once more I would like to thank Dr. VGM and the entire team over here for the fantastic arrangements and the fantastic cases, and thanks Kirti
Yes, sir.
for standing so patiently behind me while I was struggling to find the ring.
No, we admire your work. I keep following you. So he's my
thank
third
you so much.
spaceman. So yeah.
Thank you so much.
It was wonderful, actually.
Thank you so much.
Morning we started off with the poem F. That took a long. I mean, it was difficult. Well demonstrated, and again here another challenging G poem. Just an extraordinary person. It's really an honor to be here. I think with the other professors here. Wonderful,
so
sir.
much.
Thank you once again. Thank you so much.
Thank you. Thanks. Thank you. Okay. We can move to another room. That's okay. Until they set up the
But
scope.
Dr. Ravi will come for
Yeah.
the ESG. I mean, you
The
have
scope,
to set
you'll
up
need
now.
to set up the scope,
You have to
no?
set up, right? Yeah. Okay. Scope
Okay.
change.
Yeah, they'll need a scope change. Yes, 2D scope. They'll need to set it up. Okay. Thank you. Are we on camera or? You can switch to another room. Then I can deglove and all that
Deglove,
because
yeah.
otherwise
Before that we
it
don't
it
get-
doesn't look good on camera.
Yeah. Wonderful, sir. Actually.
Thank you.
Now identifying the ring is the challenging part. It's
Because you go the 5 millimeter this.
Sweet memories keep haunting me, and deep in my soul I know you meant, and my heart belongs to you.
Dr. V.G. Mohan Prasad, Chairman of VGM Foundation, for this initiative.
Sweet memories keep haunting me, and deep in my soul I know you meant, and my heart belongs to you. sweet memories keep haunting me, and this
do we have? We don't have the 15? Huh? 20?
Yes, ma'am. Your mic on, ma'am. You're on live.
Okay, this is a 33-year-old male patient who presented with abdominal pain and mainly vomiting for 2 days duration. This was he had an outside ultrasound scan suggestive of chronic pancreatitis. Stomach is full of. So, you want to do it later? Yeah. Yeah, this is too much. Yeah. Okay. So this is a patient with a large pseudocyst, as you can see in the CT. Yeah, but just while as we did the endoscopy, we saw a lot of patient also has GO, gastric outlet obstruction. So you can see as ma'am is demonstrating here, there's a lot of food residue still within the stomach. So I think what we're going to do is now is we're going to abandon the procedure for now. Maybe give a thorough NG wash and maybe take him up after 1 or 2 days for a cystogastrostomy.
Ma'am, your mic on, ma'am.
Yeah, I agree. We didn't anticipate this, but I think he needs a good NG decompression, and we do this. He's got a very mature large wall. We can show the pseudocyst, but again, the main thing is you're always prepared for a complication should there be a perforation. Now all the food is leaking out. You always want to do it in a safe, controlled manner. He's not septic, and he's the pseudocyst is not infected, so you have some time to do this in the right way. Oh, the ultrasound is on. Yeah.
As you can see, ma'am is just going to just show us the pseudocyst using the EUS linear scope.
Right, so we look for the aorta, and then as we spoke about, we come down. You want to look at your celiac takeoff, and here in the region of the pancreas, you're seeing this large fluid collection. It's got a thick wall. Again, EUS is two-dimensional, so you're not seeing the whole contour of the fluid collection, but it is definitely drainable. I would say do it in a good controlled fashion. there's the liver fluid collection. And again, there are various pockets. So I think here you can see, right, it's all communicating on the scan. We looked at the scan. So this is a good window. Actually, this is the largest. I would go for this when you do plan to drain it. I always like to see endoscopically where the lumen opposing metal stent would come in case you're planning to do a necrosectomy. You want to see the angle in which your gastroscope would have to go when you do it. So I always like to take a sneak peek even on fluoro, see how your endoscope is looking in terms of whether you're coming in the cardia, you're coming in the mid-gastric body, and where your LAMS is going to play. But this is a great case for a lumen opposing metal stent. All right. All right. Right. And I think these cases are important to learn when not to intervene or when to back off, keep your patient safe, and we do it the right way.
Sure.
All
Okay,
right.
ma'am. Thank you, ma'am. Thank you.
I know that was.
Ravi sir, your mic on, sir. You are on live. Sir, your mic on. Sir, switch on your mic, sir.
உங்களுக்கு வியூஸ் மறைக்கும்.
Hello?
Yes, sir. Go ahead, sir. Go ahead.
Yeah, can you hear me? Yeah, okay. So we just watched just now a beautiful demonstration of G poem by Amal Bapai in the other room. This patient, the incision has to be closed, and so instead of applying clips, here is Dr. Ravi Shankar from Singapore General Hospital, who's an obesity man, but he is a very thin person. He is from Tamil Nadu, very proud. His house is very close to our place here. So he's going to demonstrate the Apollo overstretch, so which he uses for obesity. He's going to just underrun the sutures and then close this. This is yet another methodology of closing a defect. Over to Ravi.
Thank you everyone. Thank you very much for the kind introduction and allowing us to do this case. So as you can see, I'm going to close the defect. Primarily, suturing device was developed to close defects, then it got expanded to bariatrics. So we are using a 2T scope. Your suturing device sits on the larger channel, 3.2 channel, and in these two, I'm going to introduce your suturing device. This is called anchor exchange catheter. You can see here, the anchor exchange catheter goes through the outer area. So we are going to introduce it this way. So when we introduce this, we always want some tension in the suture. You inform your assistant to exert some tension, so it's easier when you introduce it. So push it in, go. So once the suture comes out, you create a slack, lock it, and then you load the device. Now you can see that the device is loaded with suture, and then we are going to introduce this. So when you want to introduce, hold the scope, make sure you are in a neutral position, your scope is not twisted, ensure that your device is locked, then slowly insert. As you insert, you will feel some resistance from the over tube. We have already started inserting the over tube before. It is okay for you to sometimes not use over tube for closures. It's not always mandatory. Then you hold the over tube, gently advance, 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 and then you will enter the stomach. Once you are in the stomach, your second channel is where your suction channel is. So you suction, empty your stomach, identify the area where you want to suture. You go there, insufflate, insufflate. And then once you identify the area of defect, so the area of defect is here. You can see here, that's the apex. This is the base of the defect. Now you go in with your helix. The helix goes through the outer channel. You insert here. You always start from the apex and then go. So I'm going to start from the left side and then go to the right side. Left side and then right side. That would be our objective. So when you want to take the first bite, as you can see here, the needle has to go from the normal side through the defect, not from the defect through the normal. Because towards the end you want to release the needle, you don't want the needle to be buried inside the defect. By that what I mean is, let's say I'm open, I go closer. If I want to take the bite, you have to go this way, not through the defect this way, because towards the end when you release the needle will go inside. You don't want that to happen. So you always approach from a distance. Your helix, you can drop it here, go.
So now we have Mr. Shyam Sundar rotating the helix.
So
and
he
he's
is
just trying to pull it in.
So he is rotating the helix. You open your wrist if you want to take a full thickness bite. You achieve perpendicularity. By perpendicularity, what I mean is your needle is here, your helix is here, it has to be close. When you do so, your bites are going to be full thickness bites. So your big wheel has to come all the way up bite it, you can feel the sound, which is the cracking sound of an egg. That means that your full thickness. Now I'm taking the needle, open, pull the tissue away, and then you come back. And helix. Okay.
So the helix gets unscrewed,
Then
and
you come
that
back.
has taken a suture bite there.
So we have taken the first bite now. So by doing this movement, I'm loading suture inside, so I have enough space for me to move around. Then you go in again. Now we have taken one bite. We are going to take the next bite. Go. So over here, again here, if you want to take, you rotate your body to achieve perpendicularity. You can see the tissue coming in, big wheel all the way up. Capture. Take the needle, unhelix, pull back, push your endoscope again. So now we can see we have taken 2 bites. The defect is already starting to close just with 2 bites.
This is really amazing. Just with 2 bites, it's closing.
So again,
Otherwise, it is gaping so much.
we go closer here. That's the other end of the defect. Go. You don't have to be very close to the side of the defect. Around 5 millimeter away from the defect edges is good enough. Then you capture it, take your bite, and helix.
So you're making sure, Dr. Ravi, that you're pulling in the tissue between the two, the wires.
The jaws of the. So basically, your tissue have to come in here between these, and then you make it perpendicular. Now the suture is twisting, so you have to untwist it. So it's untwisted now. Come here, lock it. We don't apply suction when we do suturing. Your suturing is going to be quite. Go here, go. So again, you open your wrist, bring your tissue. That's the gaping end. Capture. So the defect is closed. Now you no longer see the mucosotomy that was done. So these are the last 2 edges. What you can do is, you don't stop here. If this is the end of your defect, you slightly go. You start at the apex and also slightly cross the end of your defect to close it. So here, go. Move your device closer. Unlike other endoscopy, when it comes to suturing, you operate slightly at a distance. You don't work very closely because your visibility becomes poor when you want to direct the helix. So you operate at least like 5 centimeters away from the area so you can visualize everything clearly. So we'll take one more bite and then we will cinch the tissue. So insufflate, insufflate. So the mucosotomy was here, and this is going to be your last bite, and then when you crumple, the tissue comes together like this. Go.
It's nice to see that he always keeps it parallel and doesn't intertwine the threads.
On helix. So now we are done. So I'm going to release. Here the sutures are twisting. To untwist it, you just push your endoscope, go against like this. So now we are done. I have to release the needle. So you exert some slight tension on your suture. Pull back. We are still having a cross. Yeah. So you exert a tension on your suture here, so that when I eject the needle goes swiftly. So here, to eject the needle, you press the blue button. The needle is ejected now, so you don't see anything attached to it. So you take it out, and Then we will close the defect.
And this tissue is vascular, so all the gastric, mucosa is quite vascular.
Yeah.
That's
So
why these bites have
cause some
produced
bleeding.
a bleed.
It's expected. On top of it, these metallic ends are traumatic. So when you touch the gastric mucosa, it can cause mild bleeding, and bleeding is expected to happen. Cinch catheter, please. So now we are going to cut the suture. Like in surgery, how they tie the knot. Herein we have a catheter called cinching catheter, which helps you to cut the sutures, and the cutting mechanism is at the tip. So if you see at the tip, there is a capsule here. This capsule, when it goes here, it engages your suture. When it descends down further, your scissors are here. So then it slices the suture. So in order for you to cut, what you need to do is take this end of your suture. You see this, you advance it here, pull it all the way up, let go the suture, secure your catheter like this and slowly pull that. So once you pull that, the thread is here, the thread goes to the assistant, assistant gives me tension and the catheter to the assistant. So assistant who has to hold the catheter like this, easier, catheter like this, and then your other hand holds the suture, and then you give it to me, tension, slight tension, tension, tension on the suture. Yeah. No, there is a, 1 second, let go. Okay, hold it like this, easier.
The cinch has been now loaded onto the thread.
So the cinch is now loaded onto the thread. We are advancing, advancing, advancing all the way in. So you go deeper. You pull back your endoscope. Maintain your views. You don't put this catheter inside and cut it. Your catheter, you have to visualize it and you have to see. You stay, keep your catheter outside, push it down, secure your catheter with these two fingers, then you pull. When you're pulling, you're bringing the tissue together and at the same time, you're tightening it. So at one point, you will feel the resistance, beyond which...
and then it will snap.
Yeah, so the more you pull, it will snap. So once you feel the resistance, you stop there. At this point, what the assistant has to do, take off this, keep your hand like this. Your first movement is like this, forward. Once you move forward, everything drops off. The second movement is you need to put your fingers here, here, and this use two hands to cut it. Yeah? Two in the hand. Cut. Press, press, press hard.
Keep pulling.
All the way. Done. Now the suture is cut. You can take it out. I need flush. So the defect is closed now. If you want to be like surgeons, we can sometimes do double-breasted suturing, where for any mucosal defects, which is through and through, they try to wrap the defect. They will take one more and then cover the original defect so that it completely wraps up. So here we can see that the original mucosotomy defect is completely gone. It's completely wrapped up in our suture and we can't see it anymore. I think this is good enough.
Yeah, I think beautiful demonstration, and double breasting is not required here because only a submucosal tunnel, and then you have the muscularis propria
to support
below,
it. Yeah.
and also the serosa layer all preserved. So
I think this is good
yeah,
enough.
this is a fantastic demonstration. Can we clap hands here? Thank you. Thanks for demonstrating a beautiful suturing of this defect. Thank you so much. I think we should move to the next room where one more exciting case is there. I think, what is the next case?
Let's take it out. This section.
Kishore sir? Christopher sir? Christopher sir, your mic on?
Okay, we can. Yeah, maybe give me 5 minutes to have a look, please. Where is the... okay. Where's Doppler? Pulse, sorry, not pulse, but power Doppler, where is that? Which one? F. Okay. Okay. Very good. Okay. Huge dilated duct. You can see something going on in there. It's a mass. Okay. I'm live now? Oh, okay. Thank you. Thank you, Mathura. Just a big thank you again to Dr. VGM for asking me to do this. It's such an honor and pleasure to be here. Thank you for staying with us till the end of the day. And so, have we presented the case yet? Yes, please go ahead and do that.
This is a 55-year-old male patient who is a case of chronic pancreatitis, had an acute episode of pancreatitis about 3 months back, presented with a unilocular cyst, mainly involving the head and uncinate process, about 3.2 into 3 centimeters, which was compressing on the distal CBD. The patient is asymptomatic, the LFT is normal, and weight loss is there. Weight loss is there. CA99 was normal, so this case has been posted mainly for evaluation of the cystic lesion and then to decide on further management. Over to sir.
Thank you very much. Just wanting to measure. So the diameter of that cyst is roughly 40 millimeters, and okay, I'm not doing a good job here. Just oh, I see. I haven't used this system before, and it looks like you can actually tap to measure. So I'm going to try again. 42 millimeters. Okay, let's try again. But where's the calipers? Okay, here we go. Tap here. Set. Oh, okay, but just now I didn't even tap and set in it. Okay, never mind. We'll do it the standard way. So it's really quite a thick-walled lesion. Cyst, cystic lesion, roughly about 6-7 millimeters thick at some points here, about 4 centimeters across, and you can see that the fluid is sort of slightly echogenic. It's uniform, so this may actually be just leukocytes in there. I don't get nothing in the case history to suggest to us that it's infected, but why? Because debris is a feature of pseudocysts. A fairly thick wall is a feature of pseudocysts, but what goes against it may be the fact that it's really very round looking. So that's, when it's a pseudocyst, you expect it to be a little bit ragged inside. But again, there are no absolutes about this. So let's have a look, a closer look. Now so there's a little bit of calcification there, some echo, yep, in the middle of that. So this all speaks to the fact that it's comes out of a chronic setting of chronic pancreatitis. Now, when we were looking at the body and the tail of the pancreas just before all of you came on stream, I saw that the main pancreatic duct was dilated. The pancreas looked a little bit atrophic, but there was no. There were features of chronic pancreatitis like some lobularity, but nothing barn door, and I didn't see much calcification going on in the pancreatic parenchyma. But the duct was dilated all the way out, and I didn't measure it, but it looked like about 5 millimeters. So that is a suggestion that maybe it's not what it appears to be, because if this is coming out of chronic pancreatitis, you expect the features of chronic pancreatitis, very florid features all the way through the pancreatic parenchyma. But here you're seeing this in the head of the pancreas, and when I just go anti-clockwise a little bit, you can see that there's a ductal structure there. I'm not sure what it is, but let's see. It's branching off, so maybe we are dealing with a pancreatic duct. And let's turn on our power Doppler, and we can see that that is a ductal structure of some sort. So PD, because the bile duct doesn't branch down at the distal duct. So that's the main. That's probably a branch duct or the main pancreatic duct, which is going adjacent to this mass. Running adjacent to this mass, which is thick-walled, has a cystic center to it, and so let's turn this off and interrogate this a little bit better. So if I talk anti-clockwise, we're going up towards the hilum of the liver, and I'm trying to see if I can find the PD, the bile duct anywhere. So what's going on here? That looks like the portal vein. You can see some grayscale Doppler in there, and then there is a cystic or a very hypoechoic structure right there, and I'm guessing that that is going to be part of the dilated bile duct. So if we follow this, we see that in the head distally, and I'm going to pull back a little bit, that is the bile duct, which is sort of narrowing down, and adjacent to it, so is the main pancreatic duct. Can we freeze the image? Is Shivangi, are you there? Can you give me a hand, please, with the with all the little controls? I just wanted to show that the main pancreatic duct is right there, and it looks like the cyst might be communicating with the MPD. What do you think? Sorry, let me. Oh, okay. I was going to switch off the.
Professor Chris,
the
do you
flow.
think this is communicating pseudocyst or
Well,
a cystic neoplasm?
That's a really tough question. Yeah. I'm going to reserve my answer for the moment. I'm just saying that maybe it is communicating. No, it's not. It's something else,
Yeah, it's thick
I'm just
walled.
wondering, it's thick-walled. So that seems to be isolated because the contents of that lesion
This
are quite
this
echogenic.
seems to be a thick-walled,
It is.
isolated cystic lesion, but
It's
has
echogenic.
got some debris also inside.
Yeah, no, so I'm wondering, you
Echogenic.
see, what you see over here is another something else here.
Yeah,
It's very
yeah.
easy if I point out with my finger here,
Yeah,
but there's
that-
this is
that
a cystic
was
structure here.
communicating.
That's the MPD there, and where is this heading towards? We don't know. Where is it coming from? Where is it going to? Is there? Uh-huh.
Would extend to the,
Right.
the body and the tail.
Right. So, I mean, this kind of raises the question: is this, a neoplasm, a cystic degeneration? And we know.
Would that change what you are planning, or?
Well, I was planning not to stick it, but I think now it looks like we have a good reason to do an FNB off the wall.
So we do have the Moray forceps in the
Oh, we do. Okay. Okay.
room if
Okay.
you feel it's a good
Okay.
lesion for a
Yeah, perhaps.
with a thick wall.
Yeah. It's I don't have a lot of experience with the Moray. I just been a little bit frustrated using it because it can be a little bit tricky to use, and
And it needs a 19 gauge needle.
you need a
so-
19 gauge needle, and it gives you very small specimens. And just now we were talking about small specimens with a spy bite. These are even smaller, right?
Yep.
Okay, so let's before we do any sort of probing of this, let's go down to the uncinate and see if things look any different. So the examination of the uncinate is really in a short position. So I'm going to do that. And we are seeing it from the uncinate, really from, and you can see the aorta on the left of the screen. I'm going to try not to slide back because in the short position the scope is a little bit unstable. So what's underneath the transducer is uncinate, technically uncinate. You can see that this lesion extends from the head over to the uncinate. We are seeing some ductal structures there. They look like branches of the PD. I don't think there's any CBD in there, but it'll appear towards the right of the screen. And we're going to try to just look around here. We wouldn't FNB in this position, or FNA in this position because, well, we can if if we really need to, but the scope is a little bit unstable. And also the needle, the angle of the needle is going to be very sort of oblique. You really have to sort of put a lot of onto the elevator to get it to almost perpendicular to do that. So, right. So this, I would agree that this is coming out of the head uncinate. Is it coming? Is it associated with the PD? Maybe not. And the appearance certainly. So this is the major papilla. It looks absolutely normal. Maybe a little bit bulging a little bit, but within the limits of normal. Right. I don't think any of us would call this out and out of normal. Okay, and then we will come back, and there you have the right kidney. So we'll come back into the duodenal bulb. Where are we? We still. Looks like we're still in duodenum. Okay, so now we're back into the stomach. I'm going to decompress a little bit here, pop through, and now in the apex of the duodenal bulb, this is where we are. And again, let's have another look at our structures. So bile duct is on the extreme left. Pancreatic duct is probably the one which is just adjacent to that bigger structure. And yeah, we should be able to find a window into here.
Yeah.
So that other structure with no flow looks like it's part of the pancreatic duct, but I don't know. I'm not really sure where that's coming from. So we certainly do need to biopsy the wall of this. We should. We can also sample the fluid in there. Which one would you do first, Shivangi?
So it depends if you do choose to do the moray, then I biopsy the wall first and then aspirate the fluid to dryness.
Right.
If you plan to do FNB, then I would aspirate the cyst to dryness and then do a separate pass to FNB the wall, the solid.
I guess
part.
to use the moray, you need to have some volume in there, right, to keep it open.
Yeah, so you aspirate the fluid after we've done the biopsy.
Because you need to see the forceps open grab it, tent it, and then pull.
Right.
Okay.
And again, for the audience, the meta-analysis do suggest up to an 8 to 10% complication or bleeding rate. So
yeah, pancreatitis about 9-10%. Okay. So are we going to go for it? Okay. All right. So can we have a 19 gauge needle, please?
Put the flow off.
Yes. Yeah. That. I don't think this is a main. No, it's not main duct IPMN because we had a good look at the PD just now, and the PD was dilated, but it was completely empty. So it's all about this this cystic lesion here with a thick wall, with some areas of calcification within, and nowhere else in the pancreas. One other possibility, I suppose, could this be a gist with cystic degeneration? I mean, if it is, that this is not good news for the patient. Huh?
Right. Or a neuroendocrine, yes.
Oh, neuroendocrine tumor, yeah, certainly. Okay, 19 gauge. This is not going to be easy. We can try. I think this needle from Olympus is a little bit more flexible, so we might be able to get it out. Let's see. So typically, we don't use 19 gauge needles in the. Oh, sorry, you didn't forgot to take that out. Yeah. This is what happens at the end of the day. Okay, we just put that there.
Also, what's your take on antibiotics?
Definitely need antibiotics here.
Yeah, so I do give antibiotics when I do FNA of pancreas cyst.
Any of cystic lesion, but you don't give for solid lesions.
Yeah, not for solid lesions, right.
Okay.
And you always want to try to aspirate the cyst to dryness again to minimize
absolutely.
the risk of infection.
And try to not fewer passes possible. I mean, when I first started doing EUS, it kind of used to get drummed into our heads that you only want to do one pass. But I think it's become liberalized, I think. Now, what I want to do now is to make sure that I can get the needle out. So this actually has a spring sort of sheath rather than the kind of the plastic or Kevlar type sheaths that the other needles have. So it's not coming out, and I expect that. So what we will need to do is to go back into the stomach and make sure that we can get our needle out, the sheath out at least, to make sure we don't damage the scope. Okay, there you can see it at the lower right quadrant. I've pulled it back. So it's just protruding out of the channel beyond the optics of the scope. And we're going to go back in. Okay. So maybe we'll be able to get that needle out now. Okay, so first order of business is the moray, huh? Okay, can we have the flow, please? Okay, there's my needle, and if we could sort of turn it across. It's quite a vascular area. Yeah, you have to use this.
Okay.
Yeah. Okay, thank you. Yep, that's good. Thanks. So, how big a flow can you stick this needle into? Well, nothing that has a name, right? It's okay. Why am I not seeing the... We were just a bit too far away just now. Yeah, and you don't want to stick a duct either, huh?
Right, yeah.
So I saw the PD just now, and I'm going to stay clear of that. Shivangi, could we have the Doppler again,
yes,
please? Okay, this is more vascular here. It looks better just now.
That seems like a good window.
Yeah, this looks all right.
Yeah.
Okay, could you leave it on for me, please?
Sure.
And then I'll sort of just try and pick a spot to plant the needle. Okay. Okay, this looks good. Off, please. So it needs to be a sort of stabbing movement. This needle is actually particularly sharp, so it lends itself quite well. Here we go.
Perfect.
Okay, so I'm just going to push the scope in a little bit. And if we're going to advance this. Yep, okay. So
Right. We'll take
we
the
will remove
stylet
the
out
stylet
now.
out. So push through, push in first. Push in before removing. Yeah, just dislodge whatever is there. Okay, now please remove.
We'll no more.
Yeah, through the needle forceps. So the moray is tiny. It'll fit through a 19 gauge needle. It's built for that, but it doesn't come cheap.
Yes.
And in Singapore, it's the equivalent about about $500 I think, or 450, something like that. Yes, please.
Yeah, so
Yeah,
again,
close,
you
yeah.
know, every device you
Yep.
open, you're thinking the indication, complications, and here this is a very good lesion where you want tissue of the wall, and there is a concern for cystic degeneration of a solid tumor.
Yep. Can I just check that we have antibiotics on board for this patient? Yeah? Okay, good. Okay. Okay.
Pull your needle back.
Christopher,
Yep,
sir?
just pull it back to see. Yep.
Christopher, sir?
Yep, that's right. Okay, so we just keep advancing the needle until we see.
It's coming.
It's coming, yes, it's coming. You can see that.
Yeah, it's
Okay,
very,
all right. Just advance. Okay, stop there, please. Can we open? Okay, so what we do now is that we have to push the needle forward. Please push the needle. Yeah, you can push the needle also the forceps forward, please. Forward some more. Push. Yeah, push in. Yeah, it's not moving. Yeah, is it moving? Yeah. I don't see it moving. Yeah, push. Yeah. Yeah, don't push the needle, push the forceps. Only the forceps, yeah. Yeah, keep going. Okay, so maybe what you can do is you hold it there, I will push this forward. Are we on top of one of those calcifications?
I think so.
Well, maybe on something, huh?
So try to close. And
Yeah,
if you
try to
pull
close,
it,
yep.
Close and
Close,
you'll
please,
see the
close,
tent.
please. Is it closed? Okay, hold on. I will pull the needle back, hold on, and see whether there's any tenting. It does look like it's tented, huh? What do you think?
Yeah.
Okay, so pull out.
Yeah.
Yep.
you
Okay,
got
you
a
can
nice
see.
piece.
Yeah, you can see there's a little piece at the end there.
Yeah.
Okay, so please remove.
And again, these are very small pieces like the spy bite where
Yes,
you want to
yes.
handle them with care.
Exactly, and we have
speak
to.
with your pathologist.
Exactly, just warn them that it's not going to be a big chunk.
Yeah. And if you have the ability for a rapid on-site cytology, you could use their assistance to
That's right.
make slide touch prep and get
That's right.
evaluation.
So maybe we'll make 3 passes or something with the forceps, then drain it till dry, and then we'll do the wall on the way out. Yeah. What's your favorite sort of sort of acquisition technique?
You apply a band and then cut it off.
Great. So
because we don't know that it's not a sessile, it's like something like a sessile polyp, not really a pedunculate.
Yes.
So it's in the D1. It's in the D1.
Yeah. So Amal is planning to cut this by band ligation, and it's going to be a band MR. We are going to do a band ligation and then cut the polyp below the band. So prior to removing it by band ligation, he is creating a submucosal cushion. He is going to inject submucosal fluid now to ensure that when we cut it, we don't risk perforation. So Amal has nicely positioned his
B side and inject
yeah.
downside.
Yeah, other side.
Beyond the polyp.
Yeah.
Yeah.
Beyond the polyp. Beyond the polyp. Down. Further down. Distal. Start from the distal end. Yeah. Start from the distal end. Yeah. From
That's
there.
all.
And then inject.
Can I have the needle, please? Needle out.
Yeah.
Go to the distal end, even down. Not there, even below. Can you try here, somewhere here? Yeah, that might be better. Because as the polyp comes up, then it doesn't go down. Yeah?
Pull back. Yeah, go there. There.
Yes.
Go.
Perfect.
Inject, 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 and then while she injects, you poke. Yeah, go ahead.
Keep injecting, yeah. Yeah. Perfect, perfect. Great job.
Yeah,
Great
continue injecting, continue injecting. So you can sometimes do dynamic injection in order for you to get a good submucosal lift. Here we can see that there is a good submucosal lift here. You would also want to achieve some mucosal lift on the proximal side. Yeah, go there. Your needle deep inside, slightly. Okay, good. Push your scope in. Yeah, careful, careful. Why don't you inject some more here?
Yeah. Little loud.
Inject slowly, slowly. You have to poke, go in more, yeah. Not yet. Your needle is, why don't you position your needle over here? Yeah, needle out. Out. Go. Yeah, good, good, good. Keep going, keep going. Inject, 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 inject. Nice. So we have achieved a good submucosal lift now. This is adequate. Yeah, needle back. Now we are going to get the endoscope out, load it with a band ligating device and go in.
I mean, Ravi, from the way this lesion got lifted up, obviously shows it's mucosal, as you rightly pointed out. Now suck out the air and come out, please. Yeah, get into the stomach because we had inflated, right? Now we are just sucking out the air and he'll come out and quickly load a band. So this beautifully showed that it's a clear mucosal polyp. So and there's nothing in the submucosa, and we have produced a good saline cushion. The problem with saline cushion is it quickly disappears. So very quickly we'll have to go ahead and band it and then snare it. Always banding and snare. This is band and snare technique of removing a polyp.
Thanks, one. Yeah, sure.
Okay, okay.
Christopher sir, my
Okay,
concern.
we can show the sample. Yes. Hello. Sorry, sorry for the inattentiveness. So yes, don't open the tab yet. You can just put it on, please. I'll open the tab myself. The other way, the other way. No, don't open the tab. Don't open the tab. It wasn't open yet, right? Okay. No, if you're not sure, then we remove it and charge again, please. Okay. So when we were off camera just now, what we did was 2 more passes of the Moray TTNB forceps, and it looks like we have a total of 3 good specimens for the histopathologist. So the next step was to, when we removed the Moray for the last time, we put on full suction and aspirated a total of, it was maybe about 30 mils of blood stain. There it is. So Dr. Shivangi is showing you that. So I think, or we think, we agreed that it looks like pseudocyst fluid,
yeah.
which is blood stained. Okay, but of course, it's anybody's guess whether we're right about that or not. So,
What are all the parameters that you check using the?
yes, so cytopathology, CEA, amylase. And for a quick in-room sort of evaluation, we put a drop on a glucometer, and that came back as 35 milligram percent, which is below the threshold, and it would indicate that this is a mucinous lesion. Of course, if it is a carcinoma that arises out of a mucinous lesion, then that can be low as well. Okay, so can we have the syringe back, please, with the suction, with half suction? So what we're doing now is the equivalent, yeah, half suction, please. Yeah, all the way down and then pull back halfway with the tap closed.
So what I was doing
Okay,
back
this
there
is
was
full
making
suction.
sure that the fluid is handled properly, it is sent to the right lab, chemistry, cytology, and now we're doing an FNA of the wall,
Yeah.
cyst wall.
Yeah, it's kind of mobile here, so I don't want to fall out, because if I fall out, everything is lost, right? It's all going to go into the syringe. And it's kind of hard to move this, very hard to fan. I'm going to... It's not hard. Hard to say, because there's so much resistance from the needle itself, a 19 gauge needle. Yeah. No, this is just a thick wall, but I think it's anybody's guess what the pathology here is.
Yeah.
No, so I wouldn't be surprised if this is a cystic tumor. Yeah, that's cystic degeneration of either a PDAC or a PNET.
Right.
Almost falling out. Okay, I think that should be enough, right? Okay, so always remove your suction. Keep the tap closed. I prefer to remove the whole thing.
Yes.
Yeah, I don't think we have a cytopathologist on site, so we just push it all into. Yeah, you can. So you can push this all into formalin, with a stylet, with a stylet, so that it doesn't get fragmented. Okay, thank you. So actually, we're left with kind of like a tumor, with a little bit of residual fluid in the middle. Yeah, of course, yeah.
And we're almost done here.
Actually,
we're done here.
Yeah,
so,
it'll be more of the same. That's right. Okay.
Sir, audio back with you, sir.
Right. So now we have put the cap, and now you can see the lesion through the cap. Right. So now I am going to suck it. So now we have a lifter. We have entered with the plastic shooter. The red color thing which you see in front of you is the lesion. It's very nicely positioned inside the cap. Amol is going to suck it out. Okay. Captured, we can see that the black color band is nicely seated at the bottom. The next step is we are going to cut this
So while they are preparing, I must thank Dr. Meiji Mohan Prasad, my long-time friend, for inviting me, and it has been a very great workshop. We have seen very fantastic cases. Thank you very much, Mohan. So shall I thank? Can I have some gel, please?
I think we have fixed the cap at the tip of the endoscope using the micropore tape, because so that it should not get detached and fall off. Then you're going to convert it into a foreign body removal. So Ravi was very careful and just wanted it to be fixed. This is the EVIS X1. So what you can do, you can even later on when you see the banded polyp, you can use NBI to show if there is any difference in the mucosa from the surrounding. So, yeah. I think we have to exercise profound caution in removing polypoid lesions from the duodenum because you can easily perforate if you go deep. So, see, all this care was taken in order to prevent lesion from getting perforated, I mean the duodenal perforation from happening. So, what do you think, Ravi? You know, like, yeah, we are using the Steeris snare. That's what we're using. So it can, expand to 3 different sizes as you push or pull. So this is the beauty of this Steeris. It's a beautiful one. I've seen one similar one is US Endoscopy also has a similar. This is from US Endoscopy only. They make such nice products, a very nice product. So it should be very useful. It just adapts to the size of the polyp. So other polyp snares are all one size fits all. Here, you can make it into 3 sizes. So, and what do you think? Like, would you do like Americans, Ravi, to put the snare under the band or above the band?
I always go under the band. So we position it below and then we cut it so that you get the maximum amount of tissue that you can get. You don't have to worry about perforation. Okay. Even if it perforates, we have enough tools now to close it. And we have clips, we have Ovesco, we have many things. And the defect size, even if it is, it's going to be very small. You have to go below the band.
Yeah, that's fine. That's fine. You caught it well. See to that you just pull towards you and see if it is, not bringing out the rest of the mucosa. That's what. The mobility should be free.
Yeah, that's nice.
Yeah, that's perfect.
That's nice. Slowly close the snare.
Close it, please.
Yeah. Okay.
After closing, before cutting, you should pull and check. So that it's not putting the wall. Nothing else is caught out.
Insufflate?
Put some water on it. Can you put in water?
This one, do you have no water?
Put in water. And I want Ravi to answer on underwater cutting. So what advantage does it have, these polypoid lesions?
I think this underwater cutting is good. The concept behind underwater cutting is when you fill your entire colon, we notice that we displace or we make the muscularis propria straight, and then your mucosal lesions are going to crumple. So even if the lesion is big, it is easy for you to capture en bloc, and since you have displaced the muscularis propria, theoretically they say that with underwater EMR your en bloc resection rates are higher and then you don't tend to have muscle injury. But be always careful. There are reports emerging with use of underwater EMR where people have perforated.
Okay, come back. Okay. Yep.
Are we going live? We are live. So now we are closing the defect. Just a minute. Careful, yeah. Pull back. No, don't push back. Pull back. Pull back, Amma. Reposition it. Okay. Push your endoscope. Okay. Suction now. So now we are insufflate, and let us show them what we are doing. Insufflate. So what we are doing now is the polyp is removed now. We are going to close the defect. It's always better to close the defect in the duodenum. Pull back your yeah. It's always better to close the defect in the duodenum. We are using the Viper chemo clip from Stirix, which can rotate 360 degrees. It's easy to use. It's open and close clip. Pull back, yeah. Pull back, and then move with your endoscope. Move your endoscope closer. Yeah, move your endoscope closer. Yeah. Now suction. Okay. Now insufflate. Insufflate. So we can see when you want to clip, you want to capture as much tissue as you can. Here we have captured the I think we have to reposition it, yeah.
Ravi sir?
Yes?
The next set is ready. We will move on the next set and come back to you, sir.
Okay,
yeah, thank you, sir. Thank you.
Thank you.
Shivangi ma'am, your mic on ma'am, you're on live.
Can I demonstrate the
Yeah.
case, ma'am? Yeah.
Go ahead, man. Go ahead, sir.
Yeah, so this gentleman is a 57-year-old male who presented with a pain, abdomen, fever and jaundice over the last 10 days. And he was a known case of chronic liver disease. So when we did a CECT abdomen, so it was a like irregular liver contour with that left lobe enlargement with a dilated proximal CVD. And there was a distal CVD, some soft attenuating mass which obstruct the common bile duct distal part, so which may cause that proximal part dilatation. So in upper GI endoscopy, we found that grade 2 esophageal varices, but there is no RCS, no fundal varices as well. but portal hypertensive gastropathy and duodenopathy. So patient recent LFT report that it was a total bilirubin 2.1, SGOT was 57.4, but ALP was normal, but INR was 1.7, ma'am. Though we have already given fresh frozen plasma here, so already 6 been given, ma'am. So the recent, the next plan was US guided FNB of that periampullary lesion. We had done a CA99 also, but it came normal as well.
The CA99 is normal, Billy is normal. Hello everyone. My understanding is this is the last case of the day. So kudos to the audience who's been with us all day. And kudos to this entire team. We have one more. Okay, so we're second last. Huh? Oh, we're not audible? Yeah, we're on. You can hear me? You can hear me? Yes? We're live. You can hear me? Perfect. All right. So we're back with the second last case of the day. So still kudos to all the audience who's been with us all day with all the interesting cases. Again, a big shout out to Dr. BJM, Mitra, Madhura, Vamshi, and the entire team here. Vishwanathan, who's been with us for all our cases in this room. So we are doing the CUS, as we saw from the history, there is a concern for a periampullary ill-defined lesion. However, the bilirubin is not normal. Patient does have some underlying liver issues and portal hypertension. And the patient actually had an endoscopy, which is one of the first things you want to do when you have a dilated bile duct or even a double duct sign with no obvious mass. Make sure there is no mass at the major ampulla. So if you look at the endoscopic view, endoscopically actually look pretty normal. And what you are seeing here we are in the second portion of the duodenum, and we're starting our exam from the uncinate process as we slowly torque right and left. This is the hardest patient, again, mind you, for to master. It's the last thing that you will kind of get comfortable with in EUS, and you're slowly pulling back, and we're looking in the right hand side upper corner, the PD is coming in view, and then you see the CBD right above it. And what you are seeing actually is a large diverticulum filled with food that is causing an extrinsic compression on the duct. So if we can freeze and show that image, can we freeze? Freeze? Okay. And yeah, just show the marker. All right, perfect. So right here in this area you can see a large diverticulum. Actually it has food contents inside, and you can see the CBD coming right underneath it, and the diverticulum is causing a lot of artifact as well as extrinsic compression on the bile duct. We have not yet, you can unfreeze, seen a mass in this area. Again, we're going back and forth, and this goes to show that the value that endoscopic ultrasound has in terms of evaluating small lesions, which sometimes the imaging is not clear or may miss. you have the ability to do the endoscopic ultrasound and get biopsies. We're looking at the head area. You're seeing the PD come into view, and then as we slowly torque left, you see the CBD. Yeah. And then the CBD again, as I show you from the duodenal bulb. We're now in the bulb and we're looking at the CBD. Whenever in doubt, you can use flow to confirm if you're looking at the bile duct or the portal vein.
I just have a thought process here. This is a chronic liver disease patient, and there is some history of cholangitis and some, I think just
there is
LFT
the
elevation. Are we thinking of portal cholangiopathy? We know this patient has varices. Is it possible to demonstrate the periportal, choledochal varices or something on this?
Sure.
On EUS? Yes.
If he has varices, we should be able to see them. So
just wondering if that could have caused the dilated CBD. Actually, he's not symptomatic for it. We have pain abdomen was there. Jaundice was there, but that could be the jaundice could be the liver disease.
We have a little bit of artifact again. We're missing a balloon, but if you sorry, my bad. Flow. All right. So here you can see we're looking at the bile duct, the portal vein underneath it, and the PD coming into view. And as we're slowly tracking the bile duct down to the major ampulla, we're not seeing any obvious mass lesions.
No obvious varices also, very
periductal.
No.
Sometimes you can see that actually in cirrhotics is periductal varices causing extrinsic compression, but here this patient actually has a large tick, and we instilled some water in it.
So the diverticulum has caused this flaccid CBD and dilated CBD.
Right. So there is the PD coming into view. Yeah. So and there you can see the tick filling in with water. You see that? So that's what we were trying to demonstrate.
That's a beautiful demonstration of the diverticulum. So, so important to see the OGD view as well, and not just the
EUS view. So
yes. And this is something which CT could not pick up because it said that it was an ill-defined lesion. I don't know whether they meant the diverticulum.
Because again, it's very hard for the CT if it's food-filled to delineate the tick. So we're getting a very nice view of the head of the pancreas. We're rocking back and forth, coming back slowly. And there is the bile duct coming into view.
There's some strands and strands, hyperechoic strands.
Yeah, so he does have some subtle changes. We're tracking the pancreas now. You can see the PD in the neck. That's the PD. We're tracking it, slowly pulling backwards in the pancreatic body. We're seeing some hyperechoic stranding. That's the kidney, left kidney underneath the pancreatic body. And now we're heading towards the tail. That's the tail of the pancreas and the splenic hilum. Now if you look at the liver, we don't see any, yeah, there is some heterogeneity. But I'm not seeing any significant collaterals around the duodenum. And again, the spleen can be enlarged in these patients, so always be careful, especially if you're planning a liver biopsy. Make sure that you're able to delineate the plane between the liver and the spleen. All right. So again, we learned the value of the EUS, the 3 stations that help us get a good evaluation of the
Thank you for taking
pancreas
us
and
through
the
all
bile
the
duct.
stations, all the.
Yep. So there is our bile duct, gallbladder. So again, these are areas where when you start looking for EUS guided gallbladder drainage, you look in the duodenal bulb or the antrum. Those are the 2 locations where one would think of putting a lumina-posing metal stent and doing an endoscopic EUS guided gallbladder drainage.
Do you do a lot of US guided gallbladder drainages?
Yes, I do EUS gallbladder
You prefer that
drainages.
to other US biliary drainages, or?
No, that is for patients that are not good surgical candidates and who are never going to get cholecystectomy. Those are your ideal candidates for EUS guided drainage.
All right. Thank you.
All
Thank
right.
you very much.
Thank you guys. Yeah. Yeah.
And friends, so we had a fantastic, sailing right from morning 8 o'clock until now. We have gone non-stop, and all our faculty members and the entire team has been working. So we quickly introduce our team, and then we have very important lecture from Professor Christopher Kaur from Singapore General Hospital. He's going to show you some videos of difficult ERCPs, how he achieved the cannulation. So please hang on the next few minutes, maybe another 20 minutes we'll be able to close this session. So please hang on till then, please continue to listen to us. I'm sure you'll enjoy. So let me introduce my entire team of gastroenterologists. So please come over here. Dr. Madhura Prasad Suman, Dr. Vamshi Murthy, Dr. Mitra, our hepatologist, and Dr. Sunil Chako Varghese, and where is Dave? Srinivas Reddy, where is Dave is behind, and Dr. Srinivas Reddy. These are the entire team of gastroenterologists. Sangameshwaran, can you show Sangameshwaran? Yeah, we're all, this is a big team of gastroenterologists. We have 6 gastroenterologists and 1 hepatologist at BGM Hospital. And so we are able to do all the procedures non-stop. And even if one is on leave, there are others to cover up. So we have a very good team here. Very harmonious, very hardworking, very nice team. So congratulations to all of them. And now will you move out, and then we'll introduce the anesthesia team headed by today. All the cases went very smooth, thank God. It was because of 2 people. One is Harish, please come over here, and Dr. Majid. They both, and the entire team, Kodi Arasu, and who are all the people here? Kodi, come this side. Ramesh, where is Ramesh? Ramesh. Ramesh and Sister. I want your name, sister. Pechi sister, and Anbu, Anandraj. And of course, our chief of our gastroenterology OPD is here, Raji sister, who masterminded the whole thing and talked to all the, patients. And please come in. Ramesh, please come. So, and your name I just know. Lakshman and Padma sister, all these people, they've all been helping us with all the cases, anesthesia support team. Salutations to all of you. We had a very smooth journey. They deserve a big round of applause. And then of course our endo team, please come over. Thank you. So you can all move out. You can also, Kannan stay here. So, vaangappa, indha pakkam vaanga. On the endoscopy front, there are 3 people there, the trio. Please come here. Yeah, the senior most are Kannan and Ranjani sister and Vishwanathan. So Vishwanathan moved from Chennai to join us. So these 3 are real experts, and then followed by Mary sister and Anbu. And they're all, Malika sister, Anseline sister. Where is Anseline sister? So they're all, entire team. They've really toiled for days to get the whole program. Yeah, Malika sister and Anseline sister. So thank you so much. I think we should give a big round of applause to all this entire team here. So very grateful to all of you for all the hard work. Thank you. You can keep going now. And there are Olympus people and, innovative therapeutics, and we are very grateful to Videoline Anand and team, and Babu, who was, masterminding the whole thing from the central console room. So he has done a very good job in switching between theaters and to take this whole endoscopy transmission live across the globe uninterrupted. So, and my gratitude to the entire team Olympus. So, yeah. Please come over. Wang sir, please come, please come. Yeah, come. So, ITPL as represented by Vignesh and the entire team Olympus, and some more are missing. So, Malesh Praveen is coming, and what's your name, sir? Maniganda Prabhu and sir? Santosh Babu. Santosh Babu has been known to me for so many years, but we don't interact. And yeah, so the speedboat man, please come here. Venkatesh, and what's your good name? Shankar from Boston. Mahendran and Dilip, and of course Praveen. Praveen is our, our heartthrob. Because whenever we have a heart throbbing, then we call Praveen immediately for help. And he is there to help us with all the Olympus breakdowns of scopes and whatever. Immediately, the whole team is there. Salutation to the entire Olympus team. Big round of applause. We need a very big round of applause to all of you, because they have toiled for days and transported tons of equipment to bring this workshop, and also the hands-on training. 50 participants yesterday got real hands-on training on whatever techniques they wanted to learn, they learned. So grateful to all of them, and Innovative Therapeutic Saravanan and also Vignesh for masterminding all the hands-on training sessions yesterday. So it went very well. So thanks to all of you. If I have not left out anyone, I hope I have not. Alanjas, please come. Team Alanjas, we have been sailing with Alanjas, imaging for the past 20 years, and I've always used all Alanjas C-arms. We use some of the latest Alanjas C-arms, and also the laser, the Holmium laser machine, which is a brand new machine from them. What is the name of your machine?
Holmium, sir. Holmium Blaze 30 watt.
Yeah, Blaze 30 watt. Yeah, Holmium Blaze 30 watt is from Alanjas. I mean, very beautifully we demonstrated blasting of the CBD stones, the large calculi. I think all cases went well. So grateful to all of you. Thank you so much. And now we will request. Yeah, Irby people also were there who brought in their APC and everything. And because of the flight, they had to leave. I'm grateful to Microtech for providing lovely clips which are used in F-Poem because of the shortness of the length, and also there is nothing that is left behind to fall off into the peritoneal cavity. So Microtip clips, and of course Anil Sandeep ji, please come here. And what's your name, sir? Please. Dilip, yeah. Dilip and entire team Olympus, we just gave a big round of applause to the entire team Olympus. I mean, without whose help, we would have never done this program. So, very grateful. And our radiographers, please come. Sorry. Our biomedical Shanmugh Sundaram and radiographer, Munishwaran. Full name is Munishwaran. In spite of his trauma he had recently, he was standing there all through, trying to help us. Very grateful to the entire team. Thank you so much. And all our ward boys who are shifting, and the entire team of BGM. And Healthware, of course, were there to help us, Shyam Sundar and also his assistant, Jijo John. And they were all there to help us with the suturing, and amazing work, and thank you so much. And Professor Chris Kaur, are you ready to go with your lecture? We are very eager to know how you overcame the problem of, difficult ERCPs. Over to Professor Chris Kaur. And thank you very much to all the viewers for staying back with us all along. We had more than 1,200 viewers since morning, and I'm sure tomorrow more people will be watching, being a holiday tomorrow, a Sunday. On a working day, to have so many people, we are really, really thrilled. And any of you who want credit hours, from the Tamil Nadu Medical Council. So you need to apply to us. For the credit hours, we'll just get you. And the entire team EDP, led by Ebenezer and Rajesh, who was designing all the all the flyers, everything, and also to see to that the interfacing between the team of Videoline and us. Everything was done meticulously, and my PA Arjun and Administrative Officer Dinesh, FM Lenin, and HR Prabha, all the team of we told. And this is Ebenezer, and this is Rajesh from Electronic Data Processing Department of VGM Hospital. They all did a phenomenal job. So, and to all the staff nurses, intensive care nurses, ward boys, and the canteen of employees of VGM Hospital. And more than anything, my wife, who's the administrator of this hospital, never showed her face here, Radha Prasad. Very grateful to the entire team, and Dr. Suman, my orthopedic surgeon, who's my elder son-in-law, who just spent hours and hours working on for this conference, even though it is pure gastroenterology endoscopy program. Thank you so much, Professor Chris Kaur. Can we switch to Professor Kaur?
Christopher sir, your mic on, sir.
Thank you so much. Professor Kaur, you are there, ready.
Okay, I start now. Good evening. Thank you for joining us in the Gastro update from Coimbatore, VGM Hospital in Coimbatore, and my thanks once again to Dr. Mohan Prasad for inviting me to do this. Is an absolute pleasure, and I hope you enjoy this little talk that I'm going to give on some case studies in difficult biliary cannulation. So this is the outline of my talk, and just the main focus really is on the few video cases that I have. Sometimes we go to some of our our masters in the field, and this is Dr. Guido Costamagna from Rome, who who really tells us that every papilla is potentially difficult. And that is really very true, because if we approach it wrong, we can make what should be a simple cannulation difficult indeed, and really compromise the care of the patient. So just some quick words about major papilla anatomy. And if we look at this, I'm trying to find my cursor here, but if you look at that diagram, the cartoon on the left, this is the face-on view showing that the common bile duct runs in the 11 o'clock direction from the face-on view of the major papilla, and that's the line that you see in blue, whereas the line that is in red depicts the pancreatic duct, and it is actually kind of a going in type of course, and then going towards the 2 o'clock position. And if you look at the diagram on the right, a small major papilla has a different sort of slightly different angulation. In other words, the angulation is a little less obtuse of the bile duct. And generally we talk about the bile duct because that is the target of cannulation in maybe 80-90% of the ERCPs that we do on a regular basis. So just some cannulation tools. The tools of choice really for cannulation in the 21st century are to use a papillotome and to use an angled hydrophilic guide wire. And this will get you, with a little bit of talking, with a little bit of skill on the part of the assistant, will get you into a difficult major papilla. Contrast is used to see the way and to understand the anatomy. We want to avoid multiple injections, and we want to avoid injecting under very high pressure. So let's move on to the first case. This is a 62-year-old female who presented in cholangitis, was very ill with septic shock. CT abdomen showed gallstones, dilated and mildly enhancing wall of the common bile duct. So these are all features of cholangitis. And what we used in this case was a clever cut papillotome, a 0.025-inch curved Visiglide 2 from Olympus. And this is the video that I want to show you. And this is, again, to illustrate the point, and this is a fellow doing the cannulation. This should be a relatively straightforward cannulation, but if you approach the papilla wrong, then you make things harder for yourself. So here, if you can see my cursor there. The cannula is heading from right to left, but the course of the bile duct is really in the 11 o'clock direction. So they're actually almost at right angles to each other. So this approach is not going to work. And something needs to be done very differently. So I'm going to forward this on a little bit. And you'll see this is like the second cannulation by the fellow. It has not changed very much at all. And so there's no surprise that this is going to fail. So now, sorry, this is the second cannulation. It looks a little bit better. It looks a little better. And here the fellow is trying to line up, and the instructor is really coaching from beside to try and get the fellow to line up the cannula with the bile duct. And you can see that with a little bit of contrast, very careful contrast injection, there is some filling, but the guide wire is not going there. So I want you to see what looks different, when the instructor comes on to the scope. And we need to do this because we don't want to give the patient a complication, cause a complication. And of course, we need to get the job done and achieve cannulation. So here, I'm going to pull this forward a little bit because all this is not working. And we are coming to the end of the, I don't want to overshoot it because when the instructor comes on, it is very quick. And again, it's almost agonizing to be watching this occurring. So here, this is the teacher or the instructor. The first thing the instructor does is that he or she looks at the papilla. And what he does is to line up, okay, by putting the scope tip up and pulling back on the scope a little bit. And what you're doing here is to line up, and the cannula just goes directly in. You actually do need to be in the room to see this, but the point is that everything that we teach a fellow to do when we are instructing in ERCP with cannulation is really in achieving the proper orientation and direction of the travel of the guide wire and cannula, because you can't fight nature. If you try to fight nature, bad things happen. And if you do the right thing, it is easy. So this is a very nice case in point where if you point the cannula and the guide wire in the right direction, in the axis of the bile duct, cannulation will proceed fairly easily. Okay, so next video, and this is a PD stent, a pancreatic duct stent assisted cannulation. This patient has a large uncinate mass causing distal CBD obstruction. And you will see that in the initial part of the video, we mistook the minor papilla for the major. And then later we see the major, and we make use of papillotome, again, which is the standard technique with a 0.25 curve Visiglide 2. And we put a skinny 5 French Siemens stent. And that helps us to get into the bile duct. So here we are going. This does look like a major papilla, but maybe it's a little bit small. Maybe it's a little bit small. Why do we think this is the major? Because it seems to be in the right position for the major. But as we are trying to cannulate, it becomes apparent that there is something further on in the course of the duodenum. So clearly this is not going to work because there is no bile duct attached to that little papilla. And we see that there is something big going on here. And by advancing the scope, we happen upon a large ampullary mass. And this is almost certainly an ampullary tumor. And that is where the ampullary orifice is. So with a big mass there, very likely malignant, we often encounter difficulties in biliary cannulation. So remember, this patient needs biliary decompression, and we need to do an ERCP. So the short story, I mean the long and short of this is that we managed to get a pancreatic duct cannulation, but not a biliary cannulation. And so what we are doing here is to place a pancreatic duct stent, I beg your pardon. And we've placed a long stent. We want to place a long stent because you either place a very short or a very long stent, because you don't want a 5 centimeter stent, which could end up in the neck of the pancreas and potentially cause some problems there, perforation being the worst of them. So here the Zeman 5 French pancreatic stent, and this is probably an 11 or 10 centimeter that goes into the tail. It is deployed and it's pushed to the side. Now, what you need to do now is to do a pancreatic cannulation, biliary cannulation beside. And this is going to be achieved relatively easily. Why is a pancreatic cannulation helpful? Well, it does help to straighten out the distortion in the bile duct. And this is often something which is associated with a pancreatic head cancer or an ampullary cancer. So I'm going to speed this on a little bit. And here you can see that with a little bit of trying, we can get ourselves into the bile duct. And you can see that the cause is atypical. Again, it's because of tumor distortion. And now that we are in the bile duct, we can opacify. And then we can place a stent. Okay, opacification of the bile duct showing a distal CBD stricture and upstream dilation of the bile duct. Okay, now on to the third video. 62-year-old male, painless jaundice, again with an ampullary mass and a dilated CBD upstream. So what are we seeing here? There is the ampullary mass, not as big as in the previous case. And here the cannulation is being attempted. Again, the operator is trying to line up the cannula and the guide wire with the duct, but not doing very well, simply because there is a fair bit of distortion from the ampullary tumor. So that's not going to work out. What are we doing here? So now the operator is trying to find another opening. It can be a little bit difficult, but typically in an ampullary tumor, the orifice is actually on the oral side. It's not, it's fairly consistent. And here you can see that the cannulation has led with a curved guide wire forming a knuckle and going into the into what first appears to be the pancreatic duct, But again, with a little bit more cannulation, it's very clear now that we are in the bile duct. So what has happened here is that there was a let me just demonstrate that point. Guide wire manipulation, gentle talking, in order to find the direction, little subtle changes on the part of the endoscopist. So this is a team effort between the endoscopist and the assistant on the wire, who makes use of that knuckled wire and finds a route through and pushes in very gently and recognizes that this is actually bile duct and not pancreatic duct. So guide wire skill is extremely important. It's extremely important that we don't bash at the papilla, because when you cause a fall, when you make a false tract, it can impede your progress a lot, and you may have to give up because of that. But if you're gentle with a little bit of interrogation of the guide wire, you will succeed. Okay, in number 4, we are going to show a clip-assisted ERCP. So another 61-year-old patient with pale stool, hyperbilirubinemia, endoscopic ultrasound showing a diverticulum and a stone. Major papilla looks fairly normal. So there is a periampullary diverticulum, and that can complicate cannulation sometimes, or rather make we shouldn't say complicate here, but make biliary cannulation harder here. And you can see that the ampullary orifice is on the edge of a diverticulum. And here we're trying, and the usual technique here is to make use of a long leading wire, but that papilla is floppy, and every time you push against it, it moves, and therefore you're not able to cannulate. So here we are applying a resolution clip from Boston, and we're using it to push down on the periampullary mucosa. And in that way, we are applying a little bit of traction onto the mucosa and pulling the major papilla out. So now the operator is able to cannulate. The papilla has sort of been fixed in a better position and in a position, so it's no longer as floppy. And now we are achieving a pancreatic cannulation. Biliary cannulation was tried but unsuccessful. So in the same way as the 2 cases ago, we have placed a pancreatic ductal stent, and now we are able to achieve biliary cannulation. Now, PD stent is good not only for helping you to achieve biliary cannulation, but it is excellent in preventing post-ERCP pancreatitis. So if you put a pancreatic stent to assist in cannulation, please leave it there for the next 72 hours at least before you remove it, because that will reduce the risk of the patient developing cholangitis. This is a nice case that we prepared which has been accepted for publication in Video GIE, and it's awaiting it's e-publication ahead of the full publication. If you beg your pardon, we have skipped forward. I think we're running out of time, so maybe I will stop here. And just to say that it's been a pleasure to be able to do this talk. And if you want to see this video, please go to Video GIE and search under my name, and it'll be there for you to see. So that was a nice case of difficult cannulation with clip traction used to facilitate biliary cannulation in a patient who had a choledococele. So wishing you a very good evening. I hope you enjoyed this talk and benefited from it. And I will hand you back to Dr. VGM.
Sir, go ahead, sir. Santosh sir, go ahead, sir. Santosh sir, go ahead, sir.
Yes.
Yeah, sir, we can hear you.
Yeah. Yeah. This is a hello. Hello. Hello.
Sir, just a minute, sir.
Oh, okay.
Yes, sir, go ahead, sir.
Hello, friends. Now we have pathologist Dr. Santosh waiting to speak on this patient where we did, the spike cholangioscopy and we demonstrated the pathology there. And we just would like to show you the slides. So can they show the PowerPoint presentation? And then we close after that. So this was, AGM, who was 94 years old, female, who presented with cholangitis and had undergone ERCP and the cholangiogram showed large bile duct stones. The idea of doing this, spike cholangioscopy was to blast these stones, pulverize these stones using holmium laser. But what we found was something different. We found a villous adenoma, the distal end of the common bile duct. And then we did biopsies. And Dr. Santosh, even though he's traveling, he was from pathogenics labs. He was kind enough to, share his thoughts. He has done the histopathology. We would like to show the histopathology slides, and we will request Dr. Santosh to tell us what he saw. Over to Dr. Santosh. Can you
Good
please?
evening, sir. Yes, sir. Can anybody
Can you unmute, sir? Unmute. 1 second, sir. Yeah, yeah.
Sir, is it audible now? Is it audible now?
Yes, very well, sir. Very well. Please go.
Yes, sir. Sir, can anybody show that PowerPoint, please, sir?
Yeah. The PowerPoint, go back to the PowerPoint on the patient. Please go back, go back. Go back. Yeah, this set. Yeah, over to you, Dr. Santosh. Yeah. Can you hear us?
Yes, sir. I am hearing, but I want that PowerPoint, sir. That pictures.
The slides. Yeah.
Yes, yes.
Yeah. Yeah. Please go ahead.
So this is a case. What we have received a smear. That the smear. This is a 20x low power. It shows some papillary villus pattern of cells, but due to very thickening of the tissue, it's not that much good quality of the photographs. The overview of the low malignant is showing some villus papillary pattern, and yes. Next slide, please. Coming to the high power 40x, so we can see some cohesive clusters of bland looking cells. Usually benign cells are usually cohesive clusters. When compared to malignant cells always discrete and appearing separate cells. But whenever they are appearing in clusters, means it more towards benign. Next slide, please. And this is also in another section. So these cells showing some polarity of the cells. So it doesn't loss of polarity, and usually the nuclear cytoplasmic ratio is well maintained, and there is no hyperchromasia or any vesicular nucleus is seen. So it's all towards basically it's a benign lesion only. Next slide, please. This you can easily identify that there is a papillary arrangement of the columnar cells. But when you see the cells, individual cells, there is no increased atypia or increased NC ratio or any atypical mitosis or any hyperchromatic pleomorphic nuclei. So it's all looking like somewhat benign looking appearing cells only. So next slide, please. So this is little bit more high power view 60x. So we are seeing some bland looking cells and there are no atypical cells and there is no mitosis and all. And I examined the entire slide. The mitosis rate is very low. That means less than 1 by 50 per 10 high power field. So comes to the conclusion. So what we are actually thinking, it's a benign villus papillary neoplasm, and it's definitely negative for malignant cells. Probably a benign villus adenoma. It's a smear study, but definitely we need a histopathological biopsy for confirming the diagnosis. That's all,
I
sir.
thank you so much, sir.
Thank you, sir. Thank you, sir.
All the info, and we had
Yes.
used spy bite forceps using a spy cholangioscope. And these are
Okay.
all tiny bits that have been obtained through
Okay.
the like a cholangioscope which went through the ERCP scope. There, the channel is very small, so the biopsy forceps is very small. We cannot
Yes.
get bigger than
Yes.
this. So
Yeah,
very
I can
great.
understand.
In spite of being on travel, you were kind enough to pass your
No,
comments. And
no,
thank you so much. Thanks, Dr. Santosh, and
thank
thanks
you,
all
sir. Thank
of us. And we had a fantastic journey from morning 8 to evening. Now it's almost 8. So we've been continuously telecasting, cases from here. And at some points of time, we had crossed viewership of 2,000 people watching. And even
Okay.
now, just half an hour till half an hour back, we had about 1,800 people watching. I'm sure more people will get benefited by watching the whole video, all the videos which are on YouTube channel. So maybe tomorrow they can also have a look at leisure. And people who want to, Indian doctors who want to get credit hours can apply to us. And we will provide them 4 credit points from Tamil Nadu Medical Council. With that, we're just closing, ending for the day. Thank you so much to all the participants across the globe, from United States, from Singapore, from Sri Lanka, from Southeast Asia, from Middle East and Africa. Salutations to all of you. Thank you so much. I hope you all learned a lot. I learned a lot personally. And have fun. All the best. Thank you so much. We'll again join in yet another live session very soon. Thank you. Bye-bye.
Thank you, sir.
and my heart belongs to you.
Dr. V.G. Mohan Prasad, Chairman of VGM Foundation, for this initiative.
Sweet memories keep haunting me, and deep in my soul, I know you